compassion, and healing. Because every patient deserves to be safe and cared for. Happy World Patient Safety Day. In a world where health is our most precious asset, ensuring patient safety is our top priority. On this World Patient Safety Day, we come together to celebrate the dedication of medical professionals. Medical personnel play a crucial role in ensuring the safety of every patient. They listen, they diagnose, they care, they comfort, they support, they heal. But patient safety isn't just about medical professionals. It's a partnership. Patients also have a vital role to play in their own well-being. Effective communication is the foundation of patient safety. Collaboration among healthcare teams ensures the best care possible. Diversity and inclusion foster innovation and better patient outcomes. Today, let's reaffirm our commitment to patient safety. Together, we can make every day a day of safety, compassion, and healing, because every patient deserves to be safe and cared for. Happy World Patient Safety Day. world where health is our most precious asset, ensuring patient safety is our top priority. On this World Patient Safety Day, we come together to celebrate the dedication of medical professionals. Medical personnel play a crucial role in ensuring the safety of every patient. They listen, they diagnose, they care, they comfort, they support, they heal. But patient safety isn't just about medical professionals. It's a partnership. Patients also have a vital role to play in their own well-being. Effective communication is the foundation of patient safety. Collaboration among healthcare teams ensures the best care possible. Diversity and inclusion foster innovation and better patient outcomes. Today, let's reaffirm our commitment to patient safety. Together, we can make every day a day of safety, compassion, and healing, because every patient deserves to be safe and cared for. Happy World Patient Safety Day! In a world where health is our most precious asset, ensuring patient safety is our top priority. On this World Patient Safety Day, we come together to celebrate the dedication of medical professionals. Medical personnel play a crucial role in ensuring the safety of every patient. They listen, they diagnose, they care, they comfort, they support, they heal. But patient safety isn't just about medical professionals. It's a partnership. Patients also have a vital role to play in their own well-being. Effective communication is the foundation of patient safety. Collaboration among healthcare teams ensures the best care possible. Diversity and inclusion foster innovation and better patient outcomes. Today, let's reaffirm our commitment to patient safety. Together, we can make every day a day of safety, compassion, and healing, because every patient deserves to be safe and cared for. Happy World Patient Safety Day! In a world where health is our most precious asset, ensuring patient safety is our top priority. On this World Patient Safety Day, we come together to celebrate the dedication of medical professionals. Medical personnel play a crucial role in ensuring the safety of every patient. They listen, they diagnose, they care, they comfort, they support, they heal. But patient safety isn't just about medical professionals. It's a partnership. Patients also have a vital role to play in their own well-being. Effective communication is the foundation of patient safety. Collaboration among healthcare teams ensures the best care possible. Diversity and inclusion foster innovation and better patient outcomes. Today, let's reaffirm our commitment to patient safety. Together, we can make every day a day of safety, compassion, and healing, because every patient deserves to be safe and cared for. Happy World Patient Safety Day!
Good morning, esteemed delegates, distinguished guests, and participants. Welcome to the 7th Global Ministerial Summit, hosted by the Department of Health in collaboration with the Asian Development Bank and co-sponsored by the World Health Organization. We are thrilled to have you join us today. For the full summit experience, we kindly request all attendees to download the official mobile application for the summit. For assistance, you can visit the events air desk located just outside the auditorium. Thank you. And now we invite all our guests to kindly enter the main hall. Again, we invite all our guests to kindly enter the main hall. Thank you very much. Good morning. Kindly settle down as we will begin the program in a few minutes. Again, requesting everybody to kindly settle down. We will begin the program in a few minutes. Thank you. Good morning, esteemed delegates, distinguished guests, and participants. Welcome to the 7th Global Ministerial Summit hosted by the Department of Health in collaboration with the Asian Development Bank and co-sponsored by the World Health Organization. We are very thrilled to have you join us today. I am Diane Kidder. I'll be your host for today's program. And now, ladies and gentlemen, to officially commence the 7th Global Ministerial Summit, it is my distinct honor and privilege to introduce a leader dedicated to advancing global health and fostering collaboration. Please join me in welcoming the Secretary of Health of the Philippines, Dr. Teodoro J. Alposo, for his welcome remarks. Let's give him, please, a big round of applause.
Thank you very much for that kind introduction. Mabuhay, welcome to everyone. To Dr. Saiya Maupiukala, the Regional Director of the World Health Organization, Western Pacific Regional Office. Professor Sir Liam Donaldson, Special Envoy for Patient Safety from the World Health Organization. Excellencies and ministers from 12 countries and territories. Distinguished deputy ministers from 14 countries and territories. Esteemed delegates from 69 member states. Our partners from the Asian Development Bank and the World Health Organization, executive committee members of the Philippines Department of Health, distinguished resource persons, guests, colleagues, a pleasant morning to you all. Before anything else, let me warmly welcome you to the Philippines, a beautiful archipelago of 7,600 islands, renowned for its breathtaking natural wonders, stunning beaches, rich culture, and warm hospitality. May you truly experience Filipino warmth and genuine kindness throughout your stay. On the other hand, it is a great honor to welcome you to the 7th Global Ministerial Summit on Patient Safety, here in Mandaluyong City in Metro Manila, a gathering where we look forward to every year. Last year, in Santiago, Chile, we accepted the honor of hosting this summit with a firm resolve, not only to sustain the dialogue, but also to steer the global movement for patient safety. Today, we carry that momentum forward, bringing together our shared experiences and evidence-based strategies to reinforce the fabric of our healthcare systems. Building from previous ministerial summits, this year's theme, Weaving Strengths for the Future of Patient Safety Throughout the Healthcare Continuum, This resonates deeply with our vision for a healthcare system that prioritizes the well-being of every patient throughout the continuum of care. As a trauma surgeon, patient safety has been a lifelong advocacy as I witness both the fragility of life and the strength of systems that work together for healing. In 2009, I was privileged to contribute to the creation of the WHO Safe Surgical Checklist, an effort to reduce avoidable harm in operating rooms. That checklist, like the banig, a woven mat, in our local tradition, represents a thoughtful weaving together of practices, roles, and responsibilities to safeguard human life. In many Filipino homes, the banig, or the hand-woven mat, holds deep cultural meaning. It is where families gather, rest, and care for another. It reminds us of the strength and beauty that arise from the threads of reed, grass that carefully intertwined. In the very same way, patient safety is not the work of one sector alone. It is a collective endeavor, a tapestry of collaboration among governments, institutions, healthcare workers, and communities. We are reminded that behind every statistic is a person, a mother, a father, a child, whose life and well-being depend on the safety of the care they receive. Patient safety is not just about protocols within hospital walls. It extends far beyond, reaching into our communities. Pharmacies in rural towns, health centers in remote areas, and even in the hands of caregivers at home. When a midwife ensures a safe birth in a remote community, when a pharmacist offers the right guidance, when a health worker teaches a family how to prevent disease, these everyday acts are cornerstones of patient safety. They remind us that safety must be embroidered at every point of care, from the emergency room to the home, from public health campaigns to national health policies. In the Philippines, we are strengthening this tapestry through bold policies, inclusive governance, and system-wide advocacy. A key milestone is the issuance of Administrative Order number 2020-0007, which established the national policy on patient safety in health facilities, settling the groundwork for a culture of safety in our health system. We have institutionalized the National Patient Safety Committee, designated patient safety officers in our health facilities, and broadened access to training programs that equip our healthcare workers with knowledge, skills, and support they need to deliver safer, high-quality care. We continue to strengthen clinical protocols, integrate patient feedback into service improvement, and upgrade data systems to guide evidence-based decision-making. These initiatives reflect our deep commitment under the Universal Healthcare Act and our Department of Health's 8-point action agenda, which centers on providing ligtas, de kalidad at mapagkalingang serbisyo, which means safe, quality, and compassionate care for every Filipino. During this summit, as collaborators and partners, we will be exploring relevant topics across the continuum of care, such as patient safety reporting and learning systems, the role of patient engagement in addressing patient safety gaps and issues, leveraging technology and specifically AI for patient safety, the economics of diagnostic safety, and many more, weaving them into a magnificent tapestry embodied in the one singular document, the Mandaluyong Declaration. Also, the summit discussions will center on 3 tracks. 1, in primary care, enhancing patient safety in primary care and investing in patient safety sustainable healthcare. 2, in hospital care, ensuring patient safety in hospital settings amidst climate and disaster-related disruptions and creating psychologically safe and health workplaces. 3, and lastly, in governance, strengthening governance frameworks and partnerships for patient safety. Let this summit be more than a gathering. It should be a loom where we interlace ideas, share wisdom, and craft durable solutions. As we move forward, may we hold fast to the vision of a healthcare system that, like the banig, is strong, interconnected, and grounded in the well-being of every individual it serves. Before I close, I extend my gratitude to our co-hosts, the Asian Development Bank under the leadership of its new president, Masato Kanda, as well as our esteemed partners at the World Health Organization, led by Director General Dr. Tedros Ghebreyesus, and our WHO Western Pacific Regional Office Regional Director, headed by Dr. Saiya Mau Piukala, for walking alongside us in advancing this cause. Together, let us strengthen the weave of patient safety, thread by thread, policy by policy, life by life, because in the Philippines we say, bawat buhay mahalaga. That translates, every life is precious. Maraming salamat, and once again, mabuhay. Welcome to the Philippines.
Thank you very much, Dr. Herbosa, the Secretary of Health of the Philippines. Marami pong salamat. Now, we are honored to have with us a distinguished leader in global health, whose vision and expertise guide our efforts in the Western Pacific region. Please join me in extending a warm welcome to Dr. Saya Mau Piukala, Regional Director of the World Health Organization Western Pacific Regional Office, to deliver the keynote message.
Honorable Dr. Del Toro Herbosa, Secretary of Health, Department of Health, Philippines. Dr. Eduardo Penson, the Director of Human and Social Development, Office, Asia Development Bank. Honorable Ministers, Excellencies, distinguished representatives of various member states, ladies and gentlemen, magandang umaga, and a very warm good morning to all of you. It is my great honor to deliver this keynote address at this year's Global Ministerial Summit on Patient Safety. And I sincerely thank the Department of Health of the Philippines for its leadership and warm hospitality during this important summit. WHO is privileged to co-sponsor this summit, reaffirming our shared commitment to ensuring safe healthcare for all. As a surgeon, I have witnessed firsthand the challenges and triumphs of healthcare across diverse communities. You know, growing up in the Pacific, I have developed deep appreciation for the resilience of small island nations and the role that communities play in shaping health outcomes. At the heart of healthcare beats a fundamental principle: trust between patients and providers. You know, just like arteries delivering oxygen to vital organs of our body, this trust fuels every exchange, ensuring the systems remain strong, responsive, and aligned. But when fractured, it's like a clogged vessel, straining the flow and putting the entire system at risk. The Hippocratic Oath reminds us, first, do no harm. The question, are we doing enough? Truly enough to honor this foundational promise to the people we serve? How can each of us make a real difference? The answers lie not just in our discussion here in this room today, but in implementing the commitments we make beyond this room. The theme of this year's summit, Weaving Strength for the Future of Patient Safety Throughout the Healthcare Continuum, aligns with our regional vision, weaving health for families, communities, and societies. Like weaving, patient safety requires precision, collaboration, and resilience, demanding collaborative action from government, experts, health workers, patients, and partners. This summit is a rare opportunity to shape the future of patient safety. We must make it count. Despite progress, patient harm remains a major global issue, even in the most advanced health systems. In high-income countries, 1 in every 10 patients experiences harm during hospital care, and much of it is preventable. In low, middle-income countries, 134 million adverse events occur every year, leading to 2.6 million preventable tests. That is 2.6 million lives that could have been saved. 2.6 million families forever changed. These numbers is not just statistics. They represent lives lost, families changed, and eroded trust in healthcare. Behind every statistic is a human story. You know, a mother holding her newborn, a father recovering from injury, a teenager managing chronic condition, a newborn opening their eyes to the world. Every improvement we make restores trust, dignity, and hope. The Global Patient Safety Action Plan 2021-2030 vision is clear. A world in which no one is harmed in healthcare and every patient receives safe and respectful care every time and everywhere. The challenge is no longer about defining what needs to be done, as we have the plans, the roadmaps to guide our action. However, despite a clear way forward in patient safety, significant implementation challenges remain. Globally, only a limited number of countries have adequate financial and human resources for implementing patient safety initiatives, resulting in fragmented efforts, preventing the scaling up of intervention, and hindering the spread of a strong safety culture to the levels of ambulatory and primary care. Blame culture remains deeply entrenched, discouraging health workers from reporting errors, hindering the implementation of incident report systems, and obstructing effort to foster transparency, continuous learning, and ultimately reducing avoidable harm, highlighting the need for systemic changes to embed patient safety in healthcare delivery. It cannot yet be said that psychological safety is being fully practiced. Patient engagement is also still limited. We must ensure that patients, families, and health workers are truly empowered to contribute to safer care. Patient safety has long been shaped primarily within hospital settings. To truly protect patients and strengthen health system, we should integrate safety from at-home care to community-based first contact care and onto hospital treatment. This is where our focus must be. As WHO, we believe that this summit is not just a moment of reflection, but a call to urgent action. It provides a platform to decision makers, experts, healthcare workers, patients, and partners to engage in shaping the future of patient safety, ensuring discussion extend beyond hospital to governance and primary care. Patient safety is about preventing harm. It is about protecting people in their most vulnerable moments. It is about ensuring a mother does not lose life when bringing life. A child undergoing treatment receives the best care possible, and healthcare workers have the support they need to provide safe, high-quality care. In conclusion, patient safety must be the standard throughout the patient's journey in the continuum of care. We owe this to our patients. We owe this to ourselves as healthcare professionals. And we owe this to the oath we all took, and we all accountable to. And I want to leave you with this quote of Mahatma Gandhi. The best way to find yourself is to lose yourself in the service of others. Let's come together with true recommitment and collective action to uphold the very foundation of patient care. First, to no harm. Wishing you all a successful meeting in the next 2 days. Salamat po, and I thank you.
And yes, as we say in the Philippines, Dr. Piocala, maraming salamat po. Well, let's give another round of applause, please, to Dr. Piocala. Marami pong salamat. Thank you. In a bit, we'll have a photo opportunity with Dr. Piocala and the Secretary of Health of the Philippines, and with our ministers and also deputy ministers. But for the meantime, allow me to just seal the salient points from that very wonderful and beautiful keynote message of Dr. Piocala. Indeed, patient safety requires collaboration. As mentioned, the summit is an opportunity to foster that collaboration. And as mentioned, we must make it count. And as mentioned, challenges remain, and the summit is indeed not only a moment of reflection, but also a call for urgent action. And the summit is a platform for all the stakeholders to engage and indeed collaborate. And at this moment, I would like to ask again back on stage Dr. Piocala, please, together with the Secretary of Health, Secretary Herbosa, and also the ADB Director to join us here on stage, and the ministers, please, to have a photo opportunity, as the ministers from Eswatini, Federated States of Micronesia, Gambia, Jamaica, the Maldives, Papua New Guinea, Tajikistan, and Tuvalu, please. And this photo opportunity will be followed afterwards by our deputy ministers, and then afterwards will be from the Department of Health, Exicom. First up, we have the photo opportunity with the ministers. For the first photo, please, we'll have first our ministers. And after this, we'll call on stage the deputy ministers. We'll have first photo op, please, with the ministers. Thank you very much. Now, can we call on, please, the deputy ministers to join on stage for another photo opportunity? Thank you. Our deputy ministers from Angola, Cambodia, Fiji, and also, please, we would like to ask Yusek Kenneth Ronquillo, Yusek Paulo Teston, and our deputy ministers from Georgia, Germany, Indonesia. And also, please, on the top here, can we have deputy ministers from Japan, Libya, Mongolia, Panama, Russia, Slovakia, South Sudan, Timor-Leste, and Zimbabwe. After this photo op with the ministers and deputy ministers, they will be joined by DOH Execom. Thank you. And lastly, can we ask the DOH Execom, please, to join on stage for another photo opportunity? Thank you.
check, check.
All right, now, dear guests, participants, and delegates, we now move to a crucial segment of our program today. We move on now to Experts Plenary 1, which will focus on a topic of paramount importance: the implementation of the Global Patient Safety Action Plan 2021 to 2030. And we are very honored to have with us a distinguished panel of experts, and to chair this important discussion, please welcome Sir Liam Donaldson, the World Health Organization's Special Envoy for Patient Safety, United Kingdom. Good morning, sir. And please join me in acknowledging our esteemed panelists. We have Dr. Irina Papieva, Technical Officer for the Patient Safety Flagship of the World Health Organization, Switzerland. Mr. Luis Viñas Torres, Director of the Division of Health Systems and Services, WHO Regional Office for the Western Pacific, Philippines. Dr. Henrietta Hughes, Patient Safety Commissioner for England, UK. Dr. Lydia Okutoy, Director of the Healthcare Quality, Kenyatta National Hospital, Kenya. And Mr. Elios Eliard Lodzeni, Board Chair of the International Alliance of Patients Organization, UK. And indeed, all of us are eager to hear the strategies, challenges, and opportunities in advancing patient safety globally. I give the floor now to Sir Liam Donaldson.
Well, thank you very much, and welcome everybody, and it's a great honor to chair this first panel of discussion. We have a very distinguished group of experts and patient safety leaders, all coming from a slightly different perspective. But our challenge this morning is to explore the implementation of the Global Patient Safety Action Plan. I heard it referred to yesterday as GSAP, which I think is a good thing. In my experience, if something becomes an acronym, then it's already embedded in the system. If it becomes a verb, then it really does sustain. So we have these days, we message people rather than sending them a message. And hopefully in the future, after a long day, someone will say to her colleague, I've just been GSApping all day, I'm so tired. We will know then that the Global Patient Safety Action Plan is fully implemented. A little superficial maybe, a little whimsical, but we're now going to get down into some of the nitty-gritty of implementation. And I'd like to start very briefly by reminding you that the Global Patient Safety Action Plan has 7 core objectives. And I was responsible with Neelam Dhingra for drafting those 7 objectives. And we did it just pre-pandemic. We didn't know, obviously, the pandemic was coming. And I think if it had been a year later, we wouldn't have a Global Patient Safety Action Plan. So it was fortunate that that piece of work came together in a very timely way, or I don't think it would have ever happened. But I'd like to just remind you of the importance of the 7 goals. And they were very carefully framed, and they offer a very holistic view of what it would take to transform the system around the world, the health systems around the world, to be truly patient safety centered. They're holistic. They're timeless. The goals could always be in front of us, and we would never get to the point that we want to reach, which is a good thing. Creative people talk about the importance of being in a state of becoming, so that you never actually arrive and you're always striving to do better. And then finally, a particular quality that isn't talked about very much in the way that the objectives are framed is that they're fractal. They can be disaggregated to any level, to a nurse in a service, a maternity service in sub-Saharan Africa. It means something to be building resilience. To a health minister in a high-income country, resilience means something different to them, but it's part of the whole picture of delivering the action plan. So those three qualities, holistic, timeless, and fractal, are all what I believe makes these goals, the 7 central goals of the Global Patient Safety Action Plan, a transformative plan. So let me start by asking Henrietta Hughes, and Henrietta is a ministerial summit, and your role as Patient Safety Commissioner in the UK is a parliamentary role. You have to deal with politicians on an everyday basis. How much awareness do you think there is at the political level in this initiative and what we're trying to do more generally to improve patient safety, and how much political support?
Well, thank you so much, Salim. And I want to express a massive thanks to the Department of Health in the Philippines for hosting this summit. And what a fabulous summit it is already. And I'm delighted to be GSAPPing with everyone here today. I think it's going to be very energizing and hopefully not too tiring. And responding to your question, what I've found is that there's a real desire for parliamentarians, particularly those who represent their constituents, to be passionate about patient safety, that they recognise the impact on families and on individuals when patients are harmed through healthcare, and they know the devastating impact that has on their lives. So I've seen, and I am the only patient safety commissioner in the world, and if anybody wants to think about appointing somebody that I can have a cup of tea with and a nice conversation as a patient safety commissioner in your own country, I'd be very happy to have a conversation about that. But I do think that being the independent voice of patients and really being able to amplify the individual needs and the themes that we see into Parliament has been really impactful. The other thing that I was going to say is that it allows us to keep the spotlight on particular areas where patients have suffered harm, but they aren't receiving, for example, the support or help that they need. And that's been a very positive way of being able to keep the patients' needs up in the spotlight, but also to interact with the politicians, not only the ministers, but parliamentarians in both houses. So I've found that as a new role, being able to have those conversations, it's actually growing in terms of the insight, the knowledge, but also the passion that's there in our politicians for keeping patients safe.
Yeah. And one of the conundrums always for people at a political level has always been that to admit to the scale of problems that are happening is awkward, embarrassing politically. Do you find that the politicians and parliamentarians that you deal with are willing to acknowledge the scale of harm that is prevalent, or is it something that they would prefer the public not to really know about?
I think there's a real drive for transparency, because there's a recognition that when we know the areas that need to be fixed, we can actually then start looking for solutions for them. I think in the past there's been, quite a paternalistic approach, not only from healthcare systems, but perhaps from countries, governments, etc., to sort of so that patients aren't part of the conversation. But I think the reality that we're in nowadays is that patients find each other through social media, through interviews, etc., and then that amplifies the patient voice. They then, if they're not getting the the response that they would like to see from either their healthcare providers, the clinicians, etc., is that they then amplify their voices up through their members of parliament or to the press. So in the best circumstances, we need to be identifying harm very quickly, and that is often through patient anecdote, but also then acting on it swiftly so that we prevent further harm from occurring. I think that the dial is really shifting away from patients being passive participants of healthcare. They want to be seen as active, they want to be seen as partners in their care, and also part of the solution as well. And I really welcome that. We heard earlier about psychological safety for staff, and I think there's a moral injury that can happen for healthcare workers when they are witnessing harm and they don't feel able to raise it. But there's also that opportunity for people to flag things and see themselves as part of the solution. And I think that improves the morale of the workforce, it improves the outcomes for patients, and working in partnership has got to be the way forward.
Thank you, Henrietta. I'd like to turn now to Luis Torres, who is the Director and Division of Health Systems and Services in the Western Pacific region. Just to maybe ask you to talk about how you approach the embedding patient safety in the diversity of health systems that you oversee. But let me just frame the question by taking the first of the 7 strategic objectives, goals of the Global Patient Safety Action Plan. When we were drafting them, the most difficult one was the first, because 50% of people wanted to set a target. They argued that there's so many global health priorities that unless you have an ambitious target like zero harm, then nobody will commit to it. There are many other priorities to be dealt with. The other 50% said, if you set a ridiculous target, like zero harm, which nobody believes could ever be achieved, then you lose credibility. So we came up, I think, with quite an intriguing solution. We framed the first objective, and I'll read it: make zero avoidable harm to patients a state of mind and a rule of engagement in the planning and delivery of healthcare everywhere. So the state of mind, we're not setting a target, but yet we want everybody to be working on it as passionately as they can every day by having that state of mind. So how far are we, Luis, do you think, in creating that state of mind throughout our health systems?
Thank you, Liam, and again, thank you for the opportunity to share a bit from the ground, also like Henrietta. Let me start. I will make 3 points. Let me start a bit for looking to the demand side and how the demand from countries have changed in relation to patient safety and the overall quality agenda. I think the Western Pacific region has done a significant good job and progressing towards addressing, let's say, the MDG challenge and coverages. But then the better you do on coverages, then you start asking more difficult questions in the quality domain, but also on the patient safety. So we have observed a shift towards requests coming from our member states bringing, okay, help us into improving the patient safety agenda. So I can say that I would say in the last 10 years we have observed this shift in the spirit of the first strategy. The second point is, okay, what kind of requests or how this mindset shift translates into action? And there is, I would say, I will present it in 2 different ways. One would be upstream, saying more and more often we are formalizing the work on patient safety through national plans. So, and if you see our indicators compared with other parts of the world, more and more countries and a higher percentage than the global average have these documents, which the document is not the point. The point is they have gone through strategic thinking on putting the pieces together to react. The last is the downstream part, no? And there is plenty of, I like the quote from Secretary Ted, no? He contributed to set up this checklist, surgical checklist, and there is more and more these demands of tools and processes and one of the role of WHO is to be also the platform for cross-country sharing and member states sharing their knowledge. And the combination of these requests and this function that we have of sharing, I think that there is let's say, a regional response on improving the patient safety overall. One last point I would like to make. It's very important also to understand what are the policy levers that ministries have to push this agenda. And to understand and to answer these questions, we also need to look at what is the reality of the ecosystems that they work, what is the system that they work. And we observe many of our systems are still very fragmented, and proxy indicators of this fragmentation is the size of the out-of-pocket spending as a way to spend, but also the private sector size. And many times our member states' health authorities do not have these policy levers that they would like to pursue the agenda.
And do you think that the simple task for ministers of talking about patient safety and is important? I mean, I notice that when a minister draws attention to it, it has a very, very powerful effect. Do you think we should be encouraging them to make more statements, more speeches?
Absolutely, but I think there is a fertile environment to do that. As I said, we have moved a bit the needle on coverages, so we are more and more into doing a good job, quality-wise, patient safety-wise. So they will be receptive. I'm really, really optimistic that we will have this traction. Over.
Okay, well, thank you for now. And I'd like to turn now to Ella Salad-Ladzeni, who is the board chair of the International Alliance for Patients Organization. IAPO is another acronym, which means it's deeply embedded in the system, and it'll become a verb one day, I'm sure, as well. But let me just ask you, Objective 4 in the Global Patient Safety Action Plan, as you know, is phrased as engage and empower patients and families to help and support the journey to safer healthcare. And when we started the World Alliance for Patient Safety in 2005, Minister Hebosa talked about it, and he was a very powerful figure in the early days. One of the first programs we set up was the Patients for Patient Safety program, and that still exists today. But how does IAPO get engaged with this challenge of improving patient safety?
Thank you very much. First of all, let me thank the government of the Philippines for extending this warm welcome to us. Also, let me thank the WHO for actively engaging and involving IAPO into this process. As patients, we feel that our voice has been well taken care of in this process. The only challenge which we are seeing now is that depending on the regions where we are coming from, especially in the low-income countries, the patients are not taken very seriously. What do I mean when I say this? As patients, we are supposed to be given a seat in the various governance structures so that our concerns, our voices are integrated into it. But what is happening in most cases is that we are left out. But when you go into the high-income, middle-income countries, you find that patients are taken seriously. They are engaged, they are involved in most of the interventions that are taking place in as far as patient safety is concerned. So our cry is that why don't we move together, irrespective of the region peculiarities, the low income, the middle income, all of them must seriously integrate the patient perspective by giving a seat to patients either through their representatives or the patients in their individual capacities. Thank you.
Thank you very much. I should say, when we finished our first round of discussion, we very much encourage you in the audience to join in, and there are some microphone stands there, so if you I hope you'll feel able to comment or ask questions to the panel, so please take note. If you do want to do that, walk to one of the microphones and stand behind it, and we'll call on you to speak when a moment arises to do that in the discussion. So if I could turn now to Lydia Okatoi, who is the Director of Healthcare Quality in Kenya for the Kenyatta National Hospital. And I want to just ask her two things, really. One is about the challenges of implementing the Global Patient Safety Action Plan in a low-income setting. And secondly, a little bit about, more generally, about resilience. And I'd like to start with that. I mentioned that the Global Patient Safety Action Plan was born just before the COVID crisis, and I'm sure many of you will have opinions about how patient safety related to the events in the COVID crisis. The WHO produced an excellent report on that, and it seems to me that it was a mixed performance by the patient safety element of healthcare systems. The first obvious thing was that given that this was a virus of pandemic potential from the word go, we have to say that we probably didn't do it enough of a good job on healthcare infection and control over the years before the pandemic. We had the warnings with the first SARS and with Ebola, but yet those systems were not strong enough to stop, in some places, the amplification effect of the virus going into a setting that didn't have good control procedures for healthcare infection. And I think the other very striking thing from the patient and family point of view was that it was difficult to accept in retrospect, to feel that we'd done a good, we'd properly understood what it was like for families to be separated from their elderly loved ones, and whether it was necessary to be so restrictive, and indeed to remove the carer role in some cases from the elderly person who was stricken by the pandemic. So I think there was a lot of learning, and possibly the degree of resilience built in health systems to withstand the pandemic was a good indicator of the degree of resilience that we need to keep our patients safe on in non-pandemic signs. So, Lydia, you're in the Ministry of Health. Is resilience in your work on patient safety something that you think about, talk about?
Yeah, thank you very much. Can I be heard? Great. Great to be here. My name is Lydia, as mentioned, and we're glad to represent the low and middle-income countries and give some perspective in regard to the Global Patient Safety Action Plan, and especially what the pandemic meant to us. So fast forward is before the pandemic, IPC was a major aspect of concentration in many governments in Africa. And in Kenya, we had already a direction. There was a policy on infection prevention and control, and the other preparedness. had been rolled in place, guidance by the WHO and others. So when it happened, it brought challenges that were a little different in terms of especially aspect of equity and patient-centeredness, as much as the whole system was strained, just like the whole globe. So at facility levels, we required to standardize the care processes and the patient care pathways, and also we required to have the management side of COVID being made correct. And so in terms of resilience, the fact that there was already an infection and prevention control committee and already a high-level team with regard to pandemics and COVID, it enabled bringing together of resources and mapping out both the healthcare workers and the patient support that was needed. Also to mention that as this was happening at hospital level, the national government was giving direction, because our hospital was one of the centers of interest in terms of both giving national direction through webinars. It was difficult to reach all healthcare workers just at a glance, but through the webinars that used to happen almost every other second day, we were able to pass information before the ECHO platform became as active. So I can say one of the ways of getting resilience on matters pandemic preparedness and such is how do you reach these healthcare workers, both for information and the other needed resources those that are required. So Kenya has an IPC training program, some program that has been adapted from the WHO IPC trainings, and we have in the audience the head of that unit from Kenya, Mr. Irungu. If you're somewhere, you can wave. I'm mentioning about his work. Yeah, he's there, kindly stand. And so Mr. Irungu heads that program, IPC, Health Worker Safety and Patient Safety. So we got a sweet spot in elevating the voice of patient safety when the COVID pandemic came in. There was an opportunity to do a policy. The policy was targeted on health worker safety. But as a country, we needed to move the whole throttle of patient safety, health worker safety, and quality of care. And so we got an opportunity to have a national policy and an action plan and a strategy, which in itself brings resilience because it guides the county governments, guides institutions on what to do. So whereas COVID happened, but we rode on it and we were able to give guidance in these multiple parts. So most of the time when you think about patient safety in Africa, it's been about IPC only, and for a long time, we thought we needed to talk to the other, like the international patient safety goals and other patient safety issues, the medical error reporting. And so we welcome the Global Patient Safety Action Plan because it gave guidance and helped us know where we are. So as a country, we have celebrated the World Patient Safety Days consistently as an opportunity to have conversations and targeted conversations for that. And so I think the low and middle income countries are ready for this conversation of IPC plus the rest. We are ready to go towards the trainings. We are ready for health worker safety capacity building. We are ready to have indicators that track patient safety incidents, that track the other performance measures around culture. And so we feel that it is good guidance that is applicable to us and does not assume that our interests are only in IPC. Thank you.
Thank you. And just to remind you of that resilience objective, which is Objective 2, build high reliability health systems and health organizations to protect patients daily from harm. And that, I mean, we very much embraced a lot of the human factors thinking in framing that objective. And I think most people would acknowledge that the human factors expertise, which often comes from outside healthcare, is very, very valuable in building resilience and making safer systems, but it's in very scarce supply. And I just wonder if Luis or Henrietta would like to say anything about their encounters with the health human factors dimension, and whether you think more could be done to bring them into day-to-day work in our health facilities.
Well, thank you very much. And I see this as very much a total approach to patient safety management. So this is about having a full alignment of the healthcare system all the way through from the government, the ministers, but the healthcare regulators, the providers, the supply chain, and every part of the healthcare system that goes really beyond what happens inside a healthcare facility. And what we've seen is that when you build human factors in to the whole design and delivery of healthcare, that's what makes the difference. But what we need to have is a totally systematic approach to that, as we might see in other sectors. And where we can bring human factors not only into, for example, the licensing of medicines and medical devices, which is an area that I work in, but also in terms of the way that patient pathways are designed, the way that devices are procured by organizations, and particularly in terms of learning from when things have gone wrong. I think the key to this is we're seeing pockets of really good practice across England at the moment, but it's that total approach, a safety management approach, that works at all different levels. And that's where I see that we can really start building examples of really good practice. Going back to your earlier point, what can ministers talk about in a really positive way around patient safety? I think we need to change the dynamic that patient safety suggests there's something terrible that has happened, into one which is much more proactive, where we can say, these are the things that we're putting into place to keep people safe.
Yeah, I mean, I think this is a very good point, because most of the human factors experts I talk to that come into health from other fields, the very first thing they say is, where is your safety management system? They don't understand that in other industries, why healthcare isn't replicating the experience of other industries. So I think that's, if you wanted to look at one development which is very likely to happen over the next few years, it is the establishment of formal safety management systems at facility level. Louise?
Just to add, from the broader health workforce management perspective, in low and middle income countries, one thing that we have observed is that is who is in charge. It's a bit the stewardship function, meaning there is the glue of the system is less robust than in high-income countries. So to create a culture for patient safety or to implement checklists of patient safety measures, or to the chain, the policy implementation chain is not as clear and solid as in high-income countries. That poses a lot of challenges when you exactly want to embed this shift in mindset, but also to use other policy levels, let's say payment mechanisms to increase uptake on measures for patient safety. If the system is fragmented, you don't have this in your toolbox.
Thank you. I'm going to turn next to Irina Papieva, who leads for patient safety in Geneva for the World Health Organization. But as I said after the first round, we'd love to hear from you, so please go up to the microphones in preparation for your questions and comments, because we'd love to hear from you. Irina, Many people look at the World Health Organization headquarters and wonder how so many priorities can be introduced and evaluated. And really, I think even I, who've been around for quite a while in WHO circles, have difficulty in understanding what good looks like in implementation. So many global health programs. Some of them are easy to evaluate because they're a single metric, like one of my other roles is I'm monitoring the evaluation of the polio program. There's one single metric there. So easy to see whether progress is being made and when performance is falling off. But with something as complex as implementing a plan like this, which is very wide-ranging, as we know, and has to do with very fundamental things like changing the culture of healthcare. How do you start to evaluate it? And when you see implementation figures like 10, 15%, should you be disappointed, or should you be encouraged that things are happening?
Yeah, thank you. Thank you very much, Sir Liam. Quite challenging question, I would say. Indeed, following the adoption of the Global Patient Safety Action Plan back in 2021, we have been approached by many countries and partners with very straightforward questions. So what do we do now? How do we prioritize? Which strategic objective is more important than the others? Where we should put our efforts? And perhaps the level of disappointment when WHO doesn't have a formula that will suit everybody will not be surprising to us. We do understand that countries are at very different levels in their efforts to improve patient safety and strengthen their health systems. But what is important is really to put emphasis on contextualization and alignment, because whatever interventions our countries are doing, they should be deeply rooted in the local reality, aligned with policy frameworks, aligned with local priorities, with governance structures, with local expertise and organizational capacities. This is the only way to design interventions that will meet the population needs. Secondly, I want to come back to the 7x5 framework that you have mentioned, Sir Liam. Really, it's quite comprehensive. It has a number of strategies and actions designed for different stakeholder groups. But what we wanted really to achieve by introducing the framework is to make sure that countries see a bigger picture and think systems. Because although patient safety may seem a very easy, straightforward goal requiring very simple solutions, approaches to improve patient safety should be comprehensive enough. They should be strategic and coordinated. Again, that's the key to achieve long-term outcomes and sustainable improvements. Coming back to the point that Luis mentioned, it's extremely important to balance upstream and downstream interventions as well, because it's important for us to address the issue of preventable harm in healthcare at the front line, but it is equally important to build resilient systems. So upstream and downstream interventions are equally important, and they have to be integrated to achieve better results. Because just imagine, it's wonderful to have the national policy on patient safety, either stand-alone or integrated within the broader policies, but if we don't ensure running water in healthcare facilities in remote areas, what do we do with the policy? We will not see the real change and improved health outcomes. And finally, again, going back to the strategic objective number 1, Sir Liam, that you mentioned, I think The way we formulated that is really brilliant, and I have to thank you and also Dr. Neelam, who jointly led the development of the Global Patient Safety Action Plan, because this is exactly what we were expecting from member states, really to make sure that it is a state of mind and the rule of engagement in the planning and delivery of the healthcare systems. Patient safety should become a core value that influences all the decisions and actions we make. We can't go another way. Patient safety should be embedded in the design of our health systems. It should become a second nature, I would say, like we're wearing seat belts in the car. It's automatic. It's essential and it is non-negotiable. So we really want to see countries appreciating that patient safety should be something exactly like that.
Thank you, Irina. We had some interesting discussions in the World Alliance days, and we dragged in a lot of people from outside, Jim Reason, the Swiss cheese expert, many people. I remember on one occasion we had a meeting with Malcolm Gladwell, who wrote The Tipping Point. You may remember that book, and he obviously written other books. He gave a very, very interesting answer when I said to him, how do you get patient safety embedded into a health system? He didn't know anything about patient safety. And he said, it's the difference between brushing your teeth and flossing your teeth. Brushing your teeth is a habit. You don't have to really tell many people to do that. They do it instinctively, but the members that actually floss their teeth, it's not a habit. It's an acquired beneficial behavior, and so your gap is between, in patient safety, is between the toothbrushing and the flossing. You may think that's a bit of a left field, but I thought he's the guy that writes books like that. Remember, he also, apart from The Tipping Point, he talked about this concept of stickiness, an idea that really resonates with people and they remember it. And I think some of the 5 moments in the hand hygiene was a very good example of a sticky thing that just penetrates and works. I'm very pleased to see we've got people at the microphones. Abdullah, you go first, from Saudi Arabia. Have a go, speak and see, they'll probably turn it up when they hear you.
Thank you very much.
Yes.
So now that we're talking about the Global Patient Safety Action Plan, or as you said, GSAP implementation, how can we have a global benchmark? Because as of now, I don't think we have a kind of a universal way with an independent body looking at the implementation. So out of the 194 countries, which country is number 1, which country is number 10, creating that sense of, competition is going to be probably advantageous to the global patient safety efforts. So maybe the WHO can play a more active role in that. Any one of the panelists or you, Serlene.
Yeah. Okay, thank you. Well, one of the good things about a global action plan is there's a requirement to report to the World Health Assembly. So that's quite a discipline. So you like to talk about the evaluation process, Irina?
Yes, thank you very much, Abdullah. Yes, after the adoption of the Global Action Plan, we are supposed to report to the World Health Assembly every 2 years on the implementation progress. And as you know very well, there are a number of core indicators highlighted in the action plan, but we also have 175 criteria that we are using to monitor implementation. In 2022, we issued the first round of the member state survey to collect the data from the countries and see where we are and how we are progressing. The Global Patient Safety Report that we published last year in May is primarily based on the results from the member state survey, although it also contains a lot of interesting readings related to the burden of harm. It features interesting stories from the countries and also different collaborative arrangements with our partners. In January 2025, we have initiated the second round of member state survey, so to see where we are now and what we were able to achieve in the current circumstances. We never defined a target, Abdullah, and I'm going back to the point that I have highlighted, because there is no one formula and there is no one target that can be achieved by all the countries equally. Context-specific targets should be made and should be followed, and we are here just to demonstrate and share the examples from different countries on how they are progressing. There is no formula really to benchmark and to compare. Never WHO will compare the countries. We will share the results, and it will be up to the countries to learn from each other and to continue implementing that.
Henrietta.
Yeah, thank you very much. So I think that's a great question, because it really says something about the will for individual countries to do better and better, and that was very much that mindset that you mentioned, Salim, about being on a continuous journey of improvement. And I looked at our last, the feedback that we gave to WHO in preparation for this panel, and what I thought was really interesting about it was not only the progress that has been made in the UK, but also how we learn from other countries. And I see it very much that this is an opportunity for us to demonstrate not only ways that we've done it, but absolutely in the context. Every context is different. And just as an example, we've learned from other countries in the way that they've responded to patients being able to escalate concerns about deterioration in hospital from the USA, from Australia, and from other nations as well. And by doing that, have been able to bring something in England called Martha's Rule, which is already showing that thousands of patients and families have picked up the phone, and hundreds of patients have had a change in their management or been transferred to ITU as a result, saving lives. Now, that's the global cooperation that we're able to achieve by us all doing our own thing, but learning from each other. So I see very much the responding to the WHO not only sharpens our own look at what we're doing ourselves, but also by reading the report and seeing what other countries are doing, we're able to really work collaboratively globally. And that's one of the big advantages, I would say, of summits like this, where we can really meet others, learn from each other's experience, and then push further and further towards the goal.
Lydia, your hand is moving to the microphone.
Great. I just wanted to chime in because this conversation came up on a group for African patient safety practitioners, and they were asking, so where are we? And I think it is an important question that as much as we have the commitment of the ministers here, the Global Patient Safety Action Plan brings together all the requisite groups that can move this needle. And in some countries, some of the groups are still being onboarded. For example, in our program, we have the patient representatives, we have the academia, we have the researchers, and all this. So they bring in different aspects that can contribute to the Global Patient Safety Action Plan. And so for us, one of the things is it brings awareness of what ought to be done and who needs to be on this table, who need to be talking. And so in our setting, some of these people are not talking sufficiently enough. And so the action plan gives us an opportunity of saying that we're bringing you on board because of supporting research on these aspects, because of this aspect that synergizes maybe with your other professional organization that is in healthcare. And so I think you bring an important question. And for us, I think it's a question that helps us to know what are the other opportunities, partnerships, synergies that should be happening. And so when we are called to the league, to the nations, what can be our story? It will be authentic, it will reflect our background and what already exists, building on it. And so it is a great question, but it also brings new entrants onto that conversation that were otherwise not there. Yeah, thank you.
Thank you. Elos, do you want to add anything at this point?
I think the question gives some work to member countries that much as there are no concrete indicators which are uniform, there must be a spirit of competition so that those that are doing well must act as a reference point for those that are not doing well, because patient safety, it's an issue which affects everyone. Yeah. And in that case, even the patients themselves, they must be part and parcel of it. Thank you.
Yeah, I mean, Abdullah's, another question coming in a moment, but Abdullah's idea of the independent nature of evaluation is actually a very important one, because one of the deficits in global health is accountability. And it's difficult for the UN agencies like WHO because they are a membership organization. So although they talk behind the scenes in a tough way to their member states when they're not delivering, but it's more difficult to do that openly and publicly. And there are at least two major independent panels in global health. I chair one of them, which is the independent panel monitoring polio eradication. I've been doing that for 12 years, so it's a pro bono role. And we produce very, very hard-hitting reports, and the countries feel accountable whether they're delivering or not, and the amount of money they're spending. So it does have an important function. And there's also, for the last 5 years, been an independent panel on pandemics, pointing out the weaknesses in pandemic planning. So it's an interesting idea that it's not just the independence of monitoring, but it brings a level of accountability that's difficult to achieve in-house in global health programs. Anthony Staines from Switzerland.
Thank you, Sir Liam. I wish to check my understanding of what the panel is saying. I heard one reservation about patient engagement in lower income countries. Apart from that, I heard quite a bit of satisfaction about the progress of GSAPing. Am I understanding it right? Because I don't see the burden of harm globally really diminishing. So can someone comment on that discrepancy?
Okay. What about, who should have, it's a difficult question, so I don't want to put anybody on the spot, but I guess it's back to the well-worn cliche of the glass being half full or half empty. Should we be optimistic, or should we be gritting our teeth and getting very angry about the lack of progress? I certainly, at different times of the year, I can be in one or both of those, actually. But Luis, would you like to comment?
Thank you for the difficult question. Well, again, we can argue how optimistic or pessimistic we want to look like, but let me try to add another element, is do we know where we are? Meaning data. You know, in low and middle income countries, as you are referring, and again, we are not in isolation. We have to look at, it's unrealistic to believe that the agenda of patient safety is going to move faster than the rest of the health systems, development. And we have huge issues on comprehensiveness and quality of data for very basic functions. So even, if we could manage to have a complete theory of change of patient safety, big blocks, we will not have the data to tell where we are. So if we look at the metrics that we have in the plan, they're still quite process focused. But this is again a challenge, and I like the question about the ranking. We have 194 member states, and the capacities to measure varies a lot. And when we WHO have to put metrics that can be collected everywhere, that's why the UHC, for example, metrics are quite simplistic. And once you reach 80, countries like Sri Lanka and Denmark, to put two examples, are more or less at the same level, because the metrics that can be measured across the world are, we can say, oversimplistic. So I want still to remain in the optimistics group, but I want to also kind of make a plea to make an effort to improve the data availability and quality.
Well, I mean, Anthony's question was specifically about the low-income countries, and Irina mentioned the importance of context in implementing. So, Lydia, how much should we adjust the way that we evaluate in low-income? So we all know that lack of infrastructure compromises safety, the lack of skilled staff, availability of skilled staff, the lack of equipment, poor access. All of those things are going to make the service unsafe, and they're really the foundation stones of health systems, and they're not there in some countries. So can we do a fair evaluation of a service and how it's performing on patient safety in such circumstances?
Yes, I think it is possible to do that, and the guidance comes from what we have as inputs for healthcare. And if we look at quality of care and patient safety as enablers or as the software that help us get a good outcome. And so these countries have medicines and products. They have health workers. They have all the WHO building blocks to some extent. And so to what extent we convert that into the desirable outcome, it's possible to use the guidance from the Global Patient Safety Action Plan and say, if you're looking at target 6 about incident error reporting, so what data are we looking at, and what is the ability for us to have this online or paper-based, what is happening? And so I think for all the indicators, it is possible to have a conversation and adapt a standard that is contextualized, as Irena mentioned it, even with regard to patient engagement. As low and middle income countries, these are people with connections, with families, with love. In fact, in some cultures, just greeting means peace, means love. So it doesn't mean that all these things that healthcare workers, humanizing care in those healthcare facilities is not foreign to those cultures. So there are even some things that can easily be leapfrogged. And so how does this paternalistic healthcare facility have structures that have patients represented in decision making, in designing improvement, in how care is given? And so it just brings us to what is the ethical thing to do. The right thing to do is to engage the patient, but how will we monitor that we are doing progress? How will we monitor that when events and incidents happen, we are able to come back and connect and have better systems that will represent the patients there? And so I beg to strongly say that since all the aspects of the building blocks, they exist to some extent well, in other extent not as well, it is possible to have a conversation using the healthcare workers and the communities there to determine how does success look like, and when will we say we are doing progress. And so the baseline of good governance and having quality improvement for patient safety and using all those tools and system designs that enable it to be real, will make the team know that there is progress. And so in case it is at national level, they will give the framework. But at hospital level, some hospitals may be in very different situation to where I work at a teaching and referral hospital. But the conversation should be guided. In Kenya, we have the Kenya Quality Model for Health that has a level 2, level 1, up to level 6 guidance. It is all titrated, or is it cascaded to the different capabilities, and up to a community score sheet, whereby some communities can vote to what extent they have confidence in the institution. So we know there are gaps in how much the patient can engage and technically participate in the care, but it is clear that there is guidance on what you as a patient would like when you come to that hospital. And I think the GPS has that in some good way, which is still applicable. Thank you.
Thank you. Minister.
Thank you, Sir Liam, and the opportunity to ask a question. But before that, I'd like to tell a short anecdote, because during our second patient safety challenge, where we looked at the safe surgery checklist and actually parameters to count patient safety in the surgical operating suite, we actually had 3 different country levels: the low income, the middle income, and the high income. And what we did in that study was we placed 2 operating theaters, one where you did the checklist, and the other one where you did what you ever did, your toothbrush or whatever. And in the other side, we did the floss. And the surgeons that were assigned in the Philippines, the surgeons that were assigned in my hospital to the other room that had to do the checklist, were cursing me. The lead author in that particular design, they were cursing me for being, having all this. But eventually, when the results came out, the high-income countries had very little change for the checklist. The low-income had very little change for reasons that have been actually described by our panelists. But the middle-income country, ours, the 2 middle-income countries, the other one was Tanzania, I think, had the highest delta or change in morbidity and mortality. So we don't need to build very strong building blocks. We just need to have an attitude of safety. Now, when I attended the 6th Global Ministerial Summit in Santiago, Chile, the amount of ministers and deputy ministers is about the same as this one. But I attended the COP on climate change, and there were 140 health ministers. So my question to the panel is, how do I achieve this same advocacy for all the health ministers? The health ministers here, I'd like to congratulate the ones that came here. I'm looking at the profile. They're all from the Pacific Islands, the African continent, and some of the first world countries. So I think the people are already understanding. How do I get other ministers like me to actually understand this? Because I have an opportunity, and if you'll give me advice, I will incorporate it in my address as the World Health Assembly President this coming May during the WHA. So please give me some advice.
Okay, it's an excellent final question for the panel. I'll ask each of the panel members to give a very brief recommendation to the Minister. Henrietta, come on, you go first. You're the Parliamentary Commissioner.
So the first thing I would say is that our Secretary of State, for him, patient voice is absolutely central to the development of what is the NHS 10-year plan going forwards. So when I heard him talking about the voice of citizens and the views and the needs of citizens, I thought, great, I can go and sit down and put my feet up. My job is done. But I think what I would say is really important here is about trust. So we heard about trusting in the keynote speech this morning. And trust is something which is slowly built but can easily be lost. I think that when it comes to the role of patients in their own care, in the design and delivery of healthcare, but also in, when something hasn't gone as planned, how we get that transparency, that accountability, those are the areas which really build trust. So for me, it's about that working in partnership with patients, getting the clinical engagement, just as you were describing, when the clinicians can see that their patients get better outcomes when the voices of patients are incorporated, then we see it as a win-win all round. And that's the message which I have with the ministers in England. And I know that when it comes to really listening to patients, that's absolutely number one for them.
Thank you. Luis.
I was trying, if I had in front of me all the ministers of health of the world.
Now, this is one of your ministers, so you can tell him directly.
Yeah, but just multiplying a bit the small group. What I would say is, I will try, Filipinos are are provocative in the right way and saying, and I would say, I would pick one of the metrics that are in the global plan and challenge everyone. Say, come in, when we have the 2 reports, every 2 years we report, no? Get one of them and bring back and tell me the story, how you move the needle and tell me the why. That's what I would do.
Okay, Irina?
Yeah, I would probably build on Henrietta's point. Engagement of patients and their families and representatives is extremely important, and we do accept that. But I would expand this engagement to other partners. I would expand that to engagement with health professionals, with people who are delivering care at the front lines. You have to have them around the table as well, and you have to have around the table all the partners that are working closely with you, because only by leveraging their capacities and joining the forces we will be able to achieve sustainable results. And building on Louis' points, yes, we have a wonderful framework, it's quite comprehensive, but I think focus is very much important, focusing on something, and perhaps in the coming 2 years we will put focus more on downstream interventions without putting aside upstream. We will work, but focusing and advocating and promoting that at the regional level, at the global level, I think will help a lot.
Okay, thank you. Briefly, Lydia?
Yeah, for me, I think I would tell the ministers that patients come to hospital when they're very vulnerable, and healthcare being complex, it requires that we have thought ahead of things going right. And so whatever we can do to amplify patient safety, we should do that. And from a teaching and referral hospital, from a facility point of view, is that having a dedicated team to support patient safety enables the rest of the system to run. It is worthwhile to invest in them, to build their capacity, and to be vulnerable as a hospital for the purpose of learning from harm. When things go wrong, that is when the leaders are expected to step up. And so patient safety can never be overstated. It is the big thing that can easily be ignored. And so we need to design for it, we need to budget for it, and we need to give them chance in the governance structure so that the voice is heard to the highest level in the healthcare institution. Thank you.
Thank you. Ellis?
My message would be to see patients and healthcare professionals within the healthcare system in a tube and tire context, that both of them do exist and they can't exist without the other. And then the other should be to focus more investments in public education programs so that we improve the literacy levels of the patients at the grassroots levels. Thank you.
Thank you very much. And my suggestion would be a parallel with my work of the independent panel on polio. We felt certain countries are affected, but all of them are vulnerable. And on that basis, we recommended to the EMRO region that they should set up a subcommittee on polio eradication with ministers as members of this subcommittee, and also to Afro region. And so that would be what I would recommend, is that you start with this very innovative region here, led by Luis, and you set up a regional subcommittee on patient safety and probably quality as well to cover that, because that's your role. So we're within a few minutes of finishing. I've got one important thing to ask your attention for, and it's very time limited to just 5 minutes, and that is the important announcement of ISQA, a very important body in global quality and safety, and they've produced a white paper which covers their approach to implementation of the Global Patient Safety Action Plan. So I'd like to welcome onto the stage Ezekiel Elorio, the president of ISQA, and Dr. Anuradha Pikamani from India, who has been the lead author of the white paper. They're going to tell us about it, but before they come onto the stage, I'd like to thank our excellent panel for their work today in the forum. Thank you.
Good morning. Can we switch on the slides, please? On behalf of ISQA, the International Society for Quality in Healthcare, I would like to thank the Department of Health Philippines, the WHO, and Sir Liam for this opportunity to present the ISQA white paper on patient safety in healthcare organizations. So as you see, it's aptly named as Safe Care is the Right Care. And as we all discuss now, patient safety still remains a critical global challenge. And this white paper will serve as a strategic and actionable guide to help healthcare leaders strengthen policies and practices at organization level. And I would like to thank the expert work group and reviewers of this paper, Dr. Karsten Ingil, CEO ISQA, Dr. Neelam Dingra, JCI, Dr. Irina, from WHO, Dr. Jeff from IHI, Dr. Lauren Mangin from Ireland, and Dr. Shin from Japan, and the reviewers Paul Bowie and Lydia for their invaluable contributions. Aligned with the global priorities, as we discussed, we also GPSAP, and so we have identified various opportunities for improvement and strength to create this white paper, which focuses on these 4 foundational pillars and has been created as a 5x4 matrix: advocacy and leadership, health worker education and safety, patient, family and carer engagement, clinical process improvement. So this will be a structured roadmap for healthcare organizations offering practical and scalable solutions, and it shows ISQA's unwavering commitment to advancing patient safety worldwide. Thank you all. Safe care is the right care. And I request Sir Liam to do the honors.
Well, thanks. Well, can I have volunteers? Well, we were supposed to handle to Sir Liam the report, but he left the room, unfortunately. I'd like to thank again the organizers for letting us ISQA showcase the opportunity of providing this report, this white paper, which is the first product of our patient safety task force that ISQA has created recently, and shows the commitment that our society has for this cause. Thank you very much, and enjoy the next session. Thank you. We have 5 copies printed. Well, thank you so much.
All right, let's give them a big round of applause again, please, for that presentation, and also for the wonderful experts plenary one a while ago. And again, thank you, Sir Liam Donaldson, for chairing that discussion. Now, before we proceed to Experts Plenary 2, we'd like to invite everybody for a health break, 10-minute health break. We have food, beverage outside at the main hall. Enjoy the 10 minutes and socializing and enjoying the food and beverage outside. And we'll invite you back again after 10 minutes to resume for the Experts Plenary 2. So we'll see you after 10 minutes. Thank you very much.
Oh, no, this is it, yeah.
In a world where health is our most precious asset, ensuring patient safety is our top priority. On this World Patient Safety Day, we come together to celebrate the dedication of medical professionals. Medical personnel play a crucial role in ensuring the safety of every patient. They listen, they diagnose, they care, they comfort, they support, they heal. But patient safety isn't just about medical professionals. It's a partnership. Patients also have a vital role to play in their own well-being. Effective communication is the foundation of patient safety. Collaboration among healthcare teams ensures the best care possible. Diversity and inclusion foster innovation and better patient outcomes. Today, let's reaffirm our commitment to patient safety. Together, we can make every day a day of safety, compassion, and healing, because every patient deserves to be safe and cared for. Happy World Patient Safety Day. In a world where health is our most precious asset, ensuring patient safety is our top priority. On this World Patient Safety Day, we come together to celebrate the dedication of medical professionals. Medical personnel play a crucial role in ensuring the safety of every patient. They listen, they diagnose, they care, they comfort, they support, they heal. But patient safety isn't just about medical professionals. It's a partnership. Patients also have a vital role to play in their own well-being. Effective communication is the foundation of patient safety. Collaboration among healthcare teams ensures the best care possible. Diversity and inclusion foster innovation and better patient outcomes. Today, let's reaffirm our commitment to patient safety. Together, we can make every day a day of safety, compassion, and healing. Because every patient deserves to be safe and cared for. Happy World Patient Safety Day. In a world where health is our most precious asset, ensuring patient safety is our top priority. On this World Patient Safety Day, we come together to celebrate the dedication of medical professionals. Medical personnel play a crucial role in ensuring the safety of every patient. They listen, they diagnose, they care, they comfort, they support, they heal. But patient safety isn't just about medical professionals. It's a partnership. patients also have a vital role to play in their own well-being. Effective communication is the foundation of patient safety. Collaboration among healthcare teams ensures the best care possible. Diversity and inclusion foster innovation and better patient outcomes. Today, let's reaffirm our commitment to patient safety. Together, we can make every day a day of safety, compassion, and healing, because every patient deserves to be safe and cared for. Happy World Patient Safety Day.
Good morning again to all our delegates, guests, and participants. May we invite you all to go back inside the main hall as we will resume with our program. Again, we invite all our participants, guests, and delegates to kindly go back inside the main hall as we will continue with our program. Thank you. Good morning again to all our delegates, guests, and participants. May we invite you all to go back inside the main hall as we will continue the program in a few minutes. Again, may we invite everybody to come back inside the main hall as we will continue with our program. Thank you.
Kaya po ako nagpunta ng hospital kasi nag-bleed po ako. Sa resulta ng biopsy, meron daw po akong bukol sa matres. Siyempre po, natatakot po ako na, yun nga po, baka may cancer nga po. Sinabi nga po ng mga specialista sa yung consultant na di naman daw po nakakatakot magpa-chemo. Marami naman daw pong mga senior citizen na gumagaling. Kaya nag-decide na lang ako magpa-work up.
Magkapit-bahay po kami, tita ko po siya. Tuwing ina-admit siya, ako po yung bantay niya lagi. Sinabi po ng anak niya na bukol sa ovary. Pero magagamot naman po. Kaya palakasin namin yung loob ni tita. Parang wala lang, parang nag-staycation lang po kami sa ospital. Parang family din namin yung mga nurse dito. Hindi po sila nagsasawang pumasyal para magtanong kung may kailangan.
Ang role ko po as a nurse is yung siguraduhin yung safety ng patient. At the same time po is yung magawa po yung mga plans ng mga doktor and then ma-carry out po yung mga care na dapat sa kanya. at maibigay yung mga gamot niya. Sobrang importante po na maramdaman niyang safe kasi po yung buhay po kasi niya, binibigay na niya sa pangangalaga namin, sa aming mga nurses, pati sa mga doktor. So malaking bagay po yun na parang may trust po siya sa amin.
Dito sa aming hospital, meron po kaming Patient Safety Committee. Ang aming Patient Safety Committee ay kinocompose ng doctors, nurses, mga admin po. Ina-address po nila yung infection control, medication safety, patient safety, procedure safety, and proper communication po, and teamwork collaboration. Number one, na importante sa infection health control or infection control would be hand hygiene, yung proper hand washing. Minimake sure din natin na bago pumasok yung pasyente, yung safety or yung sterilization ng area. Aside from that, chine-check din natin yung mga procedure safety. Napaka-importante ng makuha natin ang consent ng patient. Kasi magpapakita ito na napaliwanag mo sa pasyente kung ano yung mga kailangan niya at dapat niyang malaman bago mo maisagawa yung isang procedure. Napaka-importante ng patient tagging kasi ito yung mag-identify sa patient. Napaka-importante ng sirens, lalo na sa mga bata, sa mga matatanda, at saka yung mga pasyente natin na hindi talaga yung normal yung level of consciousness nila, yung mga patulog-tulog. Sa safety procedures po ng laboratories or extraction ng blood, importante number one, kailangan malaman mo ba kung tamang pasyente ba yung kukunan mo ng dugo. Kasi hindi ka po pwedeng kumuha ng dugo kung kani-kanino lang pasyente. Sa infection and sanitation protocols po, meron tayong mga sulat sa bawat corner ng ating hospital kung paano po gagawin ito. Aside from that, yung patient communication. Kasi napaka-importante, nakakausapin natin yung pasyente.
Araw-araw po sila, inilagaan po nila ako. Araw-araw po sila nagra-rounds. Lalo na po yung mga consultant, mga nurses namin. Tapos po sa Euro, maga pa lang po nagde-dressing na po sila ng sugat.
Sa mga bantay na parehas ko, magtiwala din sila sa mga nurse, sa mga staff. Kasi sila yung parang pamilya mo rin dito. Hindi rin iba yung treatment nila. Kahit bantay ka, yung attention kay tita, inaanuhan din nila sa'yo para hindi ka rin magkasakit.
Wala naman pong fix sa buhay. May gagaling, may hindi. Pero ang may papangako lang po sana at ang pinaka-importanting magagawa namin as nurses is yung ma-ensure ang patient safety habang andito po sila sa aming pangangalaga.
Ako, proud ako, not only for myself, but also sa mga team namin, sa lahat ng mga staff dito sa hospital. As a doctor, I live by, of course, serving the patients first. Because for me, ang importante is improving the lives of the patient and making a difference in the patient's life as well as to the relatives.
Pakiramdam ko dito po sa mga nurses, sa mga staff, okay po, satisfied naman po sa kanila. Kampante naman po sila na safe ako sa hospital na ito. Kaya po, maraming po salamat sa kanila.
Mga kababayan, tulad ni Nanay Imelda na pinangangalagaan ng Department of Health at ng Jose Reyes ang kanilang patient safety, ganyan din po ang gagawin namin sa lahat ng aming mga ospital at healthcare facilities. Pinangungunahan ng Department of Health ang pagtaguyod sa patient safety. Sa mga kamag-anak ng mga pasyenteng nagpapagaling sa mga DOH hospital, huwag po kayong mag-alala, kami po ay nakatutok sa kanilang patient safety.
Sure that we care for the patient. It makes their life different. You also feel good dahil nakatulong ka sa kapwa mo.
Ako po si Imelda Celestino, 65 years old. Kaya po ako nagpunta ng hospital kasi nag-bleed po ako. Sa resulta ng biopsy, meron daw po akong bukol sa matris. Siyempre po, natatakot po ako na yun nga po, baka may cancer nga po. Sinabi nga po ng mga espesyalista sa yung consultant na di naman daw po nakakatakot magpa-chemo. Marami naman daw pong mga senior citizen na gumagaling. Kaya nag-decide na rin ako magpa-work up.
Magkapit-bahay po kami, tita ko po siya. Tuwing ina-admit siya, ako po yung bantay niya lagi. Sinabi po ng anak niya na bukol sa ovary. Pero magagamot naman po. Kaya palakasin namin yung loob ni tita. Parang wala lang, parang nag-staycation lang po kami sa ospital. Parang family din namin yung mga nurse dito. Hindi po sila nagsasawang pumasyal para magtanong kung may kailangan.
Ang role ko po as a nurse is yung siguraduhin yung safety ng patient. At the same time po is yung magawa po yung mga plans ng mga doktor and then ma-carry out po yung mga care na dapat sa kanya at maibigay yung mga gamot niya. Sobrang importante po na maramdaman niyang safe kasi po yung buhay po kasi niya, binibigay na niya sa pangangalaga namin, sa aming mga nurses, pati sa mga doktor. So malaking bagay po yun na parang may trust po siya sa amin.
Dito sa aming hospital, meron po kaming Patient Safety Committee. Ang aming Patient Safety Committee ay kinocompose ng doctors, nurses, mga admin po. Ina-address po nila yung infection control, medication safety, patient safety, procedure safety, and proper communication po, and teamwork collaboration. Number one na importante sa infection health control or infection control would be hand hygiene, yung proper hand washing. Minimake sure din natin na bago pumasok yung pasyente, yung safety or yung sterilization ng area. Aside from that, sine-check din natin yung mga procedure safety. Napaka-importante ng makuha natin ang consent ng patient. Kasi magpapakita ito na napaliwanag mo sa pasyente kung ano yung mga kailangan niya at dapat niyang malaman bago mo maisagawa yung isang procedure. Napaka-importante ng patient tagging kasi ito yung mag-identify sa patient. Napaka-importante ng sirens, lalo na sa mga bata, sa mga matatanda, at saka yung mga pasyente natin na hindi talaga yung normal yung level of consciousness sila, yung mga patulog-tulog. Sa safety procedures po ng laboratories or extraction ng blood, importante number one, kailangan malaman mo ba kung tamang pasyente ba yung kukunan mo ng dugo. Kasi hindi ka po pwedeng kumuha ng dugo kung kani-kanino lang pasyente. Sa infection and sanitation protocols po, meron tayong mga sulat sa bawat corner ng ating hospital kung paano po gagawin ito. Aside from that, yung patient communication. Kasi napaka-importante, nakakausapin natin yung pasyente.
Araw-araw po sila, inilagaan po nila ako. Araw-araw po sila nagra-rounds. Lalo na po yung mga consultant, mga nurses namin. Tapos po sa Euro, maga pa lang po nagde-dressing na po sila ng sugat.
Sa mga bantay na parehas ko, magtiwala din sila sa mga nurse, sa mga staff. Kasi sila yung parang pamilya mo rin dito. Hindi rin iba yung treatment nila. Kahit bantay ka, yung attention kay tita, inaanuan din nila sa'yo para hindi ka rin magkasakit.
Wala naman pong fix sa buhay. May gagaling, may hindi. Pero ang may papangako lang po sana at ang pinaka-importanting magagawa namin as nurses is yung ma-ensure ang patient safety habang andito po sila sa aming pangangalaga.
Ako, proud ako, not only for myself, but also sa mga team namin, sa lahat ng mga staff dito sa hospital. As a doctor, I live by, of course, serving the patients first. Because for me, ang importante is improving the lives of the patient and making a difference in the patient's life as well as to the relatives.
Pakiramdam ko dito po sa mga nurses, sa mga staff, okay po, satisfied naman po sa kanila. Ang pante naman po sila na safe ako sa hospital na ito. Kaya po, marami po salamat sa kanila.
Mga kababayan, tulad ni Nanay Imelda na pinangangalagaan ng Department of Health at ng Jose Reyes ang kanilang patient safety, ganyan din po ang gagawin namin sa lahat ng aming mga ospital at healthcare facilities. Pinangungunahan ng Department of Health ang pagtaguyod sa patient safety. Sa mga kamag-anak ng mga pasyenteng nagpapagaling sa mga DOH hospital. Huwag po kayong mag-alala, kami po ay nakatutok sa kanilang patient safety.
Good morning again to all. Now we move on to the Experts Plenary 2, Advancing Patient Safety Reporting and Learning Systems for a Sustainable Culture of Safety Across All Levels of Care.
And to guide this important discussion, we are honored to have Dr. Abdullela Al-Hawasawi, the chair of the organizing committee of the 4th Global Ministerial Summit in Jeddah, Saudi Arabia last 2019, and advisor to the Saudi Patient Safety Center. And now please join me in welcoming our distinguished panelists. Dr. Nilam Dingra, Vice President and Global Chief Patient Safety Officer of Joint Commission International and former head of the WHO Patient Safety Flagship Switzerland. Ms. Ronelle Steinhobel, Deputy Director, Quality Assurance and Improvement, National Department of Health South Africa Directorate, Quality Assurance. Dr. Rosie Benningworth, Chief Executive Officer, Health Services Safety Investigations Body. Professor Kenneth Mack, Director General of Health, Ministry of Health, Singapore. And Dr. Eduardo P. Banzon, Director, Human and Social Development Office, Asian Development Bank. We look forward to exploring how we can strengthen our systems to learn from incidents and improve patient outcomes. Now I give the floor to Dr. Al-Hawasawi for this Experts Plenary 2. Please, let's give them a big round of applause.
Thank you so much. It is my great honor and pleasure to be here with you today. Let me just make sure that I have my slides on. So they say that 90% of success is showing up. So I think everyone here should feel very proud that he or she succeeded. And you know, as someone who participated in all these summit series from 2016 all the way to this year, you know, I feel very humbled and very appreciative of the Philippines' role to, you know, take this global efforts moving forward. So this panel is going to discuss a very important and foundational aspect of patient safety, which is the reporting and learning. Any advanced, high reliability industry is doing extremely well in this field, and you know, we want to see what we can learn from them and what we're doing internally. So before we go and start the panel questions, I just wanted to give you a perspective, you know, framework of how this would resonate with each and every one of you. And since we're in the Philippines, I was just asking, you know, my Filipino colleagues, how many hospitals are there in the Philippines? And I was told 1,300. So, and it's not just the hospitals, it's the healthcare facilities. So think about this framework going from the microsystem through the mesosystem to the macro, all the way up to the global, and we are here in the Global Summit. So I think if we want to take the Philippines as an example, think about where the reporting starts, which is at the bedside, and that's the microsystem. So we have, I'm sure, many clinicians here in the audience, physicians, nurses, and allied health. So these are the individuals that start these reports, and the impact of such reports are on that specific unit. But if you want to then take that level of reporting at a higher level, and that to the mesosystem, so think about the healthcare facility being a primary healthcare center, being a hospital, or being you know, any other ambulatory care center. And this is where you end up having the leadership and the C-suite to play a role, and it is dependent on the aggregation of these reports from different units, and the impact is not just unit-wide, but facility-wide impact. And then if we want to take this up a notch to, let's say, the 1,300 hospitals in the Philippines, so I think this is where the Department of Health, the Ministries of Health play a role. So for each and every one of the ministers here with us and the deputy ministers and the healthcare leaders, how can we make sure that within your own countries, you have that framework where you can start aggregating, you kind of have a policy at place advocating and promoting that there is a reporting and learning system that is active in place, and how is that not just impacting the day-to-day working of that unit, but then how does it even get aggregated all the way up to the meso level and the macro national level? Because this is where you have the standards, the guidelines, and the national patient safety strategies. But then we are at the Global Ministerial Patient Safety Summit. So this is where that fourth level of benefit from reporting is important. And thankfully, the patient safety movement has made it to the G20 platforms, to the G7 platforms, and others. And this effort, this summit, is about maintaining that global patient safety agenda. So I thank each and every one of you for your participation and for your interest. So if we have such a, from what I call the ripple effect of patient safety reporting, this will contribute to the previous panel's topic, which is the Global Patient Safety Action Plan. And I believe it was the strategic objective number 6 that addresses the reporting and learning. And I think it's very important that we don't just say reporting. We have to always kind of think reporting and learning, because if you just report and you aggregate reports without learning, then you're not completing the circle. So all the efforts from the bedside all the way up to meso, macro will end up in a global benefits. And I think this is what we're trying to I want you to think about this framework as we're going through the questions. So with that in mind, I'm just going to leave this framework, but I'm going to start asking questions, and maybe I can borrow a microphone. We do have microphones. Can you hear me? Okay, perfect. So I will start with my good friend here, Dr. Neelam, who led patient safety in the WHO for a very long time. My first question to you is, what is the current global status of patient safety reporting and learning systems, and how have international collaboration to their development and impact to healthcare improvement? How did that contribute to the development and the impact on healthcare improvement?
Thank you, Abdullah, and good morning, colleagues. First of all, my congratulations to Minister Harbosa for being a global patient safety influencer and for organizing an extremely successful summit while we are all here. As Abdullah mentioned, that the number we are seeing here already shows the success of the global advocacy, which has really worked. And coming to the question of what is the situation of patient safety incident reporting and learning systems or adverse event reporting systems. So let's take a step back and look into the couple of milestones which we have reached in the last 10 years or so. Let's start from 2019, when a landmark resolution was adopted by the World Health Assembly, Global Action on Patient Safety, so WHA 72.6. And this resolution recognizes the importance of transparent reporting and learning systems at all levels for patient safety. Moving forward, it also then is embedded in the Global Patient Safety Action Plan. And while we are GSAPPing, I must mention that it is identified as one of the priorities in the Global Action Plan, as one of the strategies to establish and strengthen reporting and learning systems. And it is one of the core indicators, the 10 core indicators which are used to monitor the success of the Global Patient Safety Action Plan. One of them is on reporting and learning systems, how countries are doing on that. So learning from failures is really crucial. And as Abdullah mentioned, we have a lot to learn from high-risk industries. And reporting and learning systems in countries across the world are heavily influenced by that learning. So despite the global mandate which I described through the Global Action on Patient Safety Resolution and the Global Patient Safety Action Plan being a core indicator for patient safety, out of 194 member states of WHO, only 75 countries have introduced the reporting and learning systems at national level, but the effectiveness is not very high. It varies. If you look into what aspects of reporting and learning systems have been studied, it relates to governance, whether it's public sector or private sector which is participating, or it's hospitals or primary care settings as well, whether it's voluntary or mandatory, whether it's paper-based or it's electronic, or whether there are safety alerts issued as risk, and what are the type of incidents being reported. So there's a large variation in these 75 countries also which report. But if we go down really into to what level these countries are implementing, out of these 75, only 35 countries report that majority of their hospitals participate in reporting learning systems. So there's a big gap when it comes to asking for action and mandate and the importance of reporting learning systems, but looking at what has been really achieved. And one of the very important aspects of reporting learning systems, which you all recognize, is legal protection of health workers. Many countries report that's one of the barriers, that they don't have any legal protection for health workers, so they are facing punitive action. And out of these 35, I would say, only 20 countries actually have some legal protection laws enacted in the country. And again, these 20 countries, half of them are in the European region. So again, gross sort of a gap and implementation gap when it comes to reporting learning systems and legal protection of health workers. And 14 of them are in high-income countries. So half of them in Europe, and 14 of 20 are actually in high-risk groups. So a long way to go when it comes to improving patient safety and in reporting learning systems. But I must say that there's been a global trend now in recognizing the importance of reporting learning systems, to report them, to look into, what is the learning, what is the underlying causative and contributory factor, and how do we learn from those reports and then take corrective and preventive action. Now, the second part of the question relates to how has international collaboration and knowledge sharing really impacted the healthcare improvement. So at many fronts, this has been very, very effective in terms of how international collaboration has helped taking forward the reporting and learning agenda. And let's see, the most important is advocacy, policy, and regulatory influence. The international organizations and international collaboration between countries, between organizations, have heavily influenced national policies on reporting and learning, and also have brought awareness on that we need to protect health workers, and also very importantly, in the changing time, invest into information technology. So when we have to establish sustainable reporting and learning systems, we have to have the electronic platforms to report. So investment is also something which has been heavily advocated by these international collaborations. There'll be a lot of cross-learning opportunities, and several mechanisms have been created for high-level advocacy for reporting and learning systems as a foundation for patient safety. Now, the other one important area is data sharing. Data sharing, benchmarking, and learning as well. So countries, when they share data, it provides an opportunity to look into what are the common safety risks and also what are the trends. And I would like to share one example here of effective data sharing through the OECD. There's a working group on health quality and outcome indicators. And this group has countries who are then comparing their performance in patient safety with global benchmarks. So there is good amount of data sharing in the OECD countries, and the reports are generated on that. The next important one, I would say, relates to how are we taking forward the sustainability of leadership engagement. How do we have leaders engaged, and how have their sustainability? So again, here, a lot of competencies of leaders have been shared across countries. How we and international collaboration is heavily influencing that. The next I would like to mention is rapid response to global health crises. During the COVID time, particularly, it was seen that when countries exchange data, when the countries share the information, it actually helped in looking into what was the sort of real-time risk coming from medical errors, and also it helped in protection of health workers. We learned a lot, how do we protect health workers, and how do we identify these safety risks and protect patients and as well as health workers. During COVID time, also WHO and CDC produced guidelines on infection prevention control. So that was another area which led to important areas of collaboration. And finally, not taking more time, I think capacity building and training opportunities which have been created through international collaborations are phenomenal. Through WHO, several training programs exist, and as well as the WHO patient safety curriculum has been very important in bringing standardization to training. So representing the Joint Commission International, I'm very proud to mention that through a new initiative of JCI, which is Pathways, Patient Safety Pathways Initiative, we are actually going to launch a training of trainers program to build capabilities of healthcare leaders and professionals so that they are equipped with knowledge and tools for patient safety. And all these mechanisms will actually be effectively contributing and will contribute to improving reporting and learning systems globally. Thank you.
Thank you so much. So we did allude to to learning from other industries. So I'm going to ask Dr. Rosie Bennyworth, who leads the UK Health Services Safety Investigation Body, HSSIB. As far as I understand, there are probably very, very few countries that have such a very unique and independent, investigation body. So how has your experience in your organization influenced reporting and learning in the UK? Can you speak about some positive impacts, how the healthcare system reacted to it? We have many ministers of health here. Do you recommend that they establish similar body in their countries?
Thank you very much, and it's fantastic to be here, so thank you for inviting me. So we are unique. I think there's about 4 similar organisations across the world, and we've evolved from learning from other industries. Many other safety-critical industries have really learned about the importance of independent safety investigation. We know that, if a plane crashes somewhere across the world, there will be a team of independent investigators who go and really understand what the causes are, and then make changes, make recommendations to regulatory bodies and other bodies that actually will reduce the risk of things happening again. And they've been very successful at that. And we've been set up on a similar model. My investigatory team, they're experts in safety science and human factors, and they come from a very wide range of backgrounds. I have team members who have come from aviation, from the military, from nuclear, and from legal backgrounds, and they come with a very different approach and really try and understand what are the systemic reasons for things going wrong, and how do we put in systemic barriers rather than individual barriers to prevent the same instance happening again. We cover all parts of healthcare, so we look at hospitals, we look at primary care, we look at mental health, we look at the care that happens between the transition of care between those sectors as well.
And we work on the basis of no blame and no liability, and that's really important. Our legislation has been set up so anything that people tell us in the course of an investigation is protected by law. We don't disclose that information. We don't disclose it in legal proceedings. We don't name individuals. We don't name hospital names. And that's important because people can talk freely about things that have gone wrong without worrying about being in trouble with their organisation or being in trouble with their line manager. We often find that the reason things go wrong is not due to an individual, it's due to the systems, the processes and the environments that they work in. So we try and uncover those areas, we look at issues on a national basis, and we make recommendations to national bodies about the things that need to change. My investigators look at the difference between work as done compared to work as imagined, and that's actually often quite different. What people think is happening is often very different to what is happening on the ground. And just to try and bring that to life, I'll give you an example of a recent piece of work we've done in mental health inpatient care. So in mental health inpatients, we have national guidance that says you should not use risk stratification tools because it leads to an increase in harm. And yet when our investigators went out onto the ground, they found that all the people on the ground were using these tools, and we were trying to understand why. Now, the traditional approach might be to say, well, actually, that's the health professionals' fault because they should know the national guidance, they should be following the national guidance. But when we looked at and saw what was happening, we found that firstly, the IT systems that they were using made them put someone into a high, medium or low risk before they could move on to the next screen. And we also found that the coroners in our country were unaware of the changes that had been made to national guidance, and they were asking people when they came to inquests to actually say, how did you use the tools? So there was other factors that were driving people to use these tools. And that's an example of actually what we think is happening on a national system was not happening in the ground, and there's other factors. And in that situation, our role was to speak to the coroners across the country and explain that the guidance had changed, and also to work with the IT companies to say, actually, the guidance has changed and we need to move from using these tools. So that's a practical example of how we should not assume that what we think is happening and what the policy says always happens on the ground, and it's often in those gaps that things go wrong. We also believe that investigators should be professionalised. We think it's a very complex process to understand why incidents happen. And one of the things we do as an organisation is run an education programme to really upskill those people undertaking local investigations. We often hear how local investigations don't involve patients and families well. They don't listen to what has happened from those patients and families. And also, we find that often the investigation does not lead to change. So part of our role has been to look at how do we improve those quality of investigations so families are listened to, staff members are listened to, and it really leads to that learning and that change on the ground. We've seen many positive impacts from our work. We've seen lots of change in guidance nationally, lots of change in training. We've seen changes in legislation at times, and we've seen lots of local improvements. And I think our work is more important than ever as we go into the changing demographics of our populations, and that will increase patient safety concerns as we go into tighter financial situations, and all of us are experiencing workforce challenges. We need to really understand how do we create the systems, the processes, the environments that enable our health professionals to do the work that they're employed to do. Thank you.
Thank you so much. So I think you're going to have some interested people with questions either within this panel or afterwards regarding the potential to implement such a body in their countries. So moving on to Ms. Brunel Steinhobel from South Africa, which I mentioned before that patient safety made it to the G20 agenda. as part of the global patient safety improvement efforts. So we will get to that, but for now, if you can share with us your experience about implementing reporting and learning systems in South Africa.
Thank you, Doctor, and thank you for the opportunity to also share our journey in developing a national patient safety reporting and learning system. So our journey started when the Minister of Health convened a medico-legal summit in 2015 due to the rising cost of litigation in our country. So one of the outcomes of that summit was that there was an instruction to develop a national reporting system, and around about the same time there was also a call from the WHO for countries to develop reporting and learning systems. So we started off by doing a rapid assessment in all 9 our provincial departments of health, and the outcome of that rapid assessment was that we realized that everyone was doing something regarding reporting, but everyone was doing it differently. So there was no national standard to report these incidents. We then drafted the first national guideline for patient safety incident reporting and learning. And we shared it with provinces for inputs, and we also then hosted a national consultation workshop where the first guideline was discussed before it was finalized. And then in 2018, it was approved by the Technical Committee of the National Health Council and came into effect on 1 April 2018. We also decided that when we rolled out the guideline, we also rolled out a web-based information system simultaneously with the guideline. So since implementation in 2018, we have done a few things to try and improve our reporting system, because as you are implementing, you are really learning a lot, especially if it's your first time. So we started to publish quarterly and annual reports that we share with provincial quality assurance managers, as well as provincial departments heads of provincial departments of health. And we also then did a revision of the guideline in 2022, because we realized from our analysis that the classifications needed some changes, and at that time the Global Action Plan from the WHO was also published, which required some reporting on indicators which wasn't included in our classification system. We also added the automated notification function on the web-based information system to notify the next level when an adverse event occurs. And we also developed online courses that is accredited with CPD points, so that staff can attend those training courses, and it's the purpose of that is to help them to implement the national guidelines. Now, it was not an easy road for us. There were many challenges, and the challenges I'm going to mention was mentioned in this panel and in the previous one as well, so I don't think it's all that new. But we didn't have participation of all our 9 provinces initially. It took us a few years to get there, but now everyone is reporting. We still struggle with poor data quality. When we do analysis, the description of the incidents isn't clear and classifications isn't done correctly. As Dr. Neelam has mentioned, just culture is also not prevailing in all our facilities, resulting in staff fear to report because of disciplinary action, because we don't have that litigation legal system to actually protect them against that. We also see sometimes that the data is not used to drive improvement, but it's seen as a compliance exercise. And we also see that the training course that we developed is underutilized. Important for us is also to share what we have learned during the course of this journey that we had. I think to involve partners when you are doing this, and it's the first time, is so important. So we are very thankful towards the WHO, who assisted us with the drafting of the first national guideline. the resources that they have available, both the international classification system and the minimum information model, which our system is based on, was very useful for us. When we revised the second guideline, we had a partnership with the British High Commission in Pretoria, who assisted us with the revision of the classifications. It's important when you start out to just pilot in a subset of facilities before you finalize, so that you can identify gaps. And then also first develop your standardized guideline for reporting before you go over to a web-based information system, because we've seen countries that did it the other way around, and it's quite difficult. And being a ministerial summit, I cannot emphasize enough that leadership commitment is so important in this, because if you don't have, your chances of succeeding really diminishes. And then lastly, also, you have to have continuous monitoring and feedback to your stakeholders to see that you are actually using the data that you are collecting, and that you use that data to learn to prevent harm from occurring. And then lastly, that change take time, so be patient when it's your first time doing this. Thank you, Doctor.
Thank you so much. So moving on from South Africa to Singapore, I'm going to ask Professor Kenneth Mack to talk about your experience. And I think both previous panelists did talk about the just culture and the implications of the potential legal implications. So what legal safeguards and strategies has Singapore implemented to promote just culture?
Thank you very much for the question, and thank you very much for the opportunity to share what we're doing in Singapore. Much of what we're doing is very similar to what Rosie has shared as well in the UK. We have a legislative framework that we've put in place, which is exemplified by several important principles. The first of which is to promote trust and psychological safety, and to desensitize the need for reporting. And that allows, in fact, for us to get the relevant information. It allows us then to build on quality improvement and patient safety improvement efforts on the ground. Secondly, we have been focusing on capability building, particularly in the capabilities to do root cause analysis. It's not enough for us to be able to sense-make the issues and incidents occurring on the ground, but what we actually want to do is to develop actionable insights that lead to meaningful change, both at the institutional level and across the system. And that can only take place if there's a robust framework in place for root cause analysis and determining what actionable measures need to be taken to improve things on the ground. And thirdly, to promote proactive and self-assessments in our organizations to mitigate future patient safety incidents and risks from taking place. So when it comes to the legislative efforts, we mandate all licensed healthcare institutions in Singapore across both the public and private sectors, across the entire continuum, as long as they're licensed as healthcare institutions, to do mandated reporting of incidents that will take place. This includes both what we call sentinel risk events that take place across 31 different categories that have and potentially will lead to serious reportable harm that takes place, but also various other incidents that don't fall into the SRE definition, so as to encourage as much reporting as is possible. And that is something that we've put in place. These disclosures and subsequent discussions and investigations that take place are protected as is in the UK and cannot be disclosed either in for medical legal complaints or in courts, so as to ensure therefore that there's some level of legal protection and to allow this disclosure and further analysis to take place with that security in mind. Thirdly, when it comes to reporting of incidents as well as whistleblowing framework which is established in parallel, the just culture principle is very important to us, and therefore it's on the basis of no blame and no discrimination or stigmatization that takes place on the basis of actually reporting any incident on the ground that is part of our culture, and it's actually mandated as well. So we think that these are some of the important elements that we put in place that's very important to establish that legal framework that promotes then patient safety and patient safety reporting. Then when it comes to capability building, we have put in place training frameworks that actually now build these skill sets on the ground across all the healthcare institutions, at the staff and ground level to do that root cause analysis, to be proactive about sense making, detecting issues that occur, and giving them the courage and confidence to pull the cord, such that they are willing to make changes, not just report, to effect change on the ground as they report. So, by the time it comes up to us at the systems level, it's a bit late. It will be several generations of reporting up the system, and there may be sometimes quite a bit of time that is spent and delays that have incurred, and ongoing risk may occur if it was a particularly egregious incident with system impact. And therefore, it's very important that we actually train our staff to take the lead and to carry out corrective actions even as they report this up, and then train them on the skill sets to do root cause analysis, and then to identify what are root issues that do need further intervention. And this is part of the training that we actually put in place. We have mandated annual and monthly reports that will then be circulated through the entire system to all healthcare providers. The idea is really then not just to keep the actionable insights to the institution locally which has reported the incident, but to socialize this as well as the best practice and the responses so that we can learn from each other. And this occurs through a community of practice model which we establish at the various levels in the healthcare system. And these are coupled with an encouragement that all our institutions have to do this proactively in a preemptive fashion. They should sense make and look for issues, and we practice the mindset of high reliability organizations with the mindset that we should be aiming towards zero patient harm. Not always possible in various aspects, but it doesn't stop us from trying to aspire and keep that as our ambition moving forward, and that's, I think, something important to us. In terms of promoting further systems on the ground, we have put in place what we call Ensure Safer Systems. It started out initially with a collaboration with JCI, Joint Commission International, with many of our hospitals being benchmarked to JCI standards, but we've moved beyond that to our own local domestic framework, which we've called ESS, which then promotes a further bottom-up organizational leadership commitment from the ground, committed towards patient safety and change, actionable change that has to take place. And we support that at the Ministry of Health through resourcing, as well as promoting collaboration and partnerships across the entire ecosystem, both public and private, across healthcare workers and non-healthcare workers working in the system, within the Ministry of Health and other allied government agencies that are committed to supporting healthcare, and more importantly, also to bring patient safety advocates into the conversation as well. So these are some of the things that we've done.
Thank you so much. So now moving on to a topic that everyone here cares about, which is money. So, I learned during my time in the Saudi Patient Safety Center that if you want to get the ministers and, politicians to take notice, talk about money, talk about saving it and talk about making sure, how to reduce wasting it. And when we put patient safety on the G20 agenda in 2020, the Saudi government commissioned the OECD to write a report about the economics of patient safety. And guess what? The global health expenditure is around 10 trillion US dollars. If you, based on the OECD reports, the direct cost of harm is around 13 to 15%. So $1.5 trillion can be saved. So it's not about just saving money, saving lives. It's not about minimizing harm. It's also about saving money. So for each minister here, think about how much you spend in your own country on healthcare, and then do the math. 15% of that, at least, is wasted on harm. So to answer, Dr. Herbosa's question of how we get ministers interested, I want to add, the economic aspect to this as well. So with that, I'm going to ask Dr. Eduardo Banzan from the Asian Development Bank. So you are our host, right? So, so thank you very much for hosting us. From an economic perspective, how does investing in patient safety contribute to overall healthcare efficiency, cost savings, and sustainable healthcare systems?
Thanks. And I was about to say that
I used to work in EMRO, so I love how the GCC countries and Saudi systems actually work. So I think I'll go back and step back. I think a question that was asked is, why is Asian Development Bank, a bank, hosting a patient safety meeting, right? It's not because that we're friends with Secretary Herbosa. It's because ADB is committed to supporting countries in our developing member countries, or that's all around you, to achieve universal health coverage, right? So UHC, and if we start looking at UHC, and I think this is going to be crucial for us, and probably an advice to patient safety advocates, you should always connect patient safety with universal health coverage. Because if you get to understand what is UHC, it's making sure that every person would have access to healthcare services when needed. That means you need to make sure there's enough money. And if 13% of health expenditure is being lost, that means that's 13%, if it's not lost, can actually provide will provide more coverage to more people, can be used to pay for more needed health services. That's like an unbelievable injection. And I could just imagine how much improved health outcomes we could have if that money from unsafe health practices is converted into, in a sense, good health practices. So in addition to what OECD numbers, they say that diagnostic errors is about 17%. When we started looking at country-by-country assessment, in Asia we tried to look, then we saw something unfortunate. The numbers are not there. The studies are not there. And for us, that would be crucial, because as a development bank, we engage planning ministries, we engage finance ministries, because we don't just work with ministries of health. We work with them and we try to help ministries of health and other line ministries develop investment plan. And that's where we come in then, because if the domestic money is not enough, then we can come in and provide necessary financing. We don't do grants, we're a bank. We do grants for the Pacific, that's and what we call our ADF, but that's not the kind of grant that you're used to from other grant-giving organizations. That's usually like allocated grant to a country. So if we could actually have this country-by-country details of how much is, per country is being lost, then that would be easier for us to do the investment case. And by framing it as part of a universal healthcare story, then that's easier for us to make it part of programs supporting countries pursue universal health coverage. You try to avoid to carve it again as another vertical program, because ministers of finance don't like that. They got too many vertical programs that they have to talk to. So, but framing it as part of a health system reform, again, UHC, then you get it works forward. Now, a second part why ADB is very much would like the surveillance system, specifically for the surveillance system, is part of what we do is we really try to get countries to work together in regional disease surveillance and all. We call it in ADB regional cooperation integration work. So we actually have friends here from the Greater Mekong sub-region. We have invited them here. They had a different meeting yesterday, and they're looking into how they could improve health cooperation among the Greater Mekong sub-region countries. So this is part of China, Myanmar, Thailand, Laos, Cambodia, and Vietnam. The Pacific Islands, of course, ADB loves the Pacific Islands. So we've been working a lot with WIPRO to see how they can actually get the Pacific Islands to share information and data. Central Asia, we call that CAREC, and so on. And of course, my favorite, ASEAN. So there's actually lots of institutions. It's not something that needs to be driven out of ministries of health. It actually can be driven by existing institutions, like the Pacific Island Forum, ASEAN, GMS, CAREC, where we could actually drive collaboration. And ADB is actually committed to support this regional cooperation work, putting in money, leveraging ADB support so actually countries could spend money. So these are the reasons why we are here to help ministries of health argue the case, to build the case, and talk to ministries of finance and ministries of planning for you to get this great things done. There's another thing we always like to describe, how would we differentiate ourselves from other institutions? Well, what we actually do is we help countries solve complex problems, because as a bank, we actually work with so many specialties here. I'm health, We have colleagues here within the same building working on all other sectors you could imagine, from agriculture, transport. And so we could easily just pull everybody in to sit down, including the private sector. And what we usually want to do is we help countries scale up what they think would be good. Because if there's one thing sometimes so that is quite unfortunate, there are great ideas like Singapore and UK is doing, and you keep on wondering, why isn't the Philippines doing it? What is so hard about what Singapore and UK are doing that other countries cannot do? And so that's part of our job. We want to help this country scale up things that have already been proven to be working. Thank you.
Thank you so much. So we may have also time for one or two questions from the audience. So I will ask my panelists here to try to stay on time so we can have more interactive session as well. So going back to Dr. Neelam, what unique challenges do high-income countries have when it comes to reporting and learning system implementation, and how does that compare to the challenges that low and middle-income countries have?
There are almost 60 countries out of the 194 member states of WHO which are high-income countries. So when I'm going to share with you the challenges which these countries face in reporting learning, it's going to be very generic because some of these countries have very advanced systems, the others may be starting it. But despite having very well-developed healthcare infrastructure, there are very unique challenges these countries face, even in high-income countries. So most important, I would say, is underreporting of adverse events because of the risk of, or the fear of litigation, and also cultural barriers. So despite our efforts on just culture, countries are still feeling that there may be legal repercussions or professional repercussions on individuals, and maybe it will also lead to reputational risk to the organization. And still blame culture is very prevalent in high-income countries, so it discourages reporting. So that may be in some situations, but in other countries which have very advanced reporting system, in those countries there's a huge amount of data which is being collected. So there are a lot of data overload, but the data is not actually analyzed, so it's almost like analysis paralysis, that we are collecting data, but we are not taking out any meaningful information from that data. And in addition to that, there's the other challenge is integration, because reporting systems are separate and then electronic health records are separate. Now, how do we make sure that these systems talk to each other? That's another challenge which these countries are facing. When health workers are reporting for adverse events, they really want to know what happened to those events. So a high-level engagement is required with these health workers so that, through a feedback mechanism, what they report, we tell them what has been done with that report and how it has led to corrective action. And in high-income countries, still there's lack of or not fully full engagement of health workers, and the feedback loops are not really effectively working. And some of these countries also have very complex systems. They have fragmented multiple reporting lines and they don't talk to each other. And some of these organizations also have lack of standardization. So it's very difficult to aggregate data in those countries. Now, those are some very unique challenges which high-income countries are facing. If we look into the problems of low-income countries, most of these relate to basic infrastructure and also chronic underfunding. So there's challenges of, for example, introducing information technology. There's lack of internet access, for example, or even the reporting systems are still paper-based. And of all the countries 75 countries which reported, 12 countries still on paper-based systems. Some others have, of course, softwares as well as email reporting. So this is another challenge, that how do we make sure that the infrastructure, basic infrastructure for reporting learning is available in these countries. And there's a major technology gap there as well. And I would say in these countries, there's also their legal and policy frameworks are not very effective. Even if policies are there, they're not implemented, and particularly legal protection for health workers, which promote safety culture, are still in very early stages. Now, which strategies have worked in these countries? I would say creating a non-punitive, just culture, and reducing the the fear of blame, I think, is very, very important. So how these countries, those who have worked both in high-income countries and low-income countries, where countries have established these systems, this is how they've done it, by creating a just culture. The other important mechanism they've done is also to build workforce capacity. Bring workforce is trained and they are aware why it is important to report. And then they have skills for data analysis. And not only that, how this data analysis is turned into some learning and how it actually engages, and there's a feedback loop to report back to the health workers, and it actually leads to some change. So these strategies have very effectively been implemented in countries. And finally, just want to say international collaboration is extremely also very important, and that has really worked in all countries, particularly sharing of resources, how one country is implementing systems and the other. A lot of cross-learning opportunities have been utilized for building strategies. So I would summarize that in high-income countries, what is really working, they're focusing on just culture, integration, as well as improving the electronic systems, and even introducing AI-driven analytics for proactive analysis of what's happening. And some of these systems also have even an automated incident detection as well. While in low middle income countries, most of the challenges relate to resource limitations, weak policy implementation, and fundamental system gaps and infrastructure gaps. But despite that, some of these strategies related to having some system to report, as well as having just culture, is really, really supporting those implementation. Thank you.
Thank you so much. So we have two questions here from the audience. So I'll start with Susan Sheridan. If you can introduce yourself, and then if you want to point to one panelist.
I point to one panelist. Well, my name is Sue Sheridan. I'm with Patients for Patient Safety US, and I want to address the reporting and learning systems that we're talking about. I want to share that 30 years ago, I witnessed my newborn son suffer brain damage in a large regional hospital due to the failure to test and treat his newborn jaundice. The number one thing I wanted to do after that was report this so others would learn and this wouldn't happen to other newborns. And this was actually happening all over the United States. What I learned then, there was no mechanism for me to report, no mechanism for me to report into so others could learn. Now that was 30 years ago. Fast forward to today, if that happened to a newborn in the United States, there would be no mechanism for that mom or dad to report that. So my plea to you and the ministries here, the number one person who knows the whole arc of a patient safety event is the patient. We are missing that rich resource to capture from us. So I plead to you that any patient safety incident learning and reporting system have mechanisms for us to report to you. And I would add that, and the framework up there, I didn't see patient reports, so let's include that in future frameworks. And then I'd also say, we're using the term just culture. Well, I would add that any just culture would welcome input and learn from their patients. Thank you.
Thank you so much. I think this is a very, very important point, which is, the contribution of patients and families to reporting. And maybe I can ask you to comment on that.
Yes, thank you very much, Sue, for sharing that. And I have to say, in our investigations that we undertake, one of the key things we hear from families is that they're not listened to. They're not listened to when they raise concerns about their care, and then they're not listened to. We work with a lot of bereaved families and a lot of patients that have experienced harm. And one of the things we hear consistently is that they're held at arm's length through the processes after someone has died or someone has experienced harm. So we need to really empower people, empower patients to be involved in those discussions to really think about how we support people after things that have gone wrong, how we make sure they are listened to, how we capture their stories, and how we use that to drive improvement. And that's something that that we hear. And I would also just like to add that we need to also think about how we support staff after things that have gone wrong. For many people, after something has happened, it's career ending for them, and we need to think about how do we support the staff members and encourage the care for them as well, and make sure that we create that learning system, both from listening to patients and families and also listening to the health professionals that work in the system.
Thank you so much. Go ahead, Mr. No.
I can maybe just mention, sorry, when we developed our patient safety incident reporting guideline, we simultaneously also developed a complaints, compliments and suggestion guideline, which actually now feeds into the patient safety incident reporting guideline. So that guideline sets out systems for patients to report their complaints, and if it's identified as a serious adverse event, it's moved to the patient safety incident reporting system. And we've also developed, about 2 years ago, a mobile app for patients specifically so that they can lodge their complaints as well.
Thank you so much. And that's one of the benefits of this summit is, you know, the learnings from talking about learnings, you know. So you have these experiences from different countries. And I think there's an opportunity also for all the audience to talk to the panelists, you know, during the break. So I'm going to ask Howard, you know, to introduce himself, but he's the CEO of ICN. And I just have to highlight one thing. You know, at least 50% of the health workforce is nurses, if not more. And we will not have improved patient safety. We will not have sustainable healthcare systems. We would not have a healthcare system if we don't invest in nurses. And there's an economic, actually, impact to investing in nursing. So if you care about patient safety, you know, as a minister, as a deputy minister, as a healthcare leader, you have to invest in nurses. So, you know, I can't just, I'm sure many of you saw the images of the, you know, when the earthquake took place, and, you know, talking about the safety of those babies in that unit, when many healthcare workers would have probably, you know, chose to escape, but those nurses, you know, heroic as they were, they stayed around and protected those babies. I think there's a lot of benefit in investing in nurses. So, Howard?
Abdullah, I'll step aside as the CEO of ICN, and you can take over. I thank you for your, and it's not just today, but over the years, you've been a consistent, loyal, powerful advocate for the nursing profession and the health workforce generally, and I thank you for that. There were some fabulous insights into just culture, the issues with the blame culture, how we move away from that, which I thought were very powerful, and I appreciated hearing those very much. When I talk to nurses pretty much around the world, there are two big things which always come up. It's in addition to what you've already said, but these two things really stand out for me. The first one, there aren't enough of us. There are shortages. We're always stretched too thinly. We're always chasing our tail. We're always having to work overtime to cover those sorts of. And on top of that, the demands of work, the intensification of work, the throughput of patients is just relentless. And we see no let-up in either of those two things. Now those are big system-wide issues, and I completely agree with Neelam that when people report, they need to hear back what's changed. But we don't often hear back things that have changed in relation to these big system issues. And in fact, Abdullah, you probably know this as well, because you did some fabulous work on safe nurse staffing systems and how important they are, because the evidence tells us that too few staff, or staff where the skill mix without the right experience, the risks to patients, the evidence shows, from trips and falls to medication errors to death, go through go through the roof. But there's a bit of a resistance around the world to putting in more robust, safe staffing systems. And staff don't necessarily see that if it's to do with the way that work's organised and the intensification of work, how the system of work may change as well. So I would be really interested, well, firstly, have we got any of those bigger system changes that we know about and that we can share? And is there something that we can do about that as well? Because that I think is something, you know, if staff are offered some, you know, they report and the feedback is, look, there's some training, there's a counsellor you can go and see. I'm not belittling that those things are helpful and important, but they don't go to the heart of the big issue that many staff are raising. And the problem with that as well is that people just get worn down. And that's where the burnout and the higher leaver rates that we see as well are coming from. And I think there's an issue about attracting people into the health professions as well. I mean, the OECD's latest study showed that interest in nursing, which is deeply worrying to me amongst 15, 16-year-olds, had dipped a bit as well. And I always struggle with talking about it's the best profession in the world, I believe that absolutely. But if I talk about the reality, there are some real challenges in there as well. So any thoughts on those bigger system issues would be great. Thank you.
Thank you so much. So maybe Dr. Eduardo, do you have any comments on that, since you're dealing with many countries? So if you want to address the nursing question within those countries.
It's actually a dangerous question because my wife is a nurse. Right, so, and of course I'm Filipino, right? So, but in a sense, when we look at, and I fully agree, you know, investing in health workers is probably one of the best intervention. And country after country, the way nurses are treated differs. And part of the challenge in OECD countries, your problem is less people wants to become nurses. In lots of developing countries, we have not really empowered nurses. To the point, I'm a doctor, and unfortunately, in lots of countries, the doctor thinks he's the king and the nurse. And so that this empowerment, unfortunately, makes it also a problem in patient safety. So just empowering nurses, making them more at the par professionally with the doctor, kill this whole doctor is king attitude will be good. Now, in developing countries, nursing is still a very good profession. It's still a well-paid position. Plus the fact that there's the migration option, which we don't want, but actually it's there. So frankly, in developing countries, if countries invest in more health workers, the people will come. It's not an OECD problem, right? You don't have, people are actually excited to become nurses. So maybe that's something we need to explore. Now, there's another missing element that in this whole story, which is important, which is very common in developing countries. I call them the community health workers. We moved from the ASHA of India to the lady health workers of Pakistan, to the Puskesmas guiders of Indonesia, to the barangay health workers. They're very powerful. And they're not just health workers, they're also, in a sense, champions of patients. People are very comfortable talking to them. People are more willing to complain to them about patient safety issues. And they're not just in the communities. There's actually, within the hospital, lots of manongs and manangs, as they call it in the Philippines. So these informal health workers, unfortunately, sometimes not part of the discussion in patient safety, when I think they should be. They're a powerful resource in a lot of developing countries, and if you expand your patient, and since good patient safety programs, unfortunately, are in developed countries, maybe we may have among here in this room, developing countries, you should speak up and talk about it. And I would believe your programs would probably have more of these informal health workers in the system, more than what we're seeing in OECD countries. Now, that's stories that we in ADB will help countries to document, to tell the story, and hopefully help it replicated, formalize a bit in other countries as well.
Thank you so much. So last question from Luke.
I think the
sorry.
Was first. I'm here as well.
So 2 last questions. Go ahead.
Thank you very much. 3 last questions.
Okay. Three last questions. Sorry for the organizing committee. We'll try to be brief.
Yeah, thank you very much. This is Ali from Saudi Arabia. I'll try to make it quick. My question is to Rosie. A question of two parts. The first part is, do you investigate all incidents? And if not, what are your criteria to choose which incident to investigate? And the second part is, in case along the investigation course, a suspicion of legal part came up, do you deal with that, or you refer to another body to take part of the, to continue the process of sort of legal aspect? Thank you.
Thank you very much. So we investigate areas of national patient safety concern. So we undertake about 20 national investigations a year, and we look at, we have criteria that we've consulted on with the Secretary of State, and the Secretary of State has agreed our criteria, and the criteria look at, is this a problem that's happening in multiple providers across the country? So is it happening in lots of different places? Is it a significant patient safety concern? And we tend to look at those areas that are of major patient safety concern. So, for example, we have been looking at mental health, we've been looking at surgery and things like retained swabs in surgery. We've looked at quite a lot in digital safety now with the new digital tools that are coming in. So areas of national patient safety concern. Can we address inequalities is another criteria we have. We want to do everything we can to address the inequalities we see in patient safety and in healthcare. And can we add value through our methodology? We don't want to repeat work that's being done elsewhere. So we look at those criteria. As I said in my first statement, we do protect information that comes through to us, but we do have the ability, and I have the ability, if I see areas that, for example, if I see criminal behaviour, or if I see things that are causing immediate harm to patient care through negligence or other things, I do have the ability to escalate concerns through regulatory bodies and through other bodies or through the police. So we do have caveats to our legislation to make sure that we share information if appropriate. But by and large, we want to keep as much information confidential through that legislation as possible, because actually we think it's really important to allow that safe space for people to talk to us. And that's learning from other industries as well, that has led to that culture that we see in other industries that drives better care.
Thank you. So who's next? Luke? Go ahead.
Thank you. Thank you, Dr. Al-Hassawi. So I'm Luke Slavomirsky. I'm one of the authors of the Economics of Patient Safety series. Thank you for promoting the work. And I fully agree with your comments and Dr. Banzon's reflection. I only wanted to add to that a very important point, is that the return on investing in improving patient safety is actually very high. It's up to $10 for every dollar invested. So it's up there with vaccines. It's much higher than the return on investment from curative care in terms of health gain or harm avoided. So that always has to accompany these statements about how expensive patient harm is. Well, there's actually some stuff we can do about it. Established programs, initiatives that generate a lot of benefit for quite modest amounts of money. And on the point of nurses, one last point. I was looking at some data recently for a separate project, looking at cardiovascular disease deaths are positively correlated with physician density, but negatively correlated with nurse density across OECD populations. So I'll leave you with that, perhaps for another time. Thank you.
Thank you so much. And again, $10, you save $10 for each dollar you spend on patient safety. I'm talking to the ministers here, so we need to invest in patient safety. So last, very quick.
Thank you very much, and thank you for giving me the opportunity. My name is Ahmadou Lamin Samate, Dr. Ahmadou Lamin Samate. I'm the Health Minister of the Gambia, and I happen to be a general surgeon, so I can relate directly to what you're talking about. And by the way, I still walk into the wards occasionally still, and then get to know the issues. Patient safety, as much as it is important, certainly is a very complex topic in the sense that there are so many factors contributing to challenges in patient safety, and the reasons might be similar in both developing and developed countries, but developing countries have particular challenges that are unique to them, capacity gaps, inadequate resources, and if we tell you the doctor-patient ratio, the nurse-patient ratio in some of our countries, you'll be amazed how the nurses or the doctors do their work. However, the patients that we care about, we cannot cause harm to them. It's as simple as that. But do we have all what it takes to ensure that there is no harm? Health system strengthening, we believe, is very, very important. We cannot effectively deal with patient safety issues without having strong health systems, where we have the equipment, but more so where we have the trained personnel, adequately trained people. Now, my question again goes to Ronil. You did say you investigate about 20 cases per annum. Now, what happens then to which cases do you actually investigate? When we have now the no litigation, reporter protection, health worker protection, which we believe is very good, is going to encourage people coming out. But then exactly as my colleague said, what happens when you think there are cases of negligence? Of course, when we have the reporting and learning systems, we know it's likely to enhance people being more careful because they know that somebody is having oversight over what is happening. But which cases do you investigate? Like in the Gambia, for example, with regards to maternal mortality, because of the concern, I said, for each maternal mortality, I need to be aware as health minister, and I want to sit on the team that looks at what went wrong. But of course, we are likely to find issues. When we find issues, what do we do? If we think there are challenges, whether it's a systematic system challenge or whether it is health worker challenge. We sincerely need advice because otherwise we're going to run into problems because the deeper we search, we are likely to find issues, and what do we do with those issues? Thank you very much.
Thank you. I think you meant Dr. Bennyworth. So.
Thank you very much for the question. So we don't replace the local investigations and the local legal proceedings. They will carry on and are done by other teams, but we do look at how we can improve the quality of those local investigations through our education program. But what we look at is those structural issues, those systemic issues that actually are impacting on all of the hospitals or impacting on all of the primary care providers or the community providers. So, for example, we know that most times when we investigate a problem, such as we looked at digital tools, for example, in primary care and how they were used, and we heard a lot from patients across the country about how those tools were not always supporting them into accessing services. So we look at a problem that affects lots of different places across the country, and we find often it needs a change in national approach. It needs a change in national guidance. It needs a change in national training of our doctors and nurses or healthcare professionals that are coming through the training. And it needs a change in regulation, and we make recommendations into those national bodies about things that need to change, and expect those national bodies to give us a response. They have a 3-month period to respond to our recommendations about what they're going to do with those recommendations. Often we hear from people working in individual hospitals, we can do so much within our individual hospitals, but there's factors externally that are impacting our ability to deliver safe care, and those are the aspects that we look at through our investigation. But I'd be very happy to come and have a longer conversation if it would be helpful.
So with that, I would like to thank each and every one of the panelists for great conversation, and thank you for being engaged and interactive. And I'll hand it over back to the organizing committee.
Thank you very much, Dr. Al-Hawasawi. And to our panelists, can we have a quick photo opportunity, please, with the panelists? Thank you. You may, all right. You can also remain seated if you like, but all right, we're standing. All right, that's good. One quick photo opportunity. And after this photo opportunity, we invite everybody for lunch. And lunch will be available at the executive dining room. And after lunch, we will reconvene for the breakout sessions. Please kindly refer to the program guide on the Summit mobile app for the location of your assigned breakout rooms. And again, after lunch, you may then proceed to the designated breakout sessions. Once again, a big round of applause to our panelists and to the one who chaired the panel. Thank you, Dr. Abdullela Al-Hawasawi, and to all the delegates who participated with their questions and remarks about the experts plenary 2 topic. All right, everybody, please do enjoy lunch. Available again in the executive dining room, and please reconvene in your designated breakout rooms after lunch. Thank you very much.
In a world where health is our most precious asset, ensuring patient safety is our top priority. On this World Patient Safety Day, we come together to celebrate the dedication of medical professionals. Medical personnel play a crucial role in ensuring the safety of every patient. They listen, they diagnose, they care, they comfort, they support, they heal. But patient safety isn't just about medical professionals. It's a partnership. Patients also have a vital role to play in their own well-being. Effective communication is the foundation of patient safety. Collaboration among healthcare teams ensures the best care possible. Diversity and inclusion foster innovation and better patient outcomes. Today, let's reaffirm our commitment to patient safety. Together, we can make every day a day of safety, compassion, and healing, because every patient deserves to be safe and cared for. Happy World Patient Safety Day. In a world where health is our most precious asset, ensuring patient safety is our top priority. On this World Patient Safety Day, we come together to celebrate the dedication of medical professionals. Medical personnel play a crucial role in ensuring the safety of every patient. They listen, they diagnose, they care, they comfort, they support, they heal. But patient safety isn't just about medical professionals. It's a partnership. patients also have a vital role to play in their own well-being. Effective communication is the foundation of patient safety. Collaboration among healthcare teams ensures the best care possible. Diversity and inclusion foster innovation and better patient outcomes. Today, let's reaffirm our commitment to patient safety. Together, we can make every day a day of safety, compassion, and healing, because every patient deserves to be safe and cared for. Happy World Patient Safety Day. In a world where health is our most precious asset, ensuring patient safety is our top priority. On this World Patient Safety Day, we come together to celebrate the dedication of medical professionals. Medical personnel play a crucial role in ensuring the safety of every patient. They listen, they diagnose, they care, they comfort, they support, they heal. But patient safety isn't just about medical professionals. It's a partnership. Patients also have a vital role to play in their own well-being. Effective communication is the foundation of patient safety. Collaboration among healthcare teams ensures the best care possible. Diversity and inclusion foster innovation and better patient outcomes. Today, let's reaffirm our commitment to patient safety. Together, we can make every day a day of safety, compassion, and healing, because every patient deserves to be safe and cared for. Happy World Patient Safety Day. In a world where health is our most precious asset, ensuring patient safety is our top priority. On this World Patient Safety Day, we come together to celebrate the dedication of medical professionals. Medical personnel play a crucial role in ensuring the safety of every patient. They listen, they diagnose, they care, they comfort, they support, they heal. But patient safety isn't just about medical professionals. It's a partnership. Patients also have a vital role to play in their own well-being. Effective communication is the foundation of patient safety. Collaboration among healthcare teams ensures the best care possible. Diversity and inclusion foster innovation and better patient outcomes. Today, let's reaffirm our commitment to patient safety. Together, we can make every day a day of safety, compassion, and healing, because every patient deserves to be safe and cared for. Happy World Patient Safety Day. In a world where health is our most precious asset, ensuring patient safety is our top priority. On this World Patient Safety Day, we come together to celebrate the dedication of medical professionals. Medical personnel play a crucial role in ensuring the safety of every patient. They listen, they diagnose, they care, they comfort, they support, they heal. But patient safety isn't just about medical professionals. It's a partnership. Patients also have a vital role to play in their own well-being. Effective communication is the foundation of patient safety. Collaboration among healthcare teams ensures the best care possible. Diversity and inclusion foster innovation and better patient outcomes. Today, let's reaffirm our commitment to patient safety. Together, we can make every day a day of safety, compassion, and healing, because every patient deserves to be safe and cared for. Happy World Patient Safety Day. In a world where health is our most precious asset, ensuring patient safety is our top priority. On this World Patient Safety Day, we come together to celebrate the dedication of medical professionals. Medical personnel play a crucial role in ensuring the safety of every patient. They listen, they diagnose, they care, they comfort, they support, they heal. But patient safety isn't just about medical professionals. It's a partnership. patients also have a vital role to play in their own well-being. Effective communication is the foundation of patient safety. Collaboration among healthcare teams ensures the best care possible. Diversity and inclusion foster innovation and better patient outcomes. Today, let's reaffirm our commitment to patient safety. Together, we can make every day a day of safety, compassion, and healing, because every patient deserves to be safe and cared for. Happy World Patient Safety Day. In a world where health is our most precious asset, ensuring patient safety is our top priority. On this World Patient Safety Day, we come together to celebrate the dedication of medical professionals. Medical personnel play a crucial role in ensuring the safety of every patient. They listen, they diagnose, they care, they comfort, they support, they heal. But patient safety isn't just about medical professionals. It's a partnership. Patients also have a vital role to play in their own well-being. Effective communication is the foundation of patient safety. Collaboration among healthcare teams ensures the best care possible. Diversity and inclusion foster innovation and better patient outcomes. Today, let's reaffirm our commitment to patient safety. Together, we can make every day a day of safety, compassion, and healing, because every patient deserves to be safe and cared for. Happy World Patient Safety Day. In a world where health is our most precious asset, ensuring patient safety is our top priority. On this World Patient Safety Day, we come together to celebrate the dedication of medical professionals. Medical personnel play a crucial role in ensuring the safety of every patient. They listen, they diagnose, they care, they comfort, they support, they heal. But patient safety isn't just about medical professionals. It's a partnership. Patients also have a vital role to play in their own well-being. Effective communication is the foundation of patient safety. Collaboration among healthcare teams ensures the best care possible. Diversity and inclusion foster innovation and better patient outcomes. Today, let's reaffirm our commitment to patient safety. Together, we can make every day a day of safety, compassion, and healing, because every patient deserves to be safe and cared for. Happy World Patient Safety Day. In a world where health is our most precious asset, ensuring patient safety is our top priority. On this World Patient Safety Day, we come together to celebrate the dedication of medical professionals. Medical personnel play a crucial role in ensuring the safety of every patient. They listen, they diagnose, they care, they comfort, they support, they heal. But patient safety isn't just about medical professionals. It's a partnership. Patients also have a vital role to play in their own well-being. Effective communication is the foundation of patient safety. Collaboration among healthcare teams ensures the best care possible. Diversity and inclusion foster innovation and better patient outcomes. Today, let's reaffirm our commitment to patient safety. Together, we can make every day a day of safety, compassion, and healing. Because every patient deserves to be safe and cared for. Happy World Patient Safety Day. In a world where health is our most precious asset, ensuring patient safety is our top priority. On this World Patient Safety Day, we come together to celebrate the dedication of medical professionals. Medical personnel play a crucial role in ensuring the safety of every patient. They listen, they diagnose, they care, they comfort, they support, they heal. But patient safety isn't just about medical professionals. It's a partnership. patients also have a vital role to play in their own well-being. Effective communication is the foundation of patient safety. Collaboration among healthcare teams ensures the best care possible. Diversity and inclusion foster innovation and better patient outcomes. Today, let's reaffirm our commitment to patient safety. Together, we can make every day a day of safety, compassion, and healing, because every patient deserves to be safe and cared for. Happy World Patient Safety Day. In a world where health is our most precious asset, ensuring patient safety is our top priority. On this World Patient Safety Day, we come together to celebrate the dedication of medical professionals. Medical personnel play a crucial role in ensuring the safety of every patient. They listen, they diagnose, they care, they comfort, they support, they heal. But patient safety isn't just about medical professionals. It's a partnership. Patients also have a vital role to play in their own well-being. Effective communication is the foundation of patient safety. Collaboration among healthcare teams ensures the best care possible. Diversity and inclusion foster innovation and better patient outcomes. Today, let's reaffirm our commitment to patient safety. Together, we can make every day a day of safety, compassion, and healing, because every patient deserves to be safe and cared for. Happy World Patient Safety Day. In a world where health is our most precious asset, ensuring patient safety is our top priority. On this World Patient Safety Day, we come together to celebrate the dedication of medical professionals. Medical personnel play a crucial role in ensuring the safety of every patient. They listen, they diagnose, they care, they comfort, they support, they heal. But patient safety isn't just about medical professionals. It's a partnership. Patients also have a vital role to play in their own well-being. Effective communication is the foundation of patient safety. Collaboration among healthcare teams ensures the best care possible. Diversity and inclusion foster innovation and better patient outcomes. Today,
Good afternoon, ladies and gentlemen, to all our guests, delegates, and participants. We are about to resume our program in some few minutes. Meanwhile, may we request our guests and participants to kindly first occupy the seats at the middle part of our venue. Again, may we request our participants here in the main hall to kindly occupy the seats in the middle part of our venue, just in front of our stage. Thank you. Good afternoon again to all our delegates and participants. In some few minutes, we will begin our program. Meanwhile, may we invite our participants to kindly occupy first the seats located at the middle part of our venue, just in front of our stage. Again, may we request all our participants to kindly occupy first the chairs in the middle part of our venue here in the main hall, just in front of our stage. Thank you. Again, our program will start in some few minutes. And now to facilitate the primary care track panel discussion 1.2, please welcome Ms. Mercedita Hoxon. Let's give her a big round of applause.
A pleasant good afternoon to everyone. Did you have your lunch already? All right. So it is indeed a privilege for me to introduce this session's members. Let us start with our session chairs that we call on Dr. Isaac Suture, focal point for global patient safety and international digitalization at the Swiss Federal Office of Public Health. We also have Dr. Irina Papiva, Technical Officer from the Patient Safety Flagship, World Health Organization Headquarters, Switzerland. And now we welcome our session panelists, Dr. Masaru Kurihara, Policy Advisor for Patient Safety at Japan's Ministry of Health, and Safety Manager at Nagoya University Hospital. We call on Dr. David Kelly, Health Policy Analyst and Report Author, Organization for Economic Cooperation and Development. We also have Dr. Hardip Singh, Professor of Medicine at Baylor College of Medicine, Houston, Texas, USA. And finally, Ms. Karen Alparce Villanueva, President of the Philippine Alliance of Patient Organization. To jumpstart the discussion on strengthening patient safety in primary, ambulatory, and community settings, the case of diagnostic safety, I now turn over the floor to our session chairs.
Yes, thank you, Mercedita. Excellencies, ladies and gentlemen, dear colleagues, it's a real honor and pleasure and a privilege to co-chair this panel with my esteemed colleague Irina, and of course to share the stage with such distinguished panelists. As you all know, we are focusing on a very pressing topic today, bringing together two crucial areas of safe healthcare. So on the one hand, healthcare increasingly shifts towards primary care settings, which is serving as the first point of contact very often for most healthcare interactions. And as you know, these settings are really critical for the provision of a diverse range of services, including early diagnosis, amongst others. And meanwhile, in these settings,
Healthcare providers often face unique challenges, such as high patient volume or increasingly high patient volumes. And on the other hand, diagnostic safety, of course, is a fundamental patient safety issue. Missed or incorrect diagnoses can lead to unnecessary treatments or worsened health outcomes. And their impact is particularly significant in primary care settings, where resources and access to specialized services, for example, may be limited. So overall, research indicates that diagnostic errors are one of the leading causes of patient harm. Now, what are our objectives of this session? We actually aim mainly at 4 things this afternoon. So firstly, we want to show the economic consequences of diagnostic errors. Then we also want to provide an impression of the safety challenges in specific settings. Furthermore, we will outline a range, or our panelists will outline a range of strategies and interventions to tackle these challenges, including the response at global level. And finally, the session will include perspectives from different stakeholders at different levels of the healthcare system. So, in this sense, I'm looking forward to a lively and insightful session, and happy to leave the floor to my colleague Irina. Thanks.
Thank you very much, Isaac, for the introduction. Indeed, diagnostic safety is in the cornerstone of provision of safe, effective, and high-quality care. And the attention to diagnostic safety is rising globally recently, considering that our health systems become more complex, that we are facing many systemic challenges like workforce capacities. We are having technological advances. So considering the complexity of the health systems, diagnostic safety should remain in the center of attention. It should remain in the center of attention not only of the national governments, but also at the global agenda. Because addressing diagnostic safety should be done through the comprehensive and systemic approaches. But to do that, the first thing for us to make sure is that we are able to build the case. Why diagnostic safety is important and why we have to put focus on diagnostic safety within broader context of improving patient safety and even within broader context of strengthening our health systems. And as was mentioned by Abdullah in the previous plenary, when we talk money, we are very clear. So let's start building the case of diagnostic safety, looking at the economic and financial implications. And I will ask David from OECD to tell us what are the financial and economic implications of unsafe care in general and specifically for diagnostic safety, and if we have any differences across different settings. So over to you, David. Thank you.
Thank you, Irina. Thank you, Isaac, for that introduction. The OECD is very happy to present our latest findings from the report, The Economics of Diagnostic Safety. In addition to the harm caused to patients from diagnostic error, there's considerable economic costs from the healthcare expenditure that goes towards both the diagnostic error and any harmful curative care that may stem from that error. So the way we estimated it, we broke it down into three sources of error. Misdiagnosis, so where a diagnosis is missed or delayed. Underdiagnosis, where it's systemically not made, and then overdiagnosis. Now, not all diagnostic error will result in harm, but it will result in wasteful healthcare expenditure and that it may not bring any benefit to the patient. So we estimate that in total, the direct costs of diagnostic error account for 17.5% of total healthcare expenditure, which is really a considerable portion. And these estimates are an update from those previously published in our 2022 report. And then additionally, if we add on to that the costs of any curative acute care administered to patients as a result of patient safety lapses from diagnostic error, the total would add up to 28.5%. So that's really a considerable proportion of healthcare spending. And to put the 17.5% figure in perspective, if we translate that into healthcare spending, for example, in the United States, 17.5% of the US expenditure budget, that would represent $870 billion US dollars. So that's the cost of diagnostic error in our updated estimates. I think you'd asked about the differences across the different healthcare settings. So in our report, we estimate that the greatest expenditure is in the acute care setting, which is perhaps understandable that patients may be sicker and may undergo more extensive diagnostic investigations and treatment. And that's greater than in the long-term care setting, where there may be issues with underdiagnosis, for example. And then the smallest relative proportion is that occurring in ambulatory care or primary care, but obviously that will vary according to the country in question. So these are the OECD estimates for the breakdown. So the greatest being in the acute care setting, and then the smallest being in the primary care setting. So as you can see from that breakdown, the costs from direct costs of diagnostic error really do represent a considerable proportion of overall healthcare expenditure, and therefore represent a potential for considerable savings if improvements in diagnostic safety are implemented. Thank you.
Thank you so much, David, for your enlightening input. Again, those numbers are impressive and worrisome, I think, at the same time. And you also showed that the challenges are manifold. The OECD's work again shows the importance and urgency of patient safety overall, and diagnostic safety in particular. So now we'll move on to our next panelist. Dr. Hardeep Singh will now elaborate on what diagnostic safety actually means, including the challenges and risks. And I think this will surely give us a more concrete idea of the issue. Please, Hardeep, you have the floor.
Thank you, Isaac, and thank you for being here post-lunch. So, can I have my slide, if the next slide? Yeah, okay. So I'm going to talk about three things to emphasize why this area is more challenging than any other patient safety problem that we talk about. First, we have to understand what is the diagnostic process. So the diagnostic process is when a patient seeks medical care, health care for a specific symptom or finding. Then there is a process of getting information from the patient, which is history, exam, testing, referrals, consultations. All of that happens over space and time in the ambulatory care, for instance, or even in acute care setting, no matter what setting you're in. Then there is a diagnosis that's made, that's communicated to the patient. Oftentimes we don't do that very well. And then there's treatment. Now, in this picture, which is from the National Academy of Medicine in Improving Diagnosis Report, and I just adapted the picture, you will see that it looks like the diagnostic process is fairly linear. But most of us know it's not. It is a very complex, iterative process that unfolds over time between different places: primary care, emergency care, hospital setting, radiology, pathology, lab, anywhere else that you can make potentially a diagnosis. So it is important to understand that this diagnostic process is influenced by not just the systems of care that we are practicing in, but very heavily also influenced by our cognition, a decision making. And when that unfolds together, where there's system and cognitive influences on the diagnostic process, a lot of things can go wrong. So it's a particularly challenging sort of area to sort of study. Now, you have to understand what is diagnostic safety. So now you know what the diagnostic process is. So diagnostic safety is not just making sure that you can make a correct and a timely diagnosis, but you also have to make sure that it's resource efficient. We cannot be ordering a CAT scan on every single patient who comes in with abdominal pain to the emergency room or primary care, correct? I mean, you might find something in 1 in 500 CAT scans, but is that a good use of our resources? No. So we have to be taking that into consideration. We also have to take sort of the patient-centeredness view into consideration. We want to maximize patient experiences. The diagnostic process involves a lot of uncertainty. There's a lot of evolution of the conditions of the patient. And we want to make sure we're able to handle uncertainty and communicate that uncertainty to the patient and to the family members. That makes this definition a bit harder. And you also have to ensure things like equity. So when you have things like correct, timely diagnosis, which is patient-centered, equitable, and is efficient, it makes it complex, and that's all the components of diagnostic safety. Now, all of this makes measurement a harder thing to do for diagnostic errors as opposed to a medication error when you know that it happened or did not happen. Infection happened, like a hospital-acquired infection, it happened, did not happen. For diagnostic error, it's not easy to tell when these things happen and when these things don't. So you have to do quite a lot of review to find out whether there is a diagnostic error or not. But using these rigorous approaches that we've developed over the last few years, what we found is diagnostic errors are happening in all settings: primary care, emergency care, radiology, pathology, lab, hospital medicine, community care, all settings. Most of the time, there are common conditions that are getting affected. In one study of 190 diagnostic errors in primary care, we found that there were 67 different types of clinical conditions that were involved, and most of them were just common conditions that primary care clinicians are seeing all the time. And that some of the times it included things like, not taking a history, not listening to the patient, not doing a physical exam, but it also involved not ordering the right test, not following up on the right test, or the referrals are getting lost in primary care. So a lot of these things are causing a difference. Thank you.
Yeah, thank you very much, Hardeep, for demystifying the concept of diagnostic safety, because I think it's quite important. I think we are now convinced that this is one of the biggest issues in patient safety that should be addressed. But coming back to what you said, Hardeep, communication to the patients in a timely manner and accurately is one of the critical components in the diagnostic process. And building also on the discussions that we had today in the morning, we understand that although we're trying to engage our patients actively in the policy-making processes, in the organizational design, engagement of patients and families at the point of care is lagging behind, unfortunately. We are happy to have in our panel Karen, who represents patient voices today. And I would like to ask you, Karen, to identify the barriers that are there from your perspective to ensure that the diagnostic process goes smoothly and efficiently. Thank you.
Thank you, Irina. So good afternoon to everyone. I represent the Consortium of Patient Groups in the Philippines. And a lot of the challenges we see is simply the fragmentation of the system. So patients find it hard to navigate the system to start with. So they don't even know what facility to go to, who type of doctor to consult with. So that in itself is part of the systemic issue. And another is obviously mentioned by Hardeep, the emotional factor. So a lot of times getting that diagnosis impacts a lot on the patient's anxiety. It causes stress and even cognitive impairment. The doctor is talking, but the mind cannot process. And so it makes it harder for us to participate in our own care and to be able to process that information. And obviously, there's also the issue of power imbalance. So patients feel very intimidated. They also have challenges in terms of communications and health literacy, trying to understand the medical jargon. And it's kind of critical because the diagnosis process is sometimes for a lot of patients, it's actually the first point of contact with the health system. And then when you are bombarded with all this medical jargon, it makes it harder for in low and middle income countries, you also need to think about how you're going to finance your care. So all this come into play. And so it's a lot of challenge to be able to ensure that there's safety in that process and there's clear understanding by the patient and making sure that at every step they understand, and that needs checking in with the patient. And if you need some more time for the patient, then ideally that should be something that we look forward to. However, there are also patients on a higher spectrum, so we call them patient leaders, and they're very adept at navigating the system. They pretty much well know their rights, etc. So these types of patients, you can engage meaningfully, and in fact, even look at them for solutions in terms of engaging them on addressing patient safety barriers and challenges. Thank you, Irina.
Thank you. Thank you very much, Karen. Yeah, it's quite clear. Another important element in the whole story is how the system supports patient engagement. And we have in our panel representative from the Ministry of Health Japan, Dr. Kurihara, and I would like to address the question to you. What are the concrete steps your Ministry of Health is taking forward to ensure diagnostic safety at the national level, including all those elements that we were able to discuss so far? And I will be particularly interested to see where do you put your focus? Do you put specific focus on the primary care, where we are facing the main challenges, including the point of the first contact between the patient and the healthcare system? So over to you, Mr. Kurihara.
Yeah, thank you very much, Irina. First, I differ why is primary care is specific. So compared to patients hospital setting, primary care operates with fewer resources per patient in patients. So in hospital, peer review among healthcare professionals helps detect and correct errors. So thereby maintain safety. However, in most of primary care environments, such peer review systems don't exist, leading to increased risk of error and risk of diagnostic safety. So this is particularly evident in the diagnostic process, which places a heavy burden on individual profession, especially physician. So to mitigate diagnostic errors, mainly there are three strategies one consideration. One point, the introduction of innovative technology and AI. Second, focus on education for healthcare providers. Third, enhance patient engagement. As you know, recently, advanced AI solutions have drawn significant attention, yet many institutions hesitate to adopt a unfamiliar system. So, in response, Japan has introduced financial incentives to encourage the implementation of scientifically proven technologies, thereby strengthen diagnosis safety in primary care. So, one of the successful examples in Japan, I want to introduce them. It is a remote diagnosis program where hospital-based radiologists provide subsidized expertise to primary care clinics through teleimaging. So, teleimaging consulting. So, furthermore, starting in 2025, government starts a clinic adopting AI-assisted diagnosis, CDSS, as a tool will receive if financial support bridges the gap between resource constraints and the need for accurate diagnosis. Looking ahead, the issue of rising patient number and aging population will remain a processing concern, with over 30% of its citizens aged 65 and older. Japan is especially at the forefront of this challenge. An overburdened healthcare workforce highlights the risk of compromised safety. By examining Japan's initiative to promote evidence-based technology adaptation in primary care, we make collectivity enhance of diagnosis safety, diagnosis reliability, and patient outcome worldwide. Thank you.
Thanks so much, Dr. Masaru, for elaborating on Japan's manifold strategies and approaches. It's good to hear from what I heard that you're taking patient engagement seriously. What I also found very interesting is that you're working with financial incentives. I think that's not very, very common. You don't see that very, very often. So thank you for that. So I think all of these statements have really helped us to understand the issue a little bit better. Or even maybe more so, and what is really important is that we need to know what we need to do, complicated sentence, to do to effectively tackle it. So thank you to all our panelists for painting an encompassing picture of diagnostic safety. This really helped us to set the scene. And so we will now move to the second part of our panel today. And actually, Dr. Masaru already helped us set the scene in a way that he elaborated on concrete measures. And we will now continue on that way. And we'll hear more about concrete solutions and actions. So how can we really improve and concretely improve diagnostic safety? Our panelists will be elaborating on that from their different perspectives. And yes, let us start with a very essential one. So, Karen, what can patients and their families contribute to fostering diagnostic safety?
Actually see three areas where we can participate, particularly the patient organizations, and by this I mean organized groups which have normally which are disease specific, or in some cases they could be cross-cutting diseases. For example, coalitions of cancer organizations or rare diseases, mental health advocates. So first is on collaboration and partnerships. So PAPO, our organization, sits in the Department of Health Safety, Patient Safety Technical Working Group, and we're working closely with academia. In fact, we were able to participate in a research with the University of the Philippines on the assessment of performance measures and indicators of patient safety in select government and private hospitals. We're advocating for the establishment of patient and family councils in each of the facilities because we think these councils are essential for building a system of continuous patient feedback. So earlier in the earlier panels, we talked about the lack of a platform for patients to give in that feedback. And to my second point on utilizing technology, we think this may be the time for PAPO to take the lead together with other stakeholders to introduce a very simple phone-based app where patients can give in their feedback, and PAPO will serve as the vetter for this information and work with the different stakeholders like the Philippine Medical Association, the Philippine Hospital Association, the Department of Health, PhilHealth. So it's going to be a multi-stakeholder engagement so that we empower the patients because part of addressing safety issues is empowering the patients to be able to articulate their concerns and feel that they have been heard. And then also importantly, as mentioned also in the earlier panels, is the importance of learning, right? We're not here to bash the facilities or the doctors, but ensure that no other patients or families suffer the same conditions because of these errors. And finally, education and advocacy. And I talked earlier about ensuring the patient's perspective are included in shaping healthcare policies. Last year, the WHA passed a resolution on social participation. And while it's similar to patient safety in 2019, these are it's a general guideline, but it has yet to be translated. And I think patient safety is a perfect platform to be able to kick off social participation because it's so important. We could have avoided so many heartaches and tears if only we could learn from this diagnostic safety errors.
Thank you very much, Karen, and thanks specifically to referring to the resolution that was passed last year. What is interesting, and I would like to highlight it here, is that at the same time the resolution was passed, the Global Patient Safety Report 2024 was published. And when we look at the implementation of the strategic objective number 4 of the report, that is totally about patient and family engagement, I think this strategic objective, the achievements, the progress in implementing this particular strategic objective was lagging very much behind. However, when you look at the core indicators, yes, we are lagging behind, but what was interesting to see that we are doing quite well in engaging patients in policy-making processes or in sharing information. For example, 80% of the countries that reported to the member state survey, they mentioned that they are sharing medical records with their patients in a very structured, organized manner. But when it comes to ensuring that we have patients represented in the governing boards of the hospitals, then we see there is no action. And I would add to that we don't have any data to confirm, to explore what is happening at the point of care, how patients are engaged in the shared decision making. And it goes much beyond diagnostic safety, but I think it's a quite important point. So just additional question to ask you. You mentioned establishment of the patient and family councils in the healthcare facilities. It's a very good institutional mechanism to ensure patients are engaged. But what do you think? What stops us from putting patients into the governing boards of the hospitals? This is a very concrete strategy that perhaps should not be contextualized. It's very straightforward and it can be implied in any setting. So what do you think? What stops us? We engage in policy-making processes, but governing bodies, we don't have patients there.
I think it's easier to get involved at the national policy level because it's broad strokes, but we have to go hospital by hospital in terms of establishing the family and patient council. I think there's still a lack of normalizing such a structure. So, there's really work to be done. And I hope that, we see our friends from the Philippine Hospital Association and the head of Philippine Medical Association. So that's something that we could advocate for. In fact, under the Universal Healthcare Law of the Philippines, there should be a civil society representative in all local health boards at the local and provincial level, but we have not done that for hospitals. I think it's perhaps for government hospitals, it will be easier because it will just take an administrative order. But for private hospitals, then that's where the challenge could be. So I like the point about making a business case for patient safety, saving hospitals and facilities a lot of money, because I think when you talk to the private sector, that is what will resonate. So thank you for the idea of how we will position the patient and family engagement councils. Because I think it also stems from the fear that, it's going to be, a venue to do complaints, we might get more litigation. And, sometimes the attitude is also, the patients don't know anything. So that's also a barrier. And so that's what we're trying to do in our organization. We're trying to build the capacity of our patient leaders so that we can sit and contribute meaningfully in all these technical working groups, in these councils. Because let's admit it, if we don't study and speak the language, then we can't move forward. So in 2023, we sent 25 patient leaders to a healthcare and leadership management course at the Asian Institute of Management. So that's very few. That's very few patient leaders. And we continue to struggle. Because remember, this work that we do is voluntary, it's pro bono, nobody gets paid. And for some patient leaders, they're actual patients who struggle with addressing their cancer, who struggle with financing their treatment. So it's not easy, but we're trying our best. And so we just show up. Every invitation we get, we show up. And we make sure that we prepare for that meeting and we read the advanced readings that they send. Or if not at all, we try to understand. So even for a topic like health technology assessment, we're training our patient leaders. It's hard to participate in the process, but we have to do it if we want to be, part of shaping policy.
Yes, thank you. Thank you very much. Yes, really worth applause, and thanks for your leadership. That's the only way, I think, to go forward. We have to identify leaders in our communities, strengthen their capacities, and just go together. Thanks a lot. You also mentioned very interesting point about engagement of patients and patient representatives in research. And I want to ask a question to Hardeep, because Hardeep is a leading researcher in the area of diagnostic safety. Do you have any insights into that point? What can we do? Can we do better?
Oh, absolutely. We've actually done several studies with patients. I mean, firstly, I must admit, first they were with us as subjects, but then they became partners. So as subjects, we studied narratives from patients who had been misdiagnosed. One of the most common reasons why patients who were misdiagnosed said they were misdiagnosed was, the doctor didn't listen to me. And that has consistently come up subsequently in other studies as well. Then we started figuring out, can we get data from patients around patients' complaints? Can we get data on safety, signals of safety within patient complaints? Most hospitals are gathering this data on whether it's, grievance, you call them grievances, complaints. There is safety signal in that. You just have to sort of look for it. Then we said, well, let's see if patients who are looking at their reports and notes online. Some of you probably heard of open notes, where in the United States at least, the medical record is becoming open to all patients to look at. So patients can log into a portal and look at their own doctor's medical records. So we did a study in which we said, we think you had a return visit. Let's say a patient was sent home and then they got hospitalized a week later. We identified some high-risk patients and we asked those patients, look at your medical record. Here's a way to evaluate your medical record. Tell us if you think there was a problem with your care. Whether you had a concern in your diagnosis. Sure enough, patients started telling us things. Then lastly, the last study we did was about asking patients, what research should we do? So we first asked researchers and other experts and organizational leaders, what kind of research should we do in diagnostic errors? And they had a whole laundry list of things. We prioritized it, great. And then we asked patients, what kinds of research questions should we ask as a field? And completely different, not completely different, very different perspectives on what patients thought that we should work on. So yes, we can gather a lot of useful information as a researcher from patients. Thank you.
Thank you. Thank you very much. And moving to the core of our agenda, Isaac, as you said, we want to explore what are the strategies that can be implemented at the organizational level to improve diagnostic safety. I know, Hardeep, we can talk for hours, but if you can summarize the scope of the strategies, and if you can also talk a little bit how we can balance what we should prioritize, or perhaps we should not prioritize and implement all of them in one go. So,
okay, all that in 5 minutes.
You.
All right. Okay. When I started studying this topic about a couple of decades ago, I found it really complex and hard, and I told you all the reasons why. And so people used to ask me, what's the best intervention? What's the magic intervention you could do for diagnostic errors, like we had for line infections and other things? And I came up with the one intervention that would have solved diagnostic errors. And that answer was divine intervention. That's the only thing that would solve this problem. Now, since then, I've become a lot more knowledgeable about what other things that we could do. And I'm going to talk about sort of this list from the National Academy of Medicine's report, Improving Diagnosis in Healthcare, which has a laundry list of lots of interventions. But I want to highlight a few that I think are worthy of discussion. One is about teamwork, and that concept has come up a little bit, especially sort of with patients, but also with nurses and other allied professionals, because a lot of the doctors think, well, the diagnosis is like my thing. What they don't realize is so many other people are involved in making a diagnosis, starting with the patient and family, coming into sort of the nurses. How many nurses here? Raise your hands. Yep. Nurses being involved, other allied health professionals. So all of these people involved. So we also say like diagnosis is a team sport. So that's one of the things, teamwork, that came up in this report. I know a lot of things have been said about education and training of health professionals, but let's be a little specific. One of the things we have been emphasizing is how can a clinician learn from their own practice and get feedback on their own cases. How many physicians or clinicians out here? Okay, how many of you have been told, oh, doctor, you made a mistake in the diagnosis that you can learn from? Raise your hands. How many of you have been told that there's a learning opportunity from a diagnosis you've made? Not a single hand here, right? We just don't find out about the cases that we miss, right? So we have now developed tools that physicians, clinicians in any health specialty can use to look and learn from their own cases. So that means you can either gather a colleague or a group of colleagues together to look at your own cases, and let's make it like a confidential sort of thing that we do. We can do that. And there's a tool called Calibrate DX that AHRQ and us, we sort of developed. It is all available on the website if you just Google Calibrate DX. The third thing I want to emphasize is organizational learning and improvement. In primary care, this is hard because we just don't have the infrastructure, the information systems, the governance structure that we need for safety improvements, as much as we do need a lot more. But there are tools that we've now developed that can help organizations gather from their data about safety, learn from that data, and put into place actions based on that data. One tool is called Measure DX. Again, if you Google it. And a lot of these reports are going to be in a WHO report that I think will come out soon that I hope Arina will highlight. So you don't have to sort of memorize them, but look for those words. Measure DX is one. And then we have an assessment tool as well. How do you know how you're doing as an organization or a clinic? Like, how do you know that the diagnostic safety practices that are being recommended, are you doing them or not? So we've created some sort of like a checklist. We call it a Safer DX checklist that we developed with a collaboration with IHI, Institute for Healthcare Improvement, which is also available freely online that people can use for a self-assessment. And most of the things are for learning and improvement. I think that there's a lot of emphasis in what do we do, what intervention do we put in place. I think if all healthcare systems and clinics were to do some sort of an assessment on their practices and figure out where their missed opportunities are and convert those missed opportunities into learning opportunities, I think we'll be able to find a lot of things go correctly. One last thing, and I think I'm out of time, but one last thing I want to mention. There was some discussion here about sort of business case and return on investment and things like that. All that is great. I feel that if you make somehow the business case being that the CEO or the CMO or the chief, the C-suite or the leader, financial compensation depends on how well they do for patient safety, I think we'll make a big headway. And in fact, this is not a pipe dream of mine. CMS, which is our largest payer in the United States, just released a structural patient safety measure that I would encourage everybody to look at. And one of the things they make sure they do, I was on the technical panel, so disclosure that yes, I was involved with some of this language. We make the C-suite leader accountable, and we say specifically about performance should be around sort of safety. So there is language in there in the CMS safety structural measure about making sure that the hospital leaders are financially accountable, that their performance is gauged by how much they invest in patient safety. Thank you.
Thank you, Hardy. Quite tricky to comment on because you mentioned so many important aspects. What stuck with me is your approach or your efforts to break open this black box with all the data which is missing and also let patients know what could be improved. And also the word or the expression divine intervention. So let's hope that your work and your fellow scientists' work and everybody involved will help us to that we can stop to rely or hope for divine interventions.
Can I just add, as a researcher, I must emphasize the last one, dedicated funding for research. If there are ministers out there, think about how much research you are funding in patient safety and diagnostic safety.
That's a good point. Yes, thank you. So, Dr. Masaru, could you let us know a little bit more about the specific areas your ministry is working on in order to reduce diagnostic errors?
Oh, yeah. Specifically in remote diagnosis, especially telemedicine, is an investor for the government. So, incentive for the clinician and big hospital to support the primary care clinic. In Japan, mainly medical setting consists of mainly small hospital and clinic. So it is important to support the for the incentive to the it is a very the high risk area of diagnostic safety. So incentive is very important. I think so.
Thank you.
Oh, okay. So I think in Japanese government also three as we know as we said three widely recognized pillars: patient engagement and technology, introduction of education. It is a widely recognized pillars. So the continuous. This is also these measures have proven effective principle. Merely introducing them without additional support often results in limited uptake. So implementation, not only implementation but also dissemination is very important for the government. So we call facilitation. So therefore, emerging critical catalysts to address this gap, there are two major facilitation for the Japanese government example. So first, incentive-based policies can motivate well-resourced hospitals to share best practice with smaller facilitation in regarding diagnostic safety. So in Japan, for example, financial support provided to institutions that assist in implementing patient safety measures, particularly those aimed at improving diagnostic accuracy. So this model benefits both the mentoring and receiving hospitals and clinics. So it is a specific incentive system in Japan. So other second, well-trained facilitators play an indispensable role in bridging the gap between theoretical knowledge to real-world implementation. So referring to Japanese experience, the CQSO program has been developed to incorporate Toyota's Kaizen, originally healthcare quality, original framework from Toyota Motor Corporation into the framework of healthcare quality and patient safety. It has already trained over 200 physicians and nurses, effective facilitators in Japan. They are working in Japan. So national subsidies help cover the cost associated with training and dispatching these facilitators, and thereby expanding access to expertise across diverse environments. In summary, while three measures are central to reduce diagnostic error in primary care, so this strategy must be accompanied by effective facilitation and strong incentive to implement and dissemination. By integrating these elements, we can foster a healthcare environment in which diagnostic safety is not just an aspiration, but a shared and enduring reality. Thank you.
Thank you very much, Dr. Kurihara. Yes, comprehensiveness of the approach is very clear, and I think that's the way to go forward. David, question. How we can ensure that in investments in patient safety in general and in diagnostic safety specifically considered by our dear and respected policymakers not as a cost but as an investment? We have elaborated, but I would like that you summarize that briefly and tell us what will be the call to action from your side. Thank you.
Understood correctly, then how do we sell improvements in diagnostic safety to people who have the power and the means to implement them? Well, we've seen that the costs are very substantial, but also that they're borne across the entire healthcare system. Well, the patient bears most of the harm from diagnostic error. The costs occur from both the micro level, in terms of the patient having to pay more, up to the meso and the macro level for health insurers having to reimburse more diagnostic care that isn't beneficial and is wasteful, and also the healthcare system having to spend more healthcare expenditure on diagnostic error and harmful care that results from this. Therefore, the cost savings that can be made across the entire healthcare system are a very strong economic argument for implementing change to achieve this. And these, within any healthcare system, already have existing levers that can be made to improve diagnostic error. So in terms of who should do what, we can see that at a cultural level, we need to have strong leaders to implement a culture of diagnostic safety, so that it becomes a regular part of clinical practice by healthcare workers when they're making a diagnosis and interpreting diagnostic results, to ensure that they have good diagnostic performance. And then for healthcare insurers and reimbursers to reimburse diagnostic care accordingly that is evidence-based and not wasteful in healthcare expenditure. Additionally, there are levers that are technological that should enable improvements in either we've seen the complex process of diagnosis to either improve the communication of diagnostic results to patients, but also to other healthcare workers who may need to follow up on a result in order to order further diagnostic tests or to not order diagnostic tests. And so we can utilize, for example, artificial intelligence or additional digital tools for digital health to improve the communication and alerts of diagnostic results to reduce diagnostic error and the costs associated with these. And then finally, at the clinical level, in the interactions between patients and clinicians, to verify what is the expectations of patients around diagnosis. Are they aware of what diagnostic tests, what results they will get and how to interpret those, and what that means for them and what they might have to spend accordingly, and do they wish to have certain diagnostic tests done altogether, particularly for example, older patients who may be at risk of being overdiagnosed with conditions that may not affect their health outcomes in the long or short term. So the costs are borne across the entire healthcare system, and policymakers should take this into account, because really any improvement in diagnostic safety has the potential to reduce diagnostic costs at any point in the healthcare system, and that should be a major selling point for having this as a priority for healthcare policymakers in any country. And indeed, many countries already have strong either national offices or national policies in place for patient safety. I know our own work on the economics of patient safety has been heavily supported by the Federal Ministry of Health in Germany, who are very invested in this subject, and that is equally represented throughout the world. So there are very good examples out there, and we'll hear more about those tomorrow in the presentation on the economics of diagnostic safety. So thank you.
Thank you very much. I think we have come almost to the end of our session, but before I hand over to my respected chair and facilitator, I would like to use this opportunity to talk a little bit about the global response from WHO perspective, because recognizing the importance of diagnostic safety within overall patient safety improvements and health system strengthening efforts, the theme of the World Patient Safety Day 2024 was chosen improving diagnosis for patient safety. And the World Patient Safety Day is one of the global public health days that WHO utilizes as a platform to raise awareness and to call for action around a very specific public health issue. So it's a very good opportunity to raise different issues for us every year. And last year we were able to bring to the attention the issue of diagnostic safety. Apart from developing a wonderful campaign that I'm sure most of you are very well aware, we have been working on the development of the technical report to bring together the range of interventions that will be important for the countries and partners to consider so we can improve diagnostic safety. And you can see on the screen the proposed new implementation model that is built on the existing frameworks, and where we are proposing to categorize interventions in 4 domains. And I think we have talked a lot about them. We have to do something to engage patients and our families in the processes. We have to build competencies of our health workforce. We have to improve systems and processes, and we have to do a lot around diagnostics and technology. So only by implementing all those interventions comprehensively at all the levels, we will be able to achieve better health outcomes. Our technical report will be out very soon, we hope within 1 month, that also brings together the research that is available as of now to prove and to build the case of diagnostic safety. And we worked very closely with Hardeep and his team on the development of this report. So thank you very much, and over to you, Mercedita.
Yes, thank you very much to our panelists, and we now open our floor, of course, for questions. You may approach the microphone.
Thank you very much, and we thank the panelists for delving into another very insightful area when it comes to the care of the patient. Of course, as we all know, without a proper diagnosis, there's no treatment, or there's no proper treatment. So diagnosis certainly is the beginning. If we don't get it right, we cannot get the treatment right. But I think part of it is as a result of the competence. And I'm happy that you've all buttressed on that. There has to be the competence. So I think it's important, just as I think Hardeep said, Doctor, clinicians assessing themselves regularly. But too often than not, I don't know if you came across this, but clinicians are assessed by other patients that the patient, other doctors that the patient went to see. And usually they are the ones who said you are misdiagnosed. You know, because when the patient is not satisfied, they go elsewhere. So I think it's very important that clinicians get the feedback. But overdiagnosing, underdiagnosing, I think sometimes is the issue of being too careful, of missing something out, especially if you have all the gadgets. If you have the CT scanner, you have the MRI, you have all. Now, you don't want to miss that one case. If you miss that one case, what is the consequence? So where do you strike the balance? In many of our low-income countries that we do not have some of all those resources, probably there is likelihood of underdiagnosis. Now, I want to put it across to you. You've done quite a lot of research, but I don't know if you did any research in low-income settings. Irina and then Dr. Adib, probably it's important to look at that, where we have primary care settings where the only health professional in that village is an untrained village health worker or barely trained village health worker who would have come across a patient who said he's having pain here or there. What impact, what information is that patient going to get? And sometimes that's all the information the patient gets for a number of months before the patient goes out to seek for health care elsewhere because it's not feeling better. And there would have been a missed opportunity. And WHO, I think these are areas that probably you need to look into with researchers so that low-income countries are able to build the capacity of village health workers, community health workers, community birth companions, so that early diagnosis is possible. Otherwise, we would be missing a whole lot of cases, misdiagnosing them most of the time, and they come with very severe problems. So that research bit, I think if you have done it, is good. Let's get the information. But if you haven't done, Adib, Gambia welcomes you to come and join us with WHO. We all work on this together, not just limited to the developed world, because quite a lot of these problems are really inherent in the developing countries. Yeah, so I think it's very important. And then refresher training for young people, young professionals, doctors, nurses. Nurses form the bulk of healthcare workers in some of our countries, you know, so due respect to them. They run the systems in many countries. But refresher training courses for young professionals is very important to improve on the diagnostic acumen. Otherwise, health professionals will be using the machines and they want to run everything, so the machines help us to do the diagnosis rather than our clinical knowledge. So I think it's important. Thank you very much.
Thank you very much. So the clarifications about competency of our healthcare workers and of course the availability of the resources. Would any of our panelists care to comment?
So I'll start first. Thank you for those comments. I must shamefully admit that most statistics that when I present about diagnostic errors, about the fact that how common it is, in the US, for instance, it's 1 in 20 US adults every year will get misdiagnosis just in the outpatient setting alone. Those statistics are coming from high-income countries. In fact, United Kingdom had a similar study, very similar to ours, and they also found about 4%, not 5%. We found 5%, they found 4%. Close though. We don't have good data from low-income countries. We did a report with WHO, with Irina's group, and they kept asking us, produce more data from low-income countries. I'm like, well, there is not much data from low-income countries. We just have not been able to do the research, and one of the things is, you need to get the data points across space and times, and measurement of the problem is really hard in this space. With that said, the scenario that you gave of somebody sort of out of the field to do the next step, there's two things. One is we realize oftentimes any healthcare professional, clinicians in particular, a bit overconfident because they don't like to seek help when they most need it. We've actually shown that in studies that clinicians will often not seek help despite the fact that they're in the middle of a very difficult situation. But if we can get good technologies, and this is where I'm not a fan of artificial intelligence as much, as you can imagine. I have not said it once up until now, but now I have to say it. There's one thing about AI that does sort of excite me is when there are these low resource settings, when a patient comes in, there are things that you can do in terms of triaging and referrals that AI can help you do. ChatGPT consumes a lot of resources, energy. My next session is on climate, and we're going to talk about energy, so I don't want to advertise ChatGPT. But a lot of times ChatGPT and other AI sources, if you put the right information in, it does give you the next possible steps. So in low resource settings like that, it could be one avenue to get patients to the right next step. which I think we need to sort of explore. And yes, I'll be happy to talk more after this session. I have to run to the other one, but I'm sure we'll be talking more in the evening. Thank you.
If I may just add.
Yes, yes, Ms.
It's also very much important when we consider strengthening one specific patient safety area, be that diagnostic safety, medication safety, or healthcare-associated infections, we have to have in mind that it serves as an entry point to the broader system intervention. So when we are talking about health workforce shortages, this is the responsibility of the health systems to ensure that you have enough doctors that will be able to diagnose correctly, accurately, and timely. And when it comes to the building competencies of health workforce, yes, again, focus might be put on the diagnostic safety, but I think addressing patient safety in general in the educational curricula or training resources will be extremely important, and incorporation of the development of the soft skills like teamwork and communication or patient engagement will be extremely important. So diagnostic safety may serve as an entry point, but whatever we do, I think we have to consider broader system improvements and broader system interventions that will definitely be beneficial for improving diagnostic safety.
All right. Yes, you have something to say as well?
Just a very short follow-up comment about feedback and how that could be leveraged as an important, and not necessarily at the individual level, but one way of perhaps benchmarking diagnostic performance is we're reporting that at a regional level, and instead of pinpointing maybe diagnostic error at an individual's practice, but if you can see there is a large variation in neighboring communes or regions, and there's no explanation for that in that they should be similar, that may be one way of feeding back that patterns of diagnostic practice are different and may need addressing. And it's not necessarily instilling a blame culture, but you are providing the information back to the prescriber to say that, okay, your rates of prescribing antibiotics are too high, or your rates of diagnosing sepsis are too low. And that could be a means of improving diagnostic safety by providing that more ecological or macro level feedback statistics on rates of diagnostic performance. So thank you.
Okay. So we proceed with the next question.
Thank you very much. Good afternoon, everyone. I'm Deputy Minister of Health and Social Affairs of Georgia. Well, in Georgia now we talk and think, and I would say work too much about the issue of medical errors, and also on the issue of how to distinguish those medical errors that could be more or less allowed within the frame of professional activities from those errors, but from truly professional negligence. So that's the question, the main question for us. So could you please tell us a bit more, I mean any one of you, on this issue, relying on your own or your country's experience? Thank you very much.
It's more like how do we draw the line, identifying such and reporting such. Anybody from the panel, please? Or even our session chairs, if any?
Maybe I will try. It's a more generic question. From WHO perspective, we are promoting establishment of the patient safety incident reporting and learning systems. So all incidents can be reported in the systems, and then you can learn and pursue proactive risk management approaches. And with incident reporting and learning systems, we are proposing a minimum information model for patient safety that contains a basic information that you should collect about the incidents. And in that model, you can see how we categorize different patient safety incidents that can be the first step to help you to categorize them and they deal with them accordingly.
Thank you, Dr. Irina. Yes, Dr. Singh?
Just to quickly, this gets hard because you're getting into sort of clinician competence areas. I've analyzed, I don't know, like thousands and thousands of cases, and most of the times it's, you know, some system issue, process issue, but we do find cases where this is bordering negligence. There's actually people who come and talk to me about some cases that have happened, and I tell them, you're going to lose this case in the court of law. There is no defense because this is negligence. It takes time and sort of experience to go through these cases over time. So that's why I'm like a researcher, so I can sort of do it. But the more the people who get into this topic and understand diagnostic safety will be able to make that distinction better. Because in the just culture, we need to sort of stay within sort of what we can do. But I agree, accountability and negligence could be important issues for some of these cases.
All right. So keys are data collection and analysis. Yes, sir?
Actually, I'm Dr. Pichmani from South India. Of course, I'm a senior practitioner. I've been practicing for the past 33 years. It was nicely pointed out by Hardeep Singh, there was a lot of errors from the clinician side, clinician's aspect of it. Especially recently, doctors do not allot time to investigate, to ask history, proper history taking and so on. And I think it should be made into curriculum. And I think somebody has to push it into the curriculum and that in the studying itself, all these patient safety, all those things to be incorporated into this. I think WHO can influence the various countries on this, and it should be made into the curriculum. That's what I feel. Even the nursing, every part of it. If that could be made, I think many of the things can be solved. And because people think when they enter into the medical school, they think they are correct. And when they come out, they are the bosses. And that's wrong actually. As you gain experience, you see many a times we do a lot of mistakes. And if we just go back, we could have done much better job. And this is happening more so recently. I see many of the juniors, they don't even realize that they are committing errors and so on. That's one aspect of it. I think this is one suggestion to organizations like WHO when they are concentrating so much on patient safety and advocacy. I think you can influence the governments to do these things at the policy level.
All right. Thank you so much. I know there are members of the academy here present. And last comments from our panelists and session chairs.
With you more. Just a statistic I'm going to tell you. In our study of diagnostic errors in primary care, the one I talked about earlier, 190 diagnostic errors, 80% of them were related to history and exam and ordering tests based on your history and exam. It was the data gathering and interpretation from the patient. We kept talking about this issue, but unfortunately we're seeing the same thing. Sort of the patient perspective of doing the history exam is neglected. I did my medical school in India where we were taught like 70% of the diagnosis will be made by history and physical alone. But we're not at that step yet, and I think we need to sort of rethink that. And I think we've emphasized that in the WHO report as well.
Yeah, from the global side, Dr. Pichumani, one of the strategic objectives in the Global Action Plan is related to building competencies of health workers, and we specifically emphasized incorporation of basic principles of patient safety in the undergraduate curricula and also in the training as part of continuing professional development. And WHO developed many years ago very comprehensive WHO patient safety curriculum guide that gives quite a comprehensive overview of what is patient safety and what are the key elements that should be taught to the undergraduate students. For the moment, we are trying to revise that because we want to emphasize competency development, not only knowledge building, but competency development. And another thing we really want to push is that the curricula is taught in the interprofessional environment where different professions can sit and learn together what is patient safety and how they can do the improvements. In addition to having the technical material, we are trying to advocate for institutionalization of the patient safety curricula and also linking the education and training to performance management of healthcare workers. The uptake from the countries is not great. It's much better than the uptake of patient and family engagement, but still there is a very long way to go. So thank you very much for the question.
We will take in one last question Yes, please.
It's again more of a comment. So Luke Slavomirsky, again, co-author of the Economics of Diagnostic Safety report. It's great to talk about curricula and competencies, but I think what the gentleman is referring to, and what we talk about this in the report, is the hidden curriculum. It's the way our clinicians, particularly our doctors, are socialized. I think you put it really well. They come out thinking they're the boss. And if you think you're the boss, you're not going to play as a team member. You're not going to play as a member of a team. So this is a really tricky thing to address, but I wondered if anybody had some thoughts or ideas about how we can start changing this at a systemic level.
All right. Yes, Dr. Singh.
Because I know we're out of time. We've looked at cognitive psychology literature to sort of figure out how you change behaviors of people. And one of the best things is learning from feedback. Clinicians have to look at their cases every few months to see how they are performing. And that's how they are going to change and realize, oh, I was actually wrong in this. I mean, there are other clinicians who don't like to talk about this topic very much, and you often don't want your supervisor to come and tell you that you made a mistake. But if you can get that right atmosphere, which is non-punitive, confidential, sort of microsystem in which clinicians can talk to each other about the errors they make, I think it changes behavior.
And just one small addition. I think we have never been taught in medical schools soft skills, right? So if we are able to incorporate soft skills development, things like teamwork, communication, patient engagement, safety culture, human factors, I think we will be able to reach to the point what Hardeep was referring to. And as I mentioned, I think bringing education into interprofessional environment is also very much important, so we can deal with hierarchical systems. So really we can bring all healthcare professionals who are going to work in the team to learn together what is patient safety about.
All right, thank you so much. You can still send your questions through our events app. But now I'd like to call in to wrap up our session, Dr. Isaac.
Yes, thank you so much. Okay, it is my pleasure to present the core messages. As we all know, they are the essence of such a session, and we as chairs will have the honorable task to also present them at the end of the day to the plenary. And even more importantly, they will also be presented together with the messages from the other sessions, of course, to the audience tomorrow, including the high-level representatives, which will be present. So this will be an excellent opportunity for us to demonstrate the relevance and the urgency of the topic of diagnostic safety. So let's do our best and let's try to seize it. We did our best and tried to capture the essence of the session as follows with 6 points, at least for the time being. Maybe we'll talk about that again later. So I'm going to read them. The first point would be that incidents related to diagnosis account for 16% of preventable patient harm globally. Secondly is contributing factors range from system vulnerabilities, such as access to care and tests, fragmented care and insufficient workforce numbers, all the way to cognitive challenges in clinical decision-making, as well as health literacy gaps and communication failures. Thirdly is addressing these challenges requires a multifaceted, comprehensive approach. I think we heard that just some minutes ago, at all levels, spanning across several domains, including patient engagement, health workforce, system and processes, and diagnostics and technology. The fourth point would be that establishing learning systems and fostering research are the prerequisites for effective and sustainable improvements. And this is also important to contextualize and prioritize interventions based on the country-specific context and clinical setting. Adapting interventions and messages is key, as we all should know by now. Then the fifth point is, again, all the time very important, strong leadership. It's just essential to reducing diagnostic errors and achieving significant cost savings. And then the last point would be there is also a need of a global response. to address diagnostic safety, for example, with the World Patient Safety Day in 2024, where the theme was improving diagnosis for patient safety, and as Arena has showed us just earlier, proposing a new action-oriented implementation model. Yes, we hope that this more or less catches the essence of our panel today and that it will leave a lasting impression with the audience tomorrow. I think or our panelists made it very clear that diagnostic safety remains an urgent task, and I would like to thank all our panelists of today's session for your valuable contributions. Thank you so much. And yes, I wish you all a successful and interesting continuation of the conference, and we hope to see you again soon. Thank you so much.
Good afternoon. We will resume with our second round of breakout session by 3 in the afternoon. Again, we will resume with our second round of breakout sessions by 3 in the afternoon. Thank you. Good afternoon. We will resume with our second round of a breakout session in 5 minutes. Again, we will resume our program in 5 minutes. Thank you.
Good afternoon, everyone. I hope everyone can settle down and so we can begin the next panel discussion. I think we have some more people outside, if they can begin to settle down as well. All right. Good afternoon. I am Dr. Diana Tamandong La Chica. I am an associate professor and a program head for the UP, University of the Philippines College of Medicine Program for Healthcare Quality and Patient Safety. And I will be your process facilitator for the panel discussion 2.2, Investing in Patient Safety for Sustainable Healthcare. I know in the past panels and plenaries, we've been hearing about financial investments towards patient safety. Obviously, that's very important. But in this session, we will be exploring the full spectrum of investments that can be done for patient safety and for sustainable healthcare. In fact, for this session, it's going to be emphasizing the non-financial investments that are equally critical in making sure that we sustain our healthcare quality and, of course, upholding patient safety. So we are honored to have Dr. Jennifer T. Pagio, Associate Professor from the University of the Philippines College of Nursing and a member of the Technical Working Group for the Patient Safety Program of the Philippines, chairing this important discussion. Welcome. I would like to say that we're very privileged to have 4 experts from different countries and I'm sure different contexts who will share their diverse perspectives on this topic. And I'd like to call them one by one, starting with Dr. Vijay Agarwal, President of the Consortium of Accredited Healthcare Organizations in India. Dr. Kazumi Tanaka, Professor and Chairman of the Department of Healthcare Quality and Safety, Gunma University Graduate School of Medicine in Japan. Dr. Eugene Liu, Chief Sustainability Officer of the National University of Health System, Singapore. And of course, Ms. Charlotte Corti, Co-founder and Healthcare Advocate of the Health Consumer Advocacy Alliance in New Zealand. So we anticipate a very exciting and valuable discussion on the strategic investments that we need to do for patient safety. I will now give the floor to our very able session chair, Dr. Pagio.
Good afternoon, everyone. How's everybody doing? Still full, still excited for our common advocacy. Thank you, Diana, for that very generous generous introduction. I am pleased to present to you just an overview of what we're going to be talking about this afternoon. We are privileged to have the panel of speakers who will be expounding on the different key areas for sustainability. It's been almost 30 years since the Institute of Medicine report, and the focus has been strongly on what we can do to mitigate the impact of patient safety. And since then, there have been countless policies, strategies, and initiatives that have been designed and implemented to address the gaps. There have been many wins for patient safety. All the policies that we've heard this morning, the unique approaches depending on the culture, resources, and also, depending on the settings. But although there have been countless wins, there also have a lot been opportunities and resources wasted. Resources in terms of physical resources, human resources, even ideas wasted when we don't engage with the team or even the patients. So our session objectives for this afternoon are as follows: to discuss the importance of investing in human resources, specifically in the availability, optimization, and capacity building. Second, encourage investments in improving the environmental sustainability of healthcare. Third, emphasize strengthening patient engagement and shared decision-making. And fourth, encourage alignment of institutional and national policies with global patient safety standards. Today, we'll cover how we can invest in patient safety to ensure that healthcare services meet the current needs without compromising the ability of future generations to access care.
So what do we mean when we say sustainable healthcare? Sustainable healthcare refers to a system that delivers safe and high-quality care while we minimize the environmental, social, and economic impact. We've all seen the horror stories of piles and piles of waste, loss of lives because of the pandemic. And sustainable healthcare hopes to mitigate that. Sustainable healthcare integrates policies and practices that balance environmental responsibility, economic efficiency, and social well-being to create a future-proof healthcare system. So these are the key principles of sustainable healthcare, which includes environmental sustainability. Eugene will be talking more about this, reducing carbon footprints, minimizing waste, conserving our resources, and adopting eco-friendly practices. We'll also touch a little bit on economic sustainability. Like what Diana said, we might not be talking a lot about the finances, but remember, any material we save, every health human resource that we maximize and invest on is equivalent to dollars and dollars. Ensuring financial viability through cost-effective care, efficient resource allocation, and reducing unnecessary healthcare expenditures while maintaining quality. Third is social sustainability, promoting health equity, improving access to care, and addressing social determinants of health to ensure that healthcare systems serve all populations fairly. Charlotte will expound later on engaging patients in this area. Resilient and adaptive systems, where we strengthen healthcare infrastructures to provide or withstand public health crises, climate change and demographic shifts, and preventive and value-based care focusing on disease prevention, population health, and patient-centered care rather than reactive and treatment-focused approaches. Kasumi and Vijay will also expound on workforce later on. But the challenge is here. How do we invest in patient safety while we ensure sustainable health care? Investing in patient safety requires a balanced approach that enhances care quality, reduces harm, and optimizes resource use. There are many initiatives available and many initiatives have been proposed in order to translate that investment into sustainable health care. Let me go through them quickly. That strategic balance for investing in patient safety and sustainability can be achieved through preventive and value-based care, shifting from reactive to proactive care by focusing on disease prevention, early detection, and chronic disease management. It can be as cost-effective as existing vaccination programs. Doesn't need to be new, but needs to be more efficiently delivered. Workforce training and ensuring safety culture, investing in continuous education on patient safety practices, looking at strengthening team-based models of approaches, and training other members of the healthcare team, and ensuring what we were talking about just previously, reporting errors to lead to learning rather than punishment. Third is smart use of technology. This doesn't just refer to AI. It can be low-cost, high-impact technologies like SMS. Who among us do not own a cell phone? These are SMS-based reminders in low-income countries, but also use of telehealth, mHealth solutions to reach underserved populations while minimizing hospital congestion and focusing on health education. Adopting e-health records, and of course, utilizing AI for predictive analytics for early warning systems. Environmentally sustainable healthcare practices by reducing wastes and optimizing the supply chain. Simply making sure of medications that are available, medications that are safe. These are some of the measures even the Department of Health has been strengthening, Department of Health of the Philippines has been strengthening over the last couple of years, making sure that the supply chain for medications is optimum, that we would not be at the mercy of not having available medicines for the population. Implementing eco-friendly sterilization techniques, reducing medication errors, and such. Another is cost-effective patient safety interventions, looking at low-cost but high-impact safety protocols, as simple as the WHO Safe Surgery Checklist. or hand washing procedures. Like one of our colleagues here mentioned, how can we focus on infection control when there isn't even water? And having that, making sure that the basic needs are met, is focusing on patient safety and making things sustainable. Standardizing hygiene compliance, and of course, data-driven decision-making and surveillance. And of course, community and patient engagement. In community and patient engagement, we improve and involve patients by engaging them to participate in literacy programs and shared decision-making, strengthening primary care networks. I remember yesterday during a policy dialogue in the University of the Philippines, our main speaker was talking about when he was in nursing school, he would still be talking about primary care. And that was decades ago. And up to now, I don't think we have realized the full potential of primary care, particularly for countries that are on crisis mode, that we need to attend to the here and now rather than focusing on what lies ahead. Developing culturally relevant patient education and safety practices and promote self-care strategies. Lastly, is policy and governance for sustainable patient safety. This includes developing the national patient safety policies, making sure that these policies are aligned with international agreements. I particularly appreciate the message earlier that WHO can put out the policies informed by data. They would not say that this is the thing that you need to do, but it is up to us, it's up to the ministers. Look at the context. How do we apply this in our resource? In addition, establish public-private partnerships to invest in patient safety. And lastly, strengthen our regulatory frameworks to ensure adherence, safety standards, monitoring, and evaluation. So, I'd like to welcome the esteemed panel for this session to talk about work optimization, environmental sustainability, patient engagement, and workforce optimization. Thank you very much.
So good afternoon, friends, and my proud privilege to welcome you on behalf of my organization, CAHO, the Consortium of Accredited Healthcare Organizations from India. So, where is my... So guys, what a topic, this patient safety, which has been going on not just for the last few years. It has been going on for the last 2,500 years. Hippocrates created the Hippocratic Oath of first do no harm. And since then, I think we have been struggling with this entire idea of avoiding harm while providing care. And right from that, now even to WHO, we are all talking the same language. But the avoidable harm continues. So what is it that, and we are all aware about the degree of the harm. It has already been spoken to. Let me skip that how much harm is there. And what kind of actions various countries could take to address this has been the legislations, the regulations, and then the latest kid on the block had been the accreditation. The accreditation was definitely one of the things that we looked at with great expectations that it will be able to reduce medical errors. But why is accreditation not making the desired impact? That's the big issue. Mainly the staff, we feel, is often overviews this as something which is more like a compliance without commitment to the underlying principles. The standards of accreditation it cannot be like one size fits all kind of a thing, so may not be applicable to everybody. But most importantly, its very nature that it is a periodic assessment. So its cyclical nature of the accreditation visits, it creates we call it a preparation syndrome. And then there is a limited evidence that accreditation has impacted the patient safety issues. So with all that, what do we do to make it impactful? That's where at CAHO, I think we decided to rock the boat, and we said that we must analyze as to why is this happening, what can we do. So first thing that we realized, that accreditation bodies have an army of people whom you call as assessors. But we realize that we do not have an army of quality implementers who should be present in every institution. Every institution started becoming dependent on an outside agency to help them understand accreditation during the accreditation process, get the stamp of accreditation, and move on. But what was required is that we have to have people who understand the standards and objective elements of the accreditation present right in their own organization. So we started training people for a basic 3 days and a residential 4 days program of an advanced certifying professionals for quality implementation in hospitals. What it became different was that out of the 100 people, let's say, who were trained, 1/3 were doctors, 1/3 were nurses, 1/3 were administrators, technicians, and all the other people. So for the first time in the healthcare ecosystem, the boundaries of hierarchy were broken, and they were all sitting together to understand about quality. And over a period of time, we have trained more than 6,000-7,000 of these quality professionals who became eventually, I would say, quality ambassadors in our country. We also realized that over a period of time, accreditation was becoming more like an administrative and a quality manager's work. The quality has to be practiced by everybody in the healthcare ecosystem. So we created forums which will address doctors, nurses, pharmacists, dietitians, rehab specialists, housekeeping, you name it, and every category of people have to be approached. So we created these forums, and what were we doing in these forums? We said, please try to understand best practices. Do not try to understand how will you pass the exam of accreditation, but first understand what are the good practices that you need to have in your departments. We need to have a repository of the adverse events, the near misses in every department and every function. They need to be aware about it. They must understand the problem or the importance of communication, of empathy. We do an award and recognition of all these kind of segments of people. So we are trying to say, and I feel that this is what is required all over the country, all over the world, that we have to change the focus from merely being evaluated for the patient safety issues to start focusing on good practices which have to be followed in every department and function. And of course, we realized that one of the most important stakeholders was the patients themselves, which we have been ignoring. And that is where we started the Patients for Patient Safety initiative, which has now been converted into a Patients for Patient Safety Foundation. And along with this foundation, we started training them and learning about patient-reported experience measures, patient-reported outcome measures, patient advisory councils. So as we talk, more than 40 hospitals in our country have started the patient advisory councils. Their experience is now shared with each other. Patient education is a huge issue. Things like consent forms. Now, typically, no doctor can have adequate time to explain how I'm going to do the knee replacement, etc. So we are now launching a consent resource kind of a app and a center where the education about that procedure is given, and the consent can be given in multiple languages, whatever language, both in an audio format, in a video format. That's the power today of artificial intelligence and technology, and that's where it can be used. Then what we also realized that to achieve all this, we started getting into the strategic collaboration. Collaboration which was even with our government bodies, with hospital networks, we'll talk about it, industry, lot of industry who have been kind of on the periphery of reaching out to the hospitals. We engage them with the whole idea of that you should be coming forward for making patient care safe. Then academic alliances with various academic institutions, getting into the hospital administration students. Now we are trying to get into the medical students and the nursing students. And of course, the global partnership, let's say with organizations like ISQA and ESQA, and must say that on every first Tuesday of the month, we have a CAHO ISQA webinar, which is being attended by people from more than 20-25 countries. 52 webinars have already taken place. We started this concept of Centers for Quality Promotion. These Centers for Quality Promotion are hospitals which are already accredited, but also have CAHO-trained quality implementers, and they are responsible for reaching out to other small and medium hospitals to spread the wave of quality. They, along with the CAHO ISQA webinar on every first Tuesday, that has been made into a monthly quality meeting where we want other departmental people, the clinicians should also come and listen to, otherwise they will never understand what is PREM and what is PROM, they will not even know. We did a survey, I can tell you that even the Global Patient Safety Day, which is we celebrate on 17th September, out of the 100 clinicians, more than 90 did not know even about the existence of such a day. So that shows that what is the kind of a distance between whatever is being talked in forums like this and what reaches the last mile. Then we, of course, we are very important that we brought out for the, developed a capacity building programs. And capacity building was, again, as we were training these quality implementers, we realized that nobody can be made a quality implementer in 3 days or 4 days' time. You have to have multiple kind of a training programs, webinars, events, and including then over a period of time, it started with this mid-level people, and now even the CXOs and CEOs boot camps are being organized. We organize national, regional, and local events. And then we are strengthening the research ecosystem. We also realize that there has not been much research in these issues of patient safety. We sometimes just imitate the learnings from one of the high-income countries, which may not be necessarily applicable to the resource-constrained settings and low-income countries. Things like even central air conditioning versus the split air conditioners and many things can be researched. Then promoting technology adoption we feel has been the game changer. This year will be our 10th annual conference to bring technology and healthcare people together. So we organize an event to recognize early adopters by the hospitals, and we showcase that. We promote startups and innovators. And for example, I would say that we come out with problem statements, and now one of the persons who has done the automated vital sign monitoring, contactless vital sign monitoring, patient is much safer when he is in the ICU, but the patient becomes very vulnerable when he comes out of the ICU, gets into the HDU or into the ward. Now with that contactless vital sign monitoring, that application is being used today by more than 15,000 beds in our country and has shown that the incidence of code blue, that is sudden death, has decreased by 80 to 100%. So that's the kind of a power we find of recognizing and promoting these kind of disruptions. Another thing we realize is that we have to train people for leadership. And the leadership, when we talk about it, is not about leadership at the CEO level or the CXO level, who are only bothered about their balance sheet. We need to develop the leadership at every department, function, every nurse ward, every nurse supervisor, every department needs leadership. And therefore, a lot of these leadership programs that we do, what I will say is to make a significant impact, we have to try and train about how do we change our medical, nursing, and paramedic education. We have to do an ongoing safety training program throughout the professional careers. Technology adoption we talked about, but I feel that the most important thing is that we have to re-engineer this process of accreditation. Accreditation, as it is going on, has become a kind of a double-edged thing, that while you have developed the people of the quality managers and the administrators have become quite tuned to understand, because there is a financial incentive that you get when you are accredited, but it has not gone down to the clinical departments. Just like we have ignored the patients, I think we have also been ignoring our clinicians, doctors. They are the ones who have to ultimately deliver quality, And somehow or the other, we have to bring them into this fold and to make them understand that the oath they took 2,500 years back through Hippocrates still is relevant, still we need to do something. So with that, thank you very much. I invite you to join this movement. Ours is not an organization, I call it a movement to shake the boat. Do not just depend upon accreditation. It is not delivered to a country like United States, where after spending, I think, $4 trillion, and still being the accreditation body being there for 80 years, and still the deaths due to preventable medical errors being the third leading cause of death, I don't think inspires confidence in us. So thank you.
So afternoon, ministers, distinguished colleagues, and thank you for the time to share with you about environmental sustainability in healthcare. I think we all recognize that the global warming and climate change will have a significant impact on health, but we also have to recognize that healthcare itself has a significant carbon footprint. So in healthcare, we both need to prepare for the impact of climate change on health, but we also need to reduce our own impact on the climate and reduce our carbon footprint. And it's been estimated that as much as 5% of the global greenhouse gas emissions are from healthcare. So Healthcare Without Harm is an organization that had estimated the world's carbon footprint due to healthcare. And if we were to just continue with business as usual, it would triple by 2050. And that's not surprising. We have a lot of energy-intensive facilities, we use a lot of drugs, products, and equipment, and we generate a lot of waste. But actually investing in energy efficiency not only reduces your energy consumption, it actually improves your energy resiliency, and that contributes to patient safety in your hospitals and clinics. And so we have to recognize, I think, we have a duty of care, not just to our patients, but also for our planet. So we need to think of sustainable healthcare as good care. And the Institute of Medicine had a few years ago recommended that sustainability now be considered a domain of quality, together with the other 6 domains, including patient safety, patient experience, and equity. And so when we look at healthcare now and evaluate it, we can look at its value in terms of quality and its outcomes for patients and population, not just in terms of cost, dollar cost, but also in terms of the carbon. So Jen had mentioned earlier about value-based care, and I think the key aim is to stop low-value care that has little or no benefit to patients. So the estimates are that as much of 20% of healthcare worldwide is of low value or even harmful to patients. So in the Choosing Wisely strategy that's widely applied, the aim is to optimize the use of resources, and by directing care to patients that truly will need and benefit from that care, actually that improves patient care quality. It also helps to prevent patient harm by avoiding unnecessary care. And it also enables your manpower, financial sustainability. So they're all aligned. In my own system, we have an appropriate care plan, and one of the key aims to prevent unnecessary tests. So such as a repeat HbA1c test within 3 months, or very frequent point-of-care glucose tests to stop some of these routine pre-op tests. Infection control is a big concern in patient safety and quality, but we do need to look at evidence-based infection control and patient safety measures. And I think most of all, we need to listen to our patients and tailor care for their stage of the care journey and to stop futile care. Patients know what they want, but they often don't get a chance to tell us what they want. Some very specific choices you could make in your healthcare systems. One is to address the use of this drug, desflurane. It's an anesthetic drug, and per hour of anesthesia, its carbon footprint is at least 50 times that of sevoflurane, or even 100 times that of propofol. So these are comparable anesthetics, which actually also happen to be much cheaper than desflurane. So we took a bit of time in my hospital to cut it down, but over 3 years, we were able to reduce its usage by 97%. But one of the lessons we learned was that communication is very, very important. And we had to communicate carbon impact in a way that the doctors could understand. And so if you look at the picture on the right, that's a desflurane vaporizer on an anesthesia machine. We stuck labels on all of them which communicated the carbon impact of an hour of anesthesia. So that's like driving 500 kilometers in your car. And if you use that fullerene for 10 hours, that's like driving 5,000 kilometers in your car. So that's further than the distance from Manila to Singapore. So that's to put it in some perspective. A second drug that's very very good to reduce is the nitrous oxide. So it's a very old drug, but it has many side effects. And in fact, stopping the use of nitrous oxide is safer for the patient in many forms of surgery due to its side effects on neural conduction or in enclosed gas spaces. So we turned off the nitrous oxide pipelines in our operating rooms, and residual needs were met from small portable cylinders directly mounted on the anesthesia machines. Another lesson we learned then was that actually, even as we were doing this shutdown, we realized that 75 to 95% of the nitrous oxide that we use in our hospital never actually reaches your patients, never reached our patients. It's all lost in pipeline leaks. And so even if you didn't change your clinical practice too much, just using cylinders instead of pipelines can reduce a lot of the greenhouse gas effect. Now, what about the role of leadership? I think leadership, particularly at ministerial level, is crucial in having a national commitment to decarbonizing healthcare, and also in spreading the message and communicating that it's actually quite an urgent problem. Now, as we invest in sustainability, I think we must keep to the principle that Vijay just mentioned, to first do no harm. And so as we work on a strategic planning to incorporate sustainability in healthcare, we do need to assess projects for their potential impact on patient safety, and also to assess for any harm on the planet, because not every environmental sustainability initiative actually benefits the planet. So we do need leaders to bring our teams together. Most work requires multidisciplinary teams for collaborative implementation, and leadership has a key role in bringing people together and also bringing data together. So we do need to leverage on technology and IT for this. But probably I think one of the biggest investments is to invest in education and training of our staff. And then lastly, we can look at putting environmental criteria into our procurement, especially at national level or group procurement. Yeah. Just one tool, so carbon accounting is a basic tool that is very useful in guiding our environmental sustainability drive in healthcare. To take it a bit further, you could look at also the marginal abatement cost, and this can help you prioritize investments for sustainability. So a marginal abatement cost studies the dollar savings or costs per ton of carbon that's reduced. And if I just share a little bit about this graph, if the x-axis would represent the amount of carbon that you could save in tons of carbon per year. So the wider the bar, that's the more carbon that you save. The vertical axis, so those bars, if it's the bars below the y-axis, that means you save carbon, you save dollars for every ton of carbon that you abate. Whereas for the bars that are above the x-axis, you incur some cost for every ton of carbon that you abate. But even if it did incur some costs, you could put it in perspective and compare it with the prevailing carbon tax rates, so you get some proportionate sense of the cost. Yeah. So I'll just summarize by saying that the environmental sustainability is very much aligned with manpower as well as financial sustainability, and very, very aligned with patient safety. Thank you.
Tēnā koutou katoa, honourable ministers, my esteemed colleagues, and distinguished guests. It is a privilege and a huge responsibility to talk to you today on the critical issues of patient engagement, patient safety, and the prevention of avoidable ongoing harm. My journey has not been easy. The harm I experienced in our health system left me permanently disabled. This has been devastating not only for myself, but also for my family. Harm can last a lifetime. It can utterly shatter families and individuals. Due to my injuries, travel is not easy, but I came here to put a face to the preventable harm that continues without effective action. Systemic failures must be addressed, and preventable harm should not persist. Behind every statistic is a person, a loved one, and a family whose lives may have been irreparably changed. People are more than just numbers. I was one of those data points, and I'm still reeling from the effects of what I experienced. To achieve safer care, we must foster environments where patients feel secure in raising concerns, and healthcare workers are empowered to speak up without fear of retaliation. The fear of blame silences voices, and silence can be dangerous, and in some cases deadly. Research has shown that when patients are actively involved in policy development and the creation of safety initiatives, medical errors decrease and outcomes improve. Yet far too often, their voices are sidelined. Retrospective harm should not be hidden. It needs to be acknowledged and addressed appropriately. We must shift the focus from blame to learning and cultivate a culture of psychological safety for both patients and providers. It's time to move beyond token consultation and embrace genuine co-design with consumers, those who live the realities of our healthcare systems every day. In 2019, New Zealand undertook a national restorative justice process to listen and learn from those affected by surgical mesh harm. This was a first for our country, a new way of listening. It unearthed a culture of bullying, power imbalances, and systemic failures in healthcare, which are mirrored worldwide. It enabled our health entities and healthcare professionals to undertake a reflective process, to identify changes that needed to be made within their own environment, but also across the entire health sector. We need to and must change the way we respond to medical harm to ensure that patient engagement is both meaningful, relevant, and leads to better outcomes. It is important to recognise the holistic nature of our complex health systems and services and view these not as one-off individual transactions and procedures or being reduced to dollars, numbers, and statistics. Ask yourself this question: do our current medico-centric models of healthcare really work well for patients? Who do they work well for? Each of us has a voice and a responsibility. I urge you to proactively engage with patient-led groups, with patients, their families, and health professionals. Find out what they know about our health services. Every conversation is an opportunity to learn. It is not about us and them, it's about working together. My message to you is that it is easy to present a polished narrative on paper, claim progress, and that concerns are being properly addressed. However, transparency is vital. The reality requires more than just words. There are 5 key points I would like you to take away with you. Properly invest in patient safety. It is not just essential, it is fundamental to creating a sustainable healthcare system. Prioritise prevention and early intervention. It is critical to empowering patients and strengthening engagement in their own care. Strengthen data capture. Invest in registries and shared monitoring systems. 4, make sure that policy and legislation, health initiatives, national strategies are created in co-design with health consumers. Ensure that patient engagement is not tokenistic. And finally, formally embed a safety learning culture into both policy and in practice. This is key to responding appropriately to harm and rebuilding and retaining trust. Patient safety is an undeniable, non-negotiable human right. It is the foundation upon which trust in our healthcare system is built. It cannot be treated as optional, nor can it be delayed. It is not enough to just focus on strengthening patient engagement. We need to improve communication and collaboration across the entire health sector. Given the complex nature of healthcare systems and services, the Health Consumer Advocacy Alliance developed what we call the 5 Eyes framework. I don't have time to talk on this now, but I can share the link with you afterwards. Thank you.
Good afternoon, everyone. So, I'd like to mention from the aspect of education. So, I received 3 questions. One is, what are the challenges in ensuring adequate staffing and workforce distribution, and how can they be addressed? So my answer is, as many of you know, healthcare system worldwide face common challenges. Securing a sufficient, well-trained healthcare workforce that is equitably distributed. I'd like to discuss 2 critical aspects of this issue. One is adequate staffing and fair distribution, and illustrated how Japan has addressed the challenges. Okay. First, so expanding the healthcare workforce requires substantial investment in education and training. However, such large-scale funding is often met with political resistance when faced with competing budget priorities. In addition, even after more healthcare professionals are trained, government must still find the resources to allocate them fairly across different regions. Public funds can be limited, and this financial constraint frequently impedes equitable distribution. Moreover, major distribution issue arises when healthcare professionals predominantly choose to work in urban centers. This leaves rural and remote regions understaffed, resulting in disparities in access to healthcare service. When physician shortage became evident, it creates the momentum needed for significant policy reforms. Stakeholders came together to invest in medical education, recognizing that a strong healthcare workforce is fundamental to national well-being. So, Japan introduced targeted incentives, such as increasing insurance payments for ICU staff. By backing these incentives with research that demonstrated the importance of critical care, policymakers gained the support of stakeholders across the board. To address regional disparities, Japan employed several complementary measures, including urban caps, rural incentives, and financial support program. Recognizing the right moment, such as a widespread shortage, can galvanize political and public support for new initiatives. As many speakers have mentioned today, grounding decisions in solid data and research help secure agreement among diverse stakeholders. Addressing healthcare workforce challenges require combining multiple approaches to suit the local context. A single strategy alone is rarely sufficient. At the last, ensuring an adequate and well-distributed healthcare workforce is both a universal priority and an ongoing challenge. Japan's experience offers valuable lessons. Securing political will, using evidence-based policies, and implementing multi-phase strategies can yield tangible improvements. By following these principles, we can work toward providing safe, equitable, and high-quality healthcare service for everyone, I think. Next slide. So this is the next question. How can we balance optimizing existing HRH and meeting their welfare needs? So to achieve balance in healthcare system, two key points must be addressed: productivity improvement and protection from excessive workload. In terms of productive improvement, we face four main challenges. First, there is the uneven distribution of human resource for health, which can be solved by fixing regional disparities of HRH. Second, restrictions on scope of practice present obstacles that can be overcome through the promotion of task shifting. Third, excessive workload challenges can be addressed through the utilization of technology. Fourth, insufficient educational opportunities require enhancement of competency. Next, regarding protection from excessive workload, two primary challenges exist. The first challenge is long working hours, which necessitated regulation of working hours. The second challenge is the emergence of burnout, which requires legal protection for stress management. Evidence-based policies informed by the principle of high reliability organization, HRO, lay the foundation for the resilient and high-performing healthcare system. By implementing these solutions, we can create a more balanced and effective healthcare environment for all stakeholders. So achieving balance in our healthcare system requires us to address four major productivity challenges and two critical workload protection issues: long working hours and burnout. By integrating evidence-based policies and HRO principles, we can create a resilient healthcare environment that not only maximize efficiency, but also safeguard the well-being of our essential healthcare workforce. This is the last slide. So, how can we make sustainable HRH possible in the context of the global health workforce crisis? So in addressing the global challenge of sustainable human resource for health, we must focus on two interdependent pillars: enhancing productivity and elevating competency. First, the global shortage of HRH requires us to optimize every available resource. Enhancing productivity is not simply an operational goal. It is a strategic imperative. By streamlining processes and adapting effective measures, we can maximize the output of our existing human capital, bridging the gap between limited resource and the growing demand of our healthcare system. However, boosting productivity alone is not enough. Continuous improvement in workforce competency is key to sustainable success. A skilled and knowledgeable workforce create benefit that multiply over time. Each increase in skill enhance individual performance and in turn contribute to exponential improvement in quality and efficiency. At the heart of competency lies a robust educational system built on two components. The provision of high-quality textbook and curricula, and the guidance of capital instructors who foster excellence. This foundation is essential for preparing a future-ready healthcare workforce. Equally important is the design and implementation of effective incentive structure. This not only reward excellence, but also motivate professionals to contribute meaningfully to their organization and the broader healthcare ecosystem, which is critical for sustaining HRH. To illustrate these principles, I'd like to present a case from Japan. Global Patient Safety Action Plan also mentioned about the importance of education as a strategic objective 5. And in strategy 5.2, they highlight to designate a patient safety center to provide leadership in patient safety education. At Gunma University, it's my university, we established the Patient Safety Education Center for multi-professionals. We say this center is PSEC. So this center uniquely integrates patient safety education across both pre-graduation and post-graduation phase. By bridging the oversight of the Ministry of Education and the regulatory domains of professional communities and the Ministry of Health, PSEC creates a continuous learning pathway. PSEC supports university faculty facing challenge in implementing patient safety education, advancing the field nationwide. Our approach goes beyond adverse event prevention by integrating human factors, system thinking, teamwork, and quality improvement into the curriculum, ensuring patient safety become a core element of healthcare providers' professional identity. Of course, so our curriculum covers the WHO Patient Safety Curriculum Guide, and in addition, so we put quite new topics into the curriculum, such as sharing mental model, followership, and situation monitoring, and shared decision-making, compassion, and so on. So in summary, sustainable HRH requires an integrated approach that boosts productivity and continuously enhance workforce competency. Strengthening education, implementing effective incentives, and adapting initiatives like PSEC will turn theory into practice, creating a safer, more efficient healthcare environment for the future. So I hope patient safety will be recognized as not only a priority in healthcare, but also an obvious foundation by sustainable education. Thank you.
Thank you. Thank you, Kazumi. Please don't forget that you still have your app, your event app, that you can post your questions on the different topics. So, Vijay, I'm going to start with you. You started our discussion, your presentation earlier with a punch about accreditation. And I'm sure our ministers here and our audience can relate to the fact and the experience that people sometimes, try to comply with accreditation. It's very difficult for people to submit documents, to comply. And sometimes you phrase it like accreditation for compliance sake. So what role does leadership play in driving policy changes and making sure that these accreditation standards translate to actual change in practice?
So it's important to first understand that healthcare is not one homogeneous kind of a thing where you feel that you can just go and deliver quality. So for example, a patient who is coming for a delivery in obstetrics has very different needs, very different expectations than a person who is coming for a bypass surgery or for a knee replacement, for anything. So a hospital has to be seen providing different products and services altogether. And ultimately, the idea is that how do we provide safe care? Accreditation provides a good framework around which every department and every function can fine-tune its department and its function to deliver safer care. Now, unfortunately, that last mile connectivity is not happening. You see, we are not, for example, even after so many years of the accreditation, people are not coming forward that these were the problems in the pediatrics department, these were the problems in the orthopedic department, in the sense that, so the clinicians can start to get around it and start, addressing them. These are not becoming a topic in various specialty organizations. They need to discuss about patient safety as a supreme thing. So I feel that as a policy, first of all, we have to address the people who are the masters of the accreditation bodies, that they have to definitely look at the end point as to what impact they are making in the concept of patient safety. Having been also a part of an accreditation body, I'll tell you, most of the time they are also bothered about their profit and loss, rather than thinking about what kind of an impact we have made towards the quality and patient safety. And it has to be broken down to various departments. And another thing I would like to say, sometimes when we talk about patients, it looks as if we are talking about somebody else. Ladies and gentlemen, we are talking about ourselves. I don't think there will be anybody, even sitting over here, who has not been a patient or will not be a patient. So we are talking about ourselves. We need to be safe. And I think our clinicians need to be involved. Every person who is working in the hospitals, they need to be involved. How do we do it? I mean, that can be a brainstorming, that can be done. But I feel that is very important to understand at least this particular part. The problem is that the hospital, when they get accreditation, feel as if it is the end of their quality journey, while that should be the beginning of their quality journey. That is the most important mindset change that is needed.
Thank you, Vijay. And I appreciate that you're highlighting quality implementers earlier. You highlighted about partnering with clinicians, and I want to shift a bit to Eugene. The way that you were presenting earlier, for example, that using this instead of this saves you a trip from Manila to Singapore. And you presented it and compared it in a simple way that anyone would be able to understand that this is more cost-effective than this. When you were working on these projects, how were you able to engage and convince as well clinicians and translate that approach to the leadership and say, this is the better way to go, this is more sustainable, and it's not gonna interfere with the quality of care that we provide?
I think the first is to get the clinical evidence that there's no drop in the quality of care with the more sustainable choice of drug or technique. But within the departments also, I think support of the head of departments are key. And one of the lessons we learned was to work with the heads who were keen on environmental sustainability in the first place. When we surveyed those departments that got involved, well over 80% of the doctors, in fact, were very, very concerned about environmental sustainability in healthcare, and hence were very keen to drive change.
Pointing out the leaks, that you are losing more of nitrous oxide with the leaks rather than actually using them. I think that's a really good data also to show. Yeah.
Yes, that was a surprise finding. It had been reported in other hospitals. I think it's not it may be published now, but we were surprised at the extent of the problem. And that was another impetus for changing the way we worked, where the nitrous oxide was still available for doctors to use if they wanted it. If they wanted it, or if it was truly indicated, such as for an obstetric patient. But it actually, in the end, very few doctors used it for other patients. Yeah, and so that shaping behavior was part of the change management.
Being in that setting, having meetings with them, informing them with evidence is part of that change. I want to shift a little bit to Charlotte. You mentioned about how you invest in engaging with patients and families. Can you share a little bit more about effective ways to involve patients and families in safety-related decisions?
Yeah, I think, adopting that kind of human factors, trauma-informed approach to healthcare, and just going back to what you said earlier, seeing patients holistically as a person as opposed to the medical problem that they present with. I think, one of the biggest challenges is that when people have been harmed in the system, you're significantly less likely to trust that system. And so we have to do what we can to improve communication, but not just with patients, with the whole entire health sector, whether it's even the cleaning staff, nurse staff, doctors. It's the whole system, and it's about taking action. There's a common health statement that is "you said, we did," and I'd like to challenge you to extend that, to change it to "you said, we reflected, we evaluated, shared our findings, took action, and then we re-evaluated the outcomes," because I think there's a focus on evaluating process as to actually evaluating the health outcomes. Yeah.
Thank you, Charlotte. Kazumi, when you were presenting earlier about ensuring workforce balance and distribution, you mentioned that with the high workload, one measure to balance it is also task shifting. And I know that WHO came out with a paper to say what would be the best way to do task shifting. In other low resource settings where the workload is so high and the workforce is so low, task shifting sometimes adds to the workload and limits the effectivity of the health worker. How do you avoid that?
Yes, actually it is very difficult, difficult things. So because we medical doctor want to shift the task to nurse or someone, but so nurse have already have a, yes. So one what to say? Yes, one strategy is using AI and technology. And other thing is education, I think. So because to educate the staff, so it will, sorry, so, it can be very helpful. And so when staff growing up, so the same amount of task is so what to say, not difficult for them.
Sharing the task would lighten the load.
And they need to understand what they have to do and why they have to do. Yeah, I think it is very important.
For anybody who would like to comment, considering that the sharing tasks and engaging with patients and engaging with the clinicians. With the increased workload, how do we sustainably plan for making sure that even though we have to distribute the workload, we ensure safety?
Like what she said, it is a complex thing. But for example, in the whole hospital, if you are going to use ventilators and they are of different brands, there are different types, then it adds to the complexity of the nursing. So, or let's say infusion pumps. So in today's date, whatever technology or the equipment that you are using, if they are uniform and if the staff is trained on that, then it is very likely that when she gets shifted from one place to the other, she will be able to deliver. And so there will be different strategies, but I'm just saying that one of the things that came to my mind.
I think it's looking at the long-term picture. One of the initiatives that the Health Consumer Advocacy Alliance is doing at the moment is through the parliamentary process. We have requested that a patient safety commissioner be established, that role be established in New Zealand, like with Henrietta in England. It's really important because it's about increasing transparency, but somebody mentioned in one of the other sessions about health professionals. What are we doing to support our health professionals? It's not just patients that need a voice, it's also our health professionals. And what Henrietta does in England is she is able to have those hard-to-have conversations. And if you increase transparency, you can retain and you can rebuild trust. And I think that's really important.
Thank you, Charlotte. So with the limited time that we have, I'd like to give back the microphone to Diana, our process facilitator. Diana?
Thank you. For those who still want to have, maybe we can have one more question on the floor, but we do have someone who came in with a question. I'll address this to Charlotte because this is something that concerns patient engagement. And the question is, what are the common reasons service designers hesitate to co-design with patients? Is that something, reasons for hesitating to co-design? Because if you're talking about true patient engagement, you have to co-design from the system to the policy. But why is there hesitation, you think?
I think it's a lack of understanding of what co-design is. Like, I've been involved in a lot of different projects and initiatives in New Zealand and with various health entities, and each idea of what co-design is different. And it's talking to that, moving from a tokenistic approach to, designing something and then bringing the consumer in at the end and then editing a document. That's not co-design. Co-design is when you are there right from the very beginning and you're there right through to the end, and then you're there for the evaluative part. But more importantly for consumers, they need to be involved in every level of the health system. So from policy, legislation, right down through, navigating for individuals through the health system itself.
Thank you for that. I think that's something that most systems aren't really doing, and that's why it's a new thing that has to be integrated and has to be explicitly tried and attempted, I guess.
And actually consumers work constructively with health professionals and ministers and health entities. There seems to be this perception that it's all the consumers over here and then everybody else over here. It's about collaboration and it's about working together, and you can actually do some pretty great work together.
Yeah, we have to leverage on that enthusiasm from our consumers and our patients. We don't have any more questions on the floor, so maybe I'll give it over to Jen again for the key takeaways.
Thank you, Diana. So with all that has been inputted today, all the comments that we have, I've taken note. I swear I wasn't texting anyone. I was just taking note of key takeaways. First is with accreditation beyond compliance, but on improvement and investing in quality implementers. The second is that patient safety leadership investment is a sustainable approach. And we have to communicate that patient safety is green. It is a green investment to invest in patient safety. Working together through transparency and learning from one another and co-designing is key to having sustainable plans for patient safety. Genuine engagement leads to learning and propel a safe culture. Lastly, investing in education that is guided by competencies for patient safety translate
to practitioners and future leaders in patient safety. We invest in this workforce, in their number, competence, well-being is a sustainable investment for patient safety. Thank you very much, and another round of applause for our panel. Thank you.
Good afternoon. At this point, we invite everybody for a 10-minute break. Please do enjoy the food and beverage outside our venue, and please be back after 10 minutes. Again, we'll have a 10-minute break. Please enjoy the food and beverage outside our venue, and see you after 10 minutes. Thank you.
Make sure that we care for the patient. It makes their life different. You also feel good dahil nakatulong ka sa kapwa mo.
Ako po si Imelda Celestino, 65 years old. Kaya po ako nagpunta ng hospital kasi nag-bleed po ako. Sa resulta ng biopsy, meron daw po akong bukol sa matris. Siyempre po, natatakot po ako na yun nga po, baka may cancer nga po. Sinabi nga po ng mga espesyalista sa yung consultant na di naman daw po nakakatakot magpa-chemo. Marami naman daw pong mga mga senior citizen na gumagaling. Kaya nag-decide na lang ako magpa-work up.
Magkapit-bahay po kami, tita ko po siya. Tuwing ina-admit siya, ako po yung bantay niya lagi. Sinabi po ng anak niya na bukol sa ovary. Pero magagamot naman po. Kaya palakasin namin yung loob ni tita. Parang wala lang, parang nag-staycation lang po kami sa ospital. Parang family din namin yung mga nurse dito. Hindi po sila nagsasawang pumasyal para magtanong kung may kailangan.
Ang role ko po as a nurse is yung siguraduhin yung safety ng patient. At the same time po is yung magawa po yung mga plans ng mga doktor and then ma-carry out po yung mga care na dapat sa kanya at maibigay yung mga gamot niya. Sobrang importante po na maramdaman niyang safe kasi po yung buhay po kasi niya, binibigay na niya sa pangangalaga namin, sa aming mga nurses, pati sa mga doktor. So malaking bagay po yun na parang may trust po siya sa amin.
Dito sa aming hospital, meron po kaming Patient Safety Committee. Ang aming Patient Safety Committee ay kinocompose ng doctors, nurses, mga admin po. Ina-address po nila yung infection control, medication safety, patient safety, procedure safety, and proper communication po, and teamwork collaboration. Number one na importante sa infection health control or infection control would be hand hygiene, yung proper hand washing. Minimake sure din natin na bago pumasok yung pasyente, yung safety or yung sterilization ng area. Aside from that, chine-check din natin yung mga procedure safety. Napaka-importante ng makuha natin ang consent ng patient. Kasi magpapakita ito na napaliwanag mo sa pasyente kung ano yung mga kailangan niya at dapat niyang malaman bago mo maisagawa yung isang procedure. Napaka-importante ng patient tagging kasi ito yung mag-identify sa patient. Napaka-importante ng SIRATES, lalo na sa mga bata, sa mga matatanda, at saka yung mga pasyente natin na hindi talaga yung normal yung level of consciousness nila, yung mga patulog-tulog. Sa safety procedures po ng laboratories or extraction ng blood, importante number one, kailangan malaman mo ba kung tamang pasyente ba yung kukunan mo ng dugo. Kasi hindi ka po pwedeng kumuha ng dugo kung kani-kanina lang pasyente. Sa infection and sanitation protocols po, meron tayong mga sulat sa bawat corner ng ating hospital kung paano po gagawin ito. Aside from that, yung patient communication. Kasi napaka-importante, nakakausapin natin yung pasyente.
Araw-araw po sila, inilagaan po nila ako. Araw-araw po sila nag-rounds. Lalo na po yung mga consultant, mga nurses namin. Tapos po sa Euro, maga pa lang po nagde-dressing na po sila ng sugat.
Sa mga bantay na parehas ko, magtiwala din sila sa mga nurse, sa mga staff. Kasi sila yung parang pamilya mo rin dito. Hindi rin iba yung treatment nila. Kahit bantay ka, yung attention kay tita, inaanuhan din nila sa'yo para hindi ka rin magkasakit.
Wala naman pong fix sa buhay. May gagaling, may hindi. Pero ang may papangako lang po sana at ang pinaka-importanting magagawa namin as nurses is yung ma-ensure ang patient safety habang andito po sila sa aming pangangalaga.
Ako, proud ako, not only for myself, but also sa mga team namin, sa lahat ng mga staff dito sa hospital. As a doctor, I live by, of course, serving the patients first. Because for me, ang importante is improving the lives of the patient and making a difference in the patient's life as well as to the relatives.
Pakiramdam ko dito po sa mga nurses, sa mga staff, okay po, satisfied naman po sa kanila. Kampante naman po sila na safe ako sa hospital na ito. Kaya po, maraming po salamat sa kanila.
Mga kababayan, tulad ni Nanay Imelda na pinangangalagaan ng Department of Health at ng Ministerial ang kanilang patient safety, ganyan din po ang gagawin namin sa lahat ng aming mga ospital at healthcare facilities. Pinangungunahan ng Department of Health ang pagtaguyod sa patient safety. Sa mga kamag-anak ng mga pasyenteng nagpapagaling sa mga DOH hospital, huwag po kayong mag-alala, kami po ay nakatutok sa kanilang patient safety.
Good afternoon. We will resume with our program at exactly 4:40 in the afternoon. Again, we will resume with our program at exactly 4:40 in the afternoon. Thank you.
We make sure that we care for the patient. It makes their life different. You also feel good dahil nakatulong ka sa kapwa mo.
Ako po si Imelda Celestino, 65 years old. Kaya po ako nagpunta ng hospital kasi nag-bleed po ako. Sa resulta ng biopsy, meron daw po akong bukol sa matris. Siyempre po, natatakot po ako na yun nga po, baka may cancer nga po. Sinabi nga po ng mga espesyalista sa yung consultant na di naman daw po nakakatakot magpa-chemo. Marami naman daw pong mga senior citizen na gumagaling. Kaya nag-decide na lang ako magpa-work up.
Magkapit-bahay po kami, tita ko po siya. Tuwing ina-admit siya, ako po yung bantay niya lagi. Sinabi po ng anak niya na bukol sa ovary. Pero magagamot naman po. Kaya palakasin namin yung loob ni tita. Parang wala lang, parang nag-staycation lang po kami sa ospital. Parang family din namin yung mga nurse dito. Hindi po sila nagsasawang pumasyal para magtanong kung may kailangan.
Ang role ko po as a nurse is yung siguraduhin yung safety ng patient. At the same time po is yung magawa po yung mga plans ng mga doktor and then ma-carry out po yung mga care na dapat sa kanya at maibigay yung mga gamot niya. Sobrang importante po na maramdaman niyang safe kasi po yung buhay po kasi niya, binibigay na niya sa pangangalaga namin, sa aming mga nurses, pati sa mga doktor. So malaking bagay po yun na parang may trust po siya sa amin.
Dito sa aming hospital, meron po kaming Patient Safety Committee. Ang aming Patient Safety Committee ay kinocompose ng doctors, nurses, mga admin po. Ina-address po nila yung infection control, medication safety, patient safety, procedure safety, and proper communication po, and teamwork collaboration. Number one na importante sa infection health control or infection control would be hand hygiene, yung proper hand washing. Minimake sure din natin na bago pumasok yung pasyente, yung safety or yung sterilization ng area. Aside from that, sine-check din natin yung mga procedure safety. Napaka-importante ng makuha natin ang consent ng patient. Kasi magpapakita ito na napaliwanag mo sa pasyente kung ano yung mga kailangan niya at dapat niyang malaman bago mo maisagawa yung isang procedure. Napaka-importante ng patient tagging kasi ito yung mag-identify sa patient. Napaka-importante ng sirens, lalo na sa mga bata, sa mga matatanda, at saka yung mga pasyente natin na hindi talaga yung normal yung level of consciousness nila, yung mga patulog-tulog. Sa safety procedures po ng laboratories or extraction ng blood, importante number one, kailangan malaman mo ba kung tamang pasyente ba yung kukunan mo ng dugo. Kasi hindi ka po pwedeng kumuha ng dugo kung kani-kanino lang pasyente. Sa infection and sanitation protocols po, meron tayong mga sulat sa bawat corner ng ating hospital kung paano po gagawin ito. Aside from that, yung patient communication. Kasi napaka-importante, nakakausapin natin yung pasyente.
Araw-araw po sila, inalagaan po nila ako. Araw-araw po sila nagra-rounds. Lalo na po yung mga consultant, mga nurses namin. Tapos po sa Euro, maga pa lang po nagde-dressing na po sila ng sugat.
Sa mga bantay na parehas ko, magtiwala din sila sa mga nurse, sa mga staff. Kasi sila yung parang pamilya mo rin dito. Hindi rin iba yung treatment nila. Kahit bantay ka, yung attention kay tita, inaanuhan din nila sa'yo para hindi ka rin magkasakit.
Wala naman pong fix sa buhay. May gagaling, may hindi. Pero ang may papangako lang po sana at ang pinaka-importanting magagawa namin as nurses is yung ma-ensure ang patient safety habang andito po sila sa aming pangangalaga.
Ako, proud ako, not only for myself, but also sa mga team namin, sa lahat ng mga staff dito sa hospital. As a doctor, I live by, of course, serving the patients first. Because for me, ang importante is improving the lives of the patient and making a difference in the patient's life as well as to the relatives.
Pakiramdam ko dito po sa mga nurses, sa mga staff, okay po, satisfied naman po sa kanila. Ang pante naman po sila na safe ako sa hospital na ito. Kaya po, maraming po salamat sa kanila.
Mga kababayan, tulad ni Nanay Imelda na pinangangalagaan ng Department of Health at ng Ministerial ang kanilang patient safety, ganyan din po ang gagawin namin sa lahat ng aming mga ospital at healthcare facilities. Pinangungunahan ng Department of Health ang pagtaguyod sa patient safety. Sa mga kamag-anak ng mga pasyenteng nagpapagaling sa mga DOH hospital, huwag po kayong mag-alala. Kami po ay nakatutok sa kanilang patient safety.
Make sure that we care for the patient. It makes their life different. You also feel good dahil nakatulong ka sa kapwa mo.
Ako po si Imelda Celestino, 65 years old. Kaya po ako nagpunta ng hospital kasi nag-bleed po ako. Sa resulta ng biopsy, meron daw po akong bukol sa matris. Siyempre po, natatakot po ako na yun nga po, baka may cancer nga po. Sinabi nga po ng mga espesyalista sa yung consultant na di naman daw po nakakatakot magpa-chemo. Marami naman daw pong mga senior citizen na gumagaling. Kaya nag-decide na lang ako magpa-work up.
Magkapit-bahay po kami, tita ko po siya. Tuwing ina-admit siya, ako po yung bantay niya lagi. Sinabi po ng anak niya na bukol sa ovary. Pero magagamot naman po. Kaya palakasin namin yung loob ni tita. Parang wala lang, parang nag-staycation lang po kami sa ospital. Parang family din namin yung mga nurse dito. Hindi po sila nagsasawang pumasyal para magtanong kung may kailangan.
Ang role ko po as a nurse is yung siguraduhin yung safety ng patient. At the same time po is yung magawa po yung mga plans ng mga doktor and then ma-carry out po yung mga care na dapat sa kanya at maibigay yung mga gamot niya. Sobrang importante po na maramdaman niyang safe kasi po yung buhay po kasi niya, binibigay na niya sa pangangalaga namin, sa aming mga nurses, pati sa mga doktor. So malaking bagay po yun na parang may trust po siya sa amin.
Dito sa aming hospital, meron po kaming Patient Safety Committee. Ang aming Patient Safety Committee ay kinocompose ng doctors, nurses, mga admin po. Ina-address po nila yung infection control, medication safety, patient safety, procedure safety, and proper communication po, and teamwork collaboration. Number one na importante sa infection health control or infection control would be hand hygiene, yung proper hand washing. Minimake sure din natin na bago pumasok yung pasyente, yung safety or yung sterilization ng area. Aside from that, chinecheck din natin yung mga procedure safety. Napaka-importante ng makuha natin ang consent ng patient. Kasi magpapakita ito na napaliwanag mo sa pasyente kung ano yung mga kailangan niya at dapat niyang malaman bago mo maisagawa yung isang procedure. Napaka-importante ng patient tagging kasi ito yung mag-identify sa patient. Napaka-importante ng SIRACE, lalo na sa mga bata, sa mga matatanda, at saka yung mga pasyente natin na hindi talaga yung normal yung level of consciousness sila, yung mga patulog-tulog. Sa safety procedures po ng laboratories or extraction ng blood, importante number one, kailangan malaman mo ba kung tamang pasyente ba yung kukunan mo ng dugo. Kasi hindi ka po pwedeng kumuha ng dugo kung kani-kanino lang pasyente. Sa infection and sanitation protocols po, meron tayong mga sulat sa bawat corner ng ating hospital kung paano po gagawin ito. Aside from that, yung patient communication. Kasi napaka-importante, nakakausapin natin yung pasyente.
Araw-araw po sila, inilagaan po nila ako, araw-araw po sila nagra-rounds. Lalo na po yung mga consultant, mga nurses namin. Tapos po sa Euro, maga pa lang po nagde-dressing na po sila ng sugat.
Sa mga bantay na parehas ko, magtiwala din sila sa mga nurse, sa mga staff. Kasi sila yung parang pamilya mo rin dito. Hindi rin iba yung treatment nila. Kahit bantay ka, yung attention kay tita, inaanuan din nila sa'yo para hindi ka rin magkasakit.
Wala naman pong fix sa buhay. May gagaling, may hindi. Pero ang may papangako lang po sana at ang pinaka-importanting magagawa namin as nurses is yung ma-ensure ang patient safety habang andito po sila sa aming pangangalaga.
Ako, proud ako, not only for myself, but also sa mga team namin, sa lahat ng mga staff dito sa hospital. As a doctor, I live by, of course, serving the patients first. Because for me, ang importante is improving the lives of the patient and making a difference in the patient's life as well as to the relatives.
Pakiramdam ko dito po sa mga nurses, sa mga staff, okay po, satisfied naman po sa kanila. Kampante naman po sila na safe ako sa hospital na ito. Kaya po, maraming po salamat sa kanila.
Mga kababayan, tulad ni Nanay Imelda na pinangangalagaan ng Department of Health at ng Ministerial ang kanilang patient safety, ganyan din po ang gagawin namin sa lahat ng aming mga ospital at healthcare facilities. Pinangungunahan ng Department of Health ang pagtaguyod sa patient safety. Sa mga kamag-anak ng mga pasyenteng nagpapagaling sa mga DOH hospital, huwag po kayong mag-alala. Kami po ay nakatutok sa kanilang patient safety.
Good afternoon again to you all, and we welcome you all back here in the main hall for the next segment of our program. We now move to Experts Plenary 3, which will explore a rapidly evolving and crucial area, leveraging AI and technology for patient safety, challenges, applications, and policy considerations. This session will delve into the potential and challenges of integrating artificial intelligence and technology to enhance patient safety. We are honored to have with us Dr. Shin Ushiro, Deputy Director and Professor of Patient Safety in Kyushu University Hospital and a board member of Japan Council for Quality Healthcare, chairing this important discussion. Let's give him a big round of applause, please. And now, please join me in welcoming our esteemed panelist, Dr. Albert Wu, Johns Hopkins Bloomberg School of Public Health, USA. Dr. Sosuke Kimura, Japan Medical Safety Research Organization. Ms. Susan Sheridan, Patients for Patient Safety, USA. Dr. Iris Tiel Isiptan, University of the Philippines. And Dr. Laura Zwan, Erasmus Medical Center, Netherlands. We look forward to a stimulating and insightful discussion on the role of AI and technology in advancing patient safety. I give the floor now to Dr. Shin Ushiro.
Please sit down. Okay, thank you very much. Thank you for coming. And honorable ministers and vice ministers, distinguished guests, and esteemed colleagues, participants, welcome to the plenary session 3 related to AI, artificial intelligence, which is the focused topics not only in healthcare industry but also in other industries. I am Professor Shin Ushiro from Kyushu University Hospital, Japan, and I also work in accreditation body called the Japan Council for Quality Healthcare, dubbed as JQ. JQ is also running reporting and the learning system at the national level as well. I would like to, first I'd like to make an introductory speech briefly on AI experience, and then After that, I will come to our esteemed panelists, one after another, with Q&A, question and answers. And some panelists have their slide. It's a sort of a visual background. And if you like, please come to the podium. But some panelists do not have a slide. So if you want to stay in your seat, please speak at your seat. Or you may come to the podium to speak verbally. Okay, and so I'd like to start with my brief presentation. Here you see. This is, here you see the cherry blossoms. Now we got into the season of cherry blossoms in my country. This cherry blossom was supposed to be the bud, and it moves to get into the full bloom. I created it through AI, but it doesn't move, unfortunately. So please come back to the very initial default setting, and then please move the slide. Can you do that? I'm organizing the secretly. Okay. Please move back. Please move back one. Okay. Here you see. This is a power of AI. So, thank you very much. Thank you very much. Okay. May I have the next slide, please? Okay. Here you see the event related to AI that I listed in chronological manner. International event is on your left, and the domestic event is seen on your right. For instance, in 2007, and now we are in the fourth boom of AI, because in 2017, there were the very famous paper came out from Google researchers, and they introduced Transformer. So you all know that the GPT. GPT is an acronym of Generative Pre-trained Transformer. And personally, I and my colleagues from Hong Kong developed BERT. It's also a AI model. BERT is an acronym of bidirectional encoder representation from transformer. So transformer is a powerful tool, and we also enjoy the evolved variants of transformer in the fourth boom of AI. And during the last couple of years, what happened globally is that the many initiatives to promote AI was launched one after another in many countries, countries like US, UK, everywhere. And a month ago, AI Summit was held by France and India. And in opening remarks, Prime Minister Modi of India stated that it's wonderful to read medical chart without difficult scientific jargon. So I hope that AI will enable patients and families to be more familiar with medical chart or healthcare record. In our countries, our government launched the headquarters for promoting AI. Now the government proposed a draft AI Act in regular diet session, and now it's in deliberation. So next slide, please. Okay, here you see, he is the Professor Matsuo of Tokyo University. He's a chair of a panel, a governmental panel. He says that when he was young, he studied in Stanford University, United States, and smartphone, iPhone, was launched at that time, but people never talked about iPhone in my country, while people talked about iPhone for coming month, for 1 month in the United States. But now, many companies are investing AI to build their big data center, and people are highly aware of AI. So he says the time has come. And he emphasized that the government, the draft AI Act produced by our government is weighing on, trying to balance promotion, innovation, and regulation. So not weighing only on regulation. That's the message from Professor Matsuo. Next slide, please. Next slide, please. Okay, here you see the outline of our draft AI Act. As I said, it tries to balance promotion and regulation. We like regulation because regulation tells us what is prohibited and what is possible, what is allowed for us to do. So probably this is our culture. So probably this AI Act will provide us what we can do. And this act does not include much penalty, like fine. If I identify provision related to, indirectly related to penalty, is the disclosure of a name of the company who doesn't follow the government guidance. That's it. So I hope this AI Act will promote innovation of AI in AI development. Next slide, please. Okay, here you see how AI works in clinical settings. Probably it will be helpful in clinical work as well as administrative work. Probably Professor Albert will touch on this issue later on. Okay, next slide, please. Here you see the New York Times report from New York Times, because I am a subscriber of New York Times and Washington Post. This report tells you what Miss Sue Sheridan experienced through AI. Maybe, hopefully, she will describe her experience later on. Next slide, please. Okay, AI is now working. AI, years ago, we were saying that AI is coming to our space on healthcare, on patient safety. But now, in 2025, AI has already arrived, and it's working in our healthcare front. For instance, last year, my country began with a disastrous event. January the 1st, we came across a crash of airplane at Haneda, Tokyo Airport. And on the 2nd of January, we came across a huge earthquake at the region called the Noto Peninsula. And people evacuated from Noto Peninsula. People includes medical professionals. So they didn't come back because their infrastructure was collapsed. So the hospitals, healthcare institutions began to suffer shortage of medical professionals, and they were motivated to introduce AI. How AI work is that AI produce a referral letter, AI produce discharge summary, operation summary, admission summary, etc., etc. So the AI saves time. AI reduces the administrative burden of medical professionals in Noto Peninsula. Next slide, please. Okay, come to think of my organization, JQ, it's an accreditation body, and it runs a reporting and learning system. We have wide variety of reporting and learning system targeting various medical institutions like hospital, clinic, dental clinic, pharmacy, community pharmacy, and it also targets some clinical symptoms like cerebral palsy. And then, so I would like to emphasize that our organization has a lot of text data. Next slide, please. Okay, here you see the database of our reporting and learning system. Since it was launched in 2004, and we equipped with a database which discloses reports to the public with identifiers deleted. I said identifiers. Identifier is the name of the hospital, name of the medical professionals. We delete that, but we disclose all the details remaining on our database. And our database is highlighted not only by clinicians or medical professionals, but also researchers and industries. Next slide, please. And one day, researchers on AI, Dr. Won Sui, came to me from Hong Kong. She's working now in my country, and we began collaboration to develop AI model. I said we developed an AI model called the BERT. And BERT is pre-trained with a large number of text in the first place. And then second step is called fine-tuning. The Dr. Wong fine-tuned the BERT with our data related to medication safety. And now BERT is working to produce structured data related to medication safety. So those data will enable medical professionals or the safety professionals to identify medication error in healthcare, in electronic healthcare record. Next slide, please. Okay, here you see the structured data are produced by the BERT we produced. For instance, this is the structured data of one incident. For instance, Monday is the Monday, and the levofloxacin is a drug, and minocycline is also a drug. And 20 milligram is a amount intended, or another 30 milligram is the amount actually administered. So this AI distinguishes the overdose or underdose. So this is what is happening in my country. So next slide, please. As I said, we are running a reporting and learning system targeting cerebral palsy. We call it no-fault compensation system. At this point, I'd like to share with you that our reporting and learning system is posted on the website of HSSIB of NHS England by kindness of Dr. Rosie Beniard. We have been collaborating each other. So I really appreciate the UK colleagues for sharing our experience. And we produce investigative report on cerebral palsy. Next slide, please. And we posted synthesized investigative report, as many as 4,000 or more currently on our website. Next slide, please. Next slide, please. And we are thinking of adapting AI to analyze investigative report to produce a model to automatically produce draft investigative report in the future. But some of you may wonder if our disclosure may breach the regulation related to personal data protection. So one day, a couple of years ago, one childbirth facility filed a lawsuit to Tokyo District Court claiming that our disclosure is breaching Japanese Data Protection Act. So JQ, my organization, should withdraw the investigative report from our website. Next slide, please. Almost the last. Okay, and the Tokyo District Court deliberated, and they ruled that our disclosure does not breach our Data Protection Act because our system and our disclosure aims at public health promotion, which is the defined reason to exempt the disclosure from banning the personal data sharing. So the claims was dismissed at district court level. I don't know what will happen in the next step, appeal court, but at present, our disclosure is maintained. So next slide, please. Okay, here you see the objective of this session. We will discuss how AI is useful and how we need to address challenges on AI. Next slide, please. Okay, recently, it has been said that ChatGPT dramatically improved the capability of generating image. So this is a picture I took 2 days ago after the ceremony to welcome new staff on the day of April 4th. That is the day of the beginning of new fiscal year in my country. So there were a lot of ceremony, and then the AI can quickly turn this picture into the style of Studio Ghibli. So next slide, please. Here you see that. Yes. So I would like to emphasize that AI is developing year by year, month and month, and week. So I hope and I believe that the AI will make our space on healthcare safer and more reliable as far as we figure out how to cope with this new technology properly. So thank you very much. Okay. Okay, now I would like to start with question and answer session. First, I come to Dr. Sosuke Kimura. I have been collaborating with Dr. Sosuke Kimura for 15 years. He is the board member of investigation body in my country. So in his organization, there are a lot of text data. So the question for Dr. Kimura is that what have been some significant challenges in ensuring patient safety based on your research, on your investigation project? And how did AI technology help in addressing these challenges? And the next question is, how do current laws and guidelines shape the development and deployment of AI in healthcare? I slightly touched on in my presentation. So maybe I will come to the second question. But for first question, please share your thought, Dr. Kimura. Thank you.
Thank you, Shin. Good afternoon. My name is Kimura, and I'm working more than 10 years on medical accident investigation systems. So today's speech is my experiences and AI. The report and learning system is essential for driving patient safety initiatives. By analyzing these factors, we gain insight that lead to learning and feedback, as well as the implementation of improvement in clinical practice. Many countries have incorporated this system into their healthcare infrastructures, and some have made it a legal requirement. As a result, large numbers of serious incident reports are submitted. Generally, when these reports are examined by highly skilled experts using established methods, they yield valuable insights that inform learning and feedback and guide to the implementation of improvements in clinical settings. However, even high-quality reports often remain unanalyzed due to a shortage of skilled experts and the limited dissemination of analytical methodologies. On the slide, the third column, one possible solution is generative AI. It can greatly bolster both the expertise and methodology needed for effective analysis, thereby accelerating patient safety improvements. We are thinking three key factors for AI tuning and training, because AI at this time is, to my understanding, is the empty black box. We put in some data to AI. First, is past high-quality reports and analytics. Second is clinical knowledge and pitfalls. Third is patient safety mechanisms. To illustrate the situation in Japan, to our institute, all hospitals and clinics legally required to report any unexpected deaths causes to our agency. At the same time, the detailed cause analysis framework is voluntary to hospitals, which means to decide if it is accident or not is dependent on the administrator of the concerned hospital. This relates the accumulation of nearly 3,000 detailed high-quality reports reflecting strong engagement. Specifically, the case analysis has been developed over the course of more than a year, incorporating input from outside experts and reflecting multi-directional discussion. As a result, these factors compare and to analyze similar multiple cases, which uncover learning offers valuable insights for clinicians. However, the same problem, due to a shortage of both experts and standardized methodologies, 90% of these reports remained unanalyzed. In response, we have launched a new generative AI project to assist in the analysis. From these experiences, we derived two important insights. First, define the procedure of each step of the analysis and organize them in stages so that they can be reliably handed over to AI. Second, retraining the staff analysis teams to our staffs, which means to be more AI-friendly, enable them to work effectively with increasingly sophisticated AI. In conclusion, by structuring each analysis step and preparing our teams for AI collaboration, we unlock untapped insights from incident and investigate reports. Embracing generative AI will foster continuous learning and elevate patient safety. And may I continue to the second question? The second question, how different laws and guidelines affect the AI development. The answer is there are three key points we have to consider when using AI to analyze medical incident and investigation reports. First, it is crucial to comply with data protection and privacy laws. Regardless of whether these reports concerning past incidents, any personal or sensitive information must be handled in accordance with regulations such as the GDPR or HIPAA. Second, we must be aware that the regulatory framework for AI is still in its infancy and subject to uncertainty. For instance, it might be repurposed to identify and blame individuals rather than supporting learning and improvement. Even if the data deal with past incident, we must carefully monitor how AI-driven analysis might influence further outcomes. Finally, because medical accidents can have major implications for patient safety, verification and oversight are essential. Human experts must variable the AI's findings, and it is imperative to establish a swift error reporting workflow. These steps help ensure that AI remains a constructive tool for improving patient safety, not a mechanism for fault finding or punitive measures. Thank you very much.
So thank you very much, Dr. Kimura. As he said, in his investigation system, individual medical institutions conduct investigation, and the institution shared investigative report with his organization. So in his organization, there are thousands of investigative reports, but it's not very much standardized, and only 10% has been utilized for prevention or learning. That's one point. And the second point is that that initially at the inception of his investigation system, people worried about data protection, clinical data protection. So only 10% is utilized. We hope that the regulation will be lifted. However, we need to consider the privacy issue or data protection issue as well. So I would like to come to Professor Albert Wu next. Professor Albert Wu is a professor of Bloomberg Institute, a School of Public Health, and Armstrong Institute. Armstrong Institute is dubbed as AI, and he's from Johns Hopkins University. So Dr. Albert Wu, please come to the podium and please share your thoughts on AI application in clinical settings. Thank you.
Thank you so much. Thank you so much. Could I, now, is there a question for me that you wanted to ask?
Thank you very much, thank you. I need to develop AI to navigate me to comply with the proper protocol. The question directed to you is, number one, what are some other promising applications? What is the application of AI and the technology in healthcare that can improve patient safety? Okay, please focus on patient safety. And what steps should be taken to ensure these technologies are accessible, reliable, and maintain high standards of quality and safety in patient care? What challenges might arise in implementing these AI-driven solutions, and how can they be addressed to ensure patient safety? So those three questions. Please respond to it. Thank you.
Thank you very much. I think I'm going to answer the first question, and then I might defer to one of my colleagues to answer the next question, and let's see how this goes. Next slide, please. Next slide, please. Thank you. So I just wanted to give a few examples of ways in which AI is already being used to improve safety, and then a few examples where it's close. Basically, the problem that we've had in healthcare for many years, and this problem has only accelerated, is that we have too much data. And that seems like a paradox. We're here to collect information so that we can use it, but we are drowning in data, and there is too much of it for our little brains to understand and do something with. So AI, magically, almost, takes that data, digests it, and feeds it to us in ways that we can perhaps take action. Some of the actions are to improve prediction. For each of these, I'll give a brief example. One example of prediction is a number of systems which are now available to predict whether or not a patient might develop the serious condition and perhaps fatal condition of sepsis. The system developed at Johns Hopkins reads the entire electronic record of every patient who is hospitalized at Johns Hopkins Hospital. It refreshes the data every 20 minutes and generates a prediction based on history, physical, reading of medical records, lab tests, and physiology of whether or not a patient might be at risk for developing sepsis in the next 24 hours. This is far better than we as humans are able to do, and this is now running continuously for every patient in the hospital. Recently, tests have been developed which can predict the presence of multiple cancers with a blood test. People call these multi-cancer early detection systems. One of them is currently licensed by the FDA, called Gallery, and it looks at fragments of DNA and actually fragments of cancer genes that are circulating in the blood. The problem is, if you see one cell or if you see a little bit of RNA or DNA, what do you do about it? What we really need is AI to look at that sample, look at what might be expected, and decide whether or not there is a good chance that this person might need to go for an additional test to see if they could actually have cancer. But there's the potential for many cancers, for example, pancreatic cancer, to be detected simply and without extensive and invasive testing. There's a problem of monitoring patients. This can help physicians and other healthcare providers, but it can also help the patients monitor themselves. Recently, a number of systems have been developed which the patient can take home. It might be a patient with heart failure, and they are at risk for all sorts of complications that might occur. Using either an implanted device or other monitoring devices, the device can read continuously their vital signs, their EKG, and when there is a risk that the person's heart failure might be worse, or that they may be experiencing a dangerous arrhythmia, they are signaled. The signal may be to take a diuretic to reduce heart failure, or it may be to call an ambulance and get to their cardiologist. We've heard a little bit about analyzing incident reports. Once again, I think that Sir Liam may know better than almost anyone that the National Health Service is suffering from an excess of data, from tens of millions of incident reports. We had this problem too at Johns Hopkins, and we had two problems. First of all, we weren't getting enough reports. Secondly, when we did get them, we didn't know quite what to do with them. The system we ultimately developed was, instead of asking dozens of questions about what happened and who did it and how severe was it, and many, many questions to classify those incidents, we simplified our system so that we asked the reporter, what happened? To figure out what happened and what to do about it would then require either a great deal of expert analysis or perhaps, in our case, an AI system, which is perhaps similar to what we heard about recently. Our own reports every year increased over the last couple of years from about 10,000 reports a year to about 50,000 reports, because you just need to take a minute or two to describe what happened. The system analyzes them, summarizes what happened, suggests who should hear about it in the hospital, sends it to them, and suggests preliminary actions or actions for additional investigation. Doctors and other providers are overworked, and something that can be done now is that, in fact, remarkably, AI can sometimes help reduce the burden of work that providers have. One of them that I experience frequently is needing to spend extra hours writing notes, summarizing what happened to my patients. Recently, we've installed an AI scribe. What happens now is the patient comes in, we sit down and chat a little bit about how their work is going, what they're doing for recreation, what medicines they're on, some medical information, and then the patient leaves and I leave. The AI scribe records the entire encounter, summarizes it, and writes a note, which I look over and generally say, that's at least as good as what I would have done. There's the potential for such a device to analyze the entire patient record of a patient. Some of my patients I've been seeing for 25 years continuously. There's a lot of information from our encounters and also from all of the other doctors, nurses, and other people they have seen over that time. What is being worked on now is the ability to read the record, summarize all of the procedures, all of the medications, all of the visits, and again, to write a concise note. So there is hope, in fact, and already some bit of reality, that AI can help predict, help diagnose, and help decision-making, and also even reduce work. I think there might be, I think you might have my non-AI, my Albert intelligence, suggests that you may have a question for our next panelist.
Thank you, Professor Albert. He touched on the analysis of incident report. Incident report was a topic of plenary session number 2. So our discussion is related to the plenary session number 2 in this morning, and he touched on the early diagnosis of sepsis. Sepsis is the condition that microbial spreads and grows in our bloodstream and harms tissues and organs. And in plenary session 1 this morning, led by Sir Liam Donaldson, Dr. Henrietta Hughes touched on Martha's Rule in NHS England. Martha passed away, unfortunately, at the age 13 due to sepsis, delayed diagnosis of sepsis. It is wonderful to make early diagnosis of sepsis. Dr. Henrietta Hughes kindly introduced me to the mother of Martha, Milope Mills. I learned a lot from Martha's mother, Milope Mills, on sepsis. I hope AI will be helpful in early diagnosis in the future. So thirdly, I'd like to visit Sue Sheridan to share your experience. So the question I would like to ask you is, can you describe your experience posted on New York Times using a generative AI chatbot for symptom diagnosis? And what were your key takeaways from this experience, your experience? And would you recommend it to others, your friends, your colleagues? And can you share what we need to do to leverage the promise of patient using AI? So Ms. Sue Sheridan is from Patient Safety, Patient for Patient Safety US. She works as a CEO of the organization. So I welcome you to share your thoughts.
Thank you, Shin. Good afternoon. Again, my name is Sue Sheridan, and usually I'm on the stage talking about medical errors and diagnostic errors that happened to my family. My son, who I spoke about this morning, and my late husband, Pat, who died of a failure to communicate a malignant pathology. But today, I'm going to talk about a diagnostic error that happened to me, and this was last July. I'm a seasoned patient advocate, but you can see here, and I first want to share, I feel kind of like an imposter on this stage because I am not an AI expert. I just happened to use AI when I needed it. So as you can see in this picture, titled Misdiagnosis Me and AI. So last July, I was having some intermittent pain in my head, my cheek, my jaw. The side of my tongue was kind of this metallic, numb feeling. And it had happened, and it was really getting worse. This was soon after I had a dental cleaning. I didn't know if it had anything to do with that. But then one day I woke up, and my husband, who is a physician, noticed that the right side of my face was drooping. So he was really alarmed at that. I was alarmed at that. So we went straight to the ED, a large regional hospital, and they immediately ruled out that I did not have a brain tumor. I was not having a stroke. But then the physician shared that since I didn't have any other symptoms except for a drooping face, that I did not have Bell's palsy. Therefore, he didn't prescribe any kind of intervention or medication. But being a seasoned patient, I said, well, wait a second, this is concerning for me. What else could this be? And he said, in the ED, we do not diagnose, we just rule out life-threatening issues. And so, and he shared with me that my best approach to what I was experiencing was to use benign neglect. So he was informing me to ignore my own symptoms. Now, my husband, being a physician, said, now, couldn't this be a reactivation of a virus? This seemed to my husband, who had been an ED doctor, it seemed to him that this could have been a virus and that this was Bell's palsy. And the physician dismissed him as well. And so we were alarmed at this. We kind of ran into a wall. I couldn't penetrate it. My husband couldn't penetrate it. We knew something was going on with my face. So we got back in our car. We drove 3 hours back up the mountain where we live. And my pain was getting worse. I could hardly tolerate it. My facial droop persisted. My husband was concerned that it was getting worse. And so what we did out of desperation was we turned to ChatGPT for the first time. Neither of us had experience in ChatGPT. We had no sophistication. We just got on. We're like two adults playing with a new toy. And like, type this in, type this in. Let's go to the next slide. And you can see that my prompts for this was facial droop, facial pain, and dental work. That's all I put in. And then you can see that Bell's palsy was one of the diagnoses. But what really got our attention was down here. The window to treat this was 72 hours. And if you didn't treat this in 72 hours, the facial paralysis could be permanent. Having seen that, equipped with this information with ChatGPT, we went to a second ED in our little town up in the mountains the next day. We walked in. The doctor immediately looked at me. He said, "You've got Bell's palsy. We have to treat this immediately or that facial paralysis will be permanent." So we went in equipped with the information from ChatGPT. We didn't have to use it because that doctor knew what was going on. He immediately treated it with prednisone and antivirals. In 5 hours, my pain was subsiding. My facial droop continued, and I continued to have what they call grade 2 facial paralysis. But you know, what if I hadn't used that ChatGPT? What if I had listened to that doctor? What if that doctor had used ChatGPT? And so, you know, it was, we were not using ChatGPT to get a final diagnosis. We were using ChatGPT as a second opinion to help us decide what were our next steps and our next actions. So I would say that, you know, my takeaways of using ChatGPT and learning what I did, I would say number one, what ChatGPT does for me and other patients when we choose to use it is it democratizes healthcare information. It gives me, it empowered me, it democracy, it equalizes. And so that was a gift to us to have that information from ChatGPT. Here's another thing I learned. We talk about ChatGPT and that there is maybe some biases baked into the algorithms. But you know, I saw the other side of that. I saw that ChatGPT didn't know I was a woman. ChatGPT, as we know, a lot of women are dismissed as, you know, it's because of stress. And that is what the ED doctor said to me. He said he thought it was because of stress, dismissed. ChatGPT didn't know I was a woman. ChatGPT wouldn't know what color I was, how old I was, if I was overweight. So I think in one way, it helps reduce implicit bias because it can't see us. I also think that my takeaway is for patients, it doesn't require that much sophistication. Because you saw what we put into that our prompts were very, very simple. I also want to say that as we talk about ChatGPT and the perils of using ChatGPT and how it's not perfect yet, I would say let's compare ChatGPT and chatbots to humans, not perfection. With ChatGPT, another of my observations is, what I'm learning more and more is we can test ChatGPT, we can refine it, we can test it, we can refine it, we can test it, we can refine it. We cannot do that with human beings. So let's keep that in mind. And I would say, would I recommend this to other patients? Absolutely. I would recommend it, in the event that, especially when healthcare is failing us, we need to access that for a second opinion. It's kind of like a Martha's rule. We're going for a second opinion, but not in the hospital. I would say ideally it would be best if we could use AI chatbots with our clinician in partnership. And I think that's what we really need to strive for. Now, Shin, did you want me to answer that last question about what do we need the promise of? Okay. So I've got to go to that page. So let's really think about the promise of promoting AI with patients, and what do we need to do that? So first of all, let's think about the promise of patients using AI. So let's help the patients. Now think about this. We talk about the workforce. We are the largest workforce out there. Put us to work. Help us use AI responsibly. Ensure that clinicians are trained to communicate more effectively with us about our use of AI. Let's have that dialogue, clinician and patients, about when they're going to use AI on us and how we can use AI to empower us. Let's change the culture that discourages patients from being, digging for more information, doing our research, to a culture that celebrates and informs patients. And I have to share, when you saw the thing on the Wall Street Journal, and also there was more media that went global when I used ChatGPT, I was heavily criticized for using that. And so I say, let's change that mind frame and let's celebrate it together. We also have to encourage healthcare systems to adopt strategies to meet the evolving patient needs of AI. As we think about the healthcare system of the future, we need to think about the patient of the future and prepare our healthcare systems for that. And finally, I'm going to say we need to build AI systems that align with the patient preferences, the patient concerns. Yes, we want privacy, and we need to be part of developing it to ensure there's appropriate governance, that profits do not overshadow our safety, and that we're there developing it, overseeing it, and governing it. So I'll conclude with that.
Okay, thank you very much. Thank you very much for your experience. I'm really impressed that you emphasize that engaging patient in developing AI, not only medical treatment but also developing AI is quite important in years to come. So thank you very much, Sue, for sharing your thoughts as a patient representative. So fourthly, I will visit Dr. Lola Zwan. Dr. Lola Zwan is an associate professor of Erasmus Medical Center of Netherlands. Netherlands is a part of EU. In my slide, I touched on the EU regulation on AI. So I would like to ask Dr. Lola Zwan, number one, what are the main risks and the benefits for patients who use AI for diagnosis, particularly based on Ms. Sue Sheridan's experience? Number two, are the benefits and risks similar for physicians using AI in their diagnostic process? Number three, how will the AI Artificial Intelligence Act, how will the EU AI Act impact the use of AI in healthcare? And number four, why is it crucial to have regulatory policies for AI and technology in patient safety? So I would like to invite you to share your thoughts.
Thank you so much. Well, what are the main risks and benefits of patients using AI for diagnosis? I think the benefits have been really nicely outlined already by Sue. I think it's key that there's an alternative diagnosis that patients can bring that are based on, ChatGPT in this case, that bring additional knowledge and that is free of implicit bias, as Sue has pointed out. There's no knowledge of gender, there's no knowledge of whether someone is overweight or has mental health issues, and that things often influence the diagnostic process. And in addition, looking at when it goes wrong in the diagnostic process, it's very often because a specific type of presentation of a disease is not recognized. And we often don't get to have a relevant alternative diagnosis, and that's really what a patient can bring using ChatGPT. And the second thing that is a benefit that Sue also already mentioned, that I want to reiterate, it's the increased feeling of confidence. Patients often feel so unsure. Do I need to seek healthcare? Do I need to go see a doctor for this? Or if I feel like my diagnosis is not correct or something else needs to be done. And ChatGPT can empower them. They can feel like, okay, I asked, I have an alternative opinion that I can bring to my doctor and feel empowered. There are also some risks associated with it. So patients can also have overconfidence in the accuracy of an AI tool, for example, ChatGPT, and that could result in some wrong actions, not seeking care if they need to, and also it can create a lot of anxiety because a lot of the AI tools are cautious and more likely to tell that you should see a doctor, so that can really cause some anxiety for patients that otherwise would not have been there. But as Sue already pointed out, no one's perfect, so I think the benefits in this case still outweigh the risks. Another risk that I see is the increased pressure in healthcare. I think a lot of countries are having the trouble that there are not enough healthcare professionals, that there's a lot of care consumption. And so we need to make sure we use those tools in the right place. For example, in the Netherlands, there's this app called Skin Vision, and you can take pictures of skin lesions. Well, if we use them at the point of seeing a GP, when you're worried about a skin lesion, it can be very helpful because it can direct you towards you either need care right away, see a dermatologist, or it can say see a GP, or it can reassure patients in those cases where it's really nothing. But if patients start taking pictures of all the skin lesions that they have, it might cause some overdiagnosis. So we need to really investigate and understand when we should use such tools and how we should use them, and we don't really know that yet. Then getting to the second question of how physicians can benefit. Well, physicians can also benefit of the increased accuracy because of the alternative diagnosis that they may get from ChatGPT. They can search for alternatives, and it depends, of course, a little bit on how they use it. They can try to refute a diagnosis that they have, ask for what next steps that they could do, and see if there's something that they have overlooked. There's also disadvantages of physicians using it. There's also the issue of trust and over-reliance. We already know that people in general are overconfident, and doctors are also overconfident, and they're less likely to change their opinion. And then if you get confirmed in your diagnosis by ChatGPT or another AI, you're even less likely to change your opinion, and that is a risk. We've seen that in one of the studies that we've done on the use of AI, that a lot of junior doctors use it to confirm their diagnosis and to then see their supervisor to tell a coherent story and say, hey, the AI tool agreed. And if that's the case, it can be harmful as well. But I do want to point out for this that a lot of research is needed because it's out there, we're using it, but we don't really know what is the best way to use it, for what situations and when. And I think that's something that we really need more research on. Shin, do you also want me to immediately talk about the AI regulations? Yes, so very briefly on the EU AI Act, I was asked to talk about that a little bit, and that was approved in 2024, and it's the world's first framework to foster trustworthy AI within the European Union. And these regulations will help to enhance transparency and accountability and reduce the risks, and I think that's the main impact that it has on healthcare. It's not only developed for healthcare, it's for all AI systems. And I think it's very important to have that to make sure that the risks of using tools are reduced. What the AI Act looks like is that they indicate different levels of risks that an AI tool can have. And depending on that, there needs to be a rigorous investigation of whether the tool is suitable for practice. This is still recently adopted, so I think that there's quite a lot that still we need to learn from it, but it can be a good example for other areas in the world to see how we can implement such a tool to make sure that there's as little risks as possible with AI tool use, and the regulations will be really crucial in that.
Thank you. Thank you very much. Thank you, Laura. Thank you. In my knowledge, European EU AI Act took a risk-based approach with four different risks. Minimal risk, limited risk, high risk, and unacceptable risk. For instance, medical device corresponds to high risk. So I don't know what other diagnostic devices or AI corresponds to what type of risk, but we will see. And some people say that the strict regulation may slow down the business on AI. However, we need to have a middle-term perspective, long-term perspective. Probably it will be beneficial to those companies to develop AI in a safer manner. So last but not least, I would like to welcome Dr. Iris Isip Tan from the College of Medicine, University of Philippines, UP in short, Manila. And she is a really capable person, so she has many hats. She is a professor, and she is also a chief of the UP Medical Informatics Unit, and she is also a director of the UP Manila Interactive Learning Center. And last but not least, she is a chair of the UP Manila Telehealth Committee. I'd like to ask you a question like, how can healthcare provider better guide patients in using AI safely and effectively? How can healthcare providers ensure that AI tools complement clinical expertise rather than replace it, while also enhancing workflow efficiency in clinical settings? In low to middle income countries like the Philippines, what AI and technology policies could be proposed to enhance healthcare and patient safety? Do you agree with the idea that AI should be available at affordable cost in low and middle income countries? Okay. Let me invite you to share your thoughts.
So good afternoon. So that's 3 questions. So the first question is, how can healthcare providers better guide patients in using AI effectively and safely? So first, for healthcare providers like me, I'm an endocrinologist. To guide patients effectively, we need to be AI literate ourselves. And that might mean different things depending on our roles. For example, as consumers of AI tools, we need to be able to select and use these tools appropriately in healthcare. And if we are to be translators, we need to be able to validate these tools for clinical use. And for those who are in developer roles, we will need expertise to actually integrate AI into our clinical workflows. So we need to distinguish between what I would call consumer-grade and medical-grade AI. In healthcare, consumer-grade tools in AI have not been clinically validated, while medical-grade AI has both clinical validation and regulatory approval. And I think our first responsibility as healthcare providers would be to help patients understand that there is this difference. So survey data that I have seen shows mixed patient interest in healthcare AI, from very excited to some of them being very scared. And many patients may not disclose their AI use to us as their healthcare team. But when they do, I would suggest for us to help them develop their own AI literacy. And this means addressing privacy concerns, letting them know how their data might be used to train these algorithms, discussing consent issues, and reviewing the terms of use of these AI tools. I would also like to tell healthcare providers to encourage patients to give us feedback about their AI experiences, because then we can help them recognize red flags in AI recommendations when they do occur. Because we worry that there might be harmful actions based on AI recommendations or delay in necessary care due to false reassurance. But we really need policies that support patient autonomy and shared decision-making. And I read that this is to avoid a new form of paternalism where the doctor knows best, but the computer knows more and actually makes fewer mistakes. So the next question is, how can healthcare providers ensure that AI tools complement clinical expertise rather than replacing it while enhancing workflow efficiency in clinical settings? When we ask this question, what we are really asking is, how can we ensure that AI enhances rather than replaces human judgment? I prefer that AI be spelled out as augmented intelligence rather than artificial intelligence. And the World Health Organization has already applied the design for value principle for AI in healthcare, and it calls for human oversight colleges where all stakeholders are engaged in the design, the development, the evaluation, and the deployment of AI in healthcare. And they mean everyone, not just computer scientists, but also the physicians, the patients, the public, and the vulnerable populations who will be affected by these systems. We need to fully support human-in-the-loop AI. So for me as a clinician, AI should augment, not automate my clinical decision-making. We need to develop critical appraisal skills where AI is a black box, so I need to know whether I can trust the AI's recommendations. We need to say that human oversight and responsibility prevails, especially for high-stakes decisions. And this is my request. The technology should adapt to clinical workflows and not vice versa. And we need to ensure that the AI tools address real clinical needs and not create technological solutions in search of problems. Now, the second part of the question mentions efficiency. And while efficiency gains may result from AI adoption, this is not the primary goal. And I would like to echo what Alondra Nelson said at the AI Action Summit in Paris. The purpose of AI is not scale or efficiency. The purpose of AI is people. The last question is on policy, and I have 3 suggestions. First, to encourage frugal AI approaches because the Philippines is a low to middle income country. This refers to AI applications that are cost-effective, resource-efficient, and appropriate for context with our limited resources. So we would like to incentivize the development of lightweight AI models that may run on less powerful hardware with lower bandwidth requirements to keep deployment and maintenance affordable. We also need to support local AI innovation ecosystems so that they can create solutions that are tailored for our own healthcare challenges, our own infrastructure limitations, and cultural context. Because AI models developed and tested primarily in high-income countries may not work reliably or even equitably in low-resource settings. As it is, health data from LMICs are underrepresented in AI training datasets. So we need to locally, clinically validate this in order to identify and mitigate bias, to avoid perpetuating or even exacerbating health inequity. And so when that validation occurs, we need to look at the AI's intended purpose, considering our local disease prevalence, our available infrastructure, and the digital literacy of both patients and healthcare providers. The second one is to have regulatory sandboxes for testing. So policies should encourage transparent and explainable AI because that will foster trust among both healthcare providers and patients. We want to prevent overregulation while maintaining necessary safeguards for patient safety. My last proposal has to do with protecting health workers and patients' rights when using AI in healthcare. So for health workers' protections, there should be clear guidelines for appropriate use cases and limitations of AI tools in clinical settings so that clinicians following established protocols may be safe from liability. And perhaps we should talk about a shared responsibility model that distributes liability between AI developers, healthcare institutions, and individual health workers. Certainly, we need appropriate accountability mechanisms to keep our patients safe. For patients, there must be strong data governance frameworks to protect patient privacy while enabling beneficial use of health data. Meaning we need informed consent processes appropriate for varied literacy levels and have mechanisms for redress when there are AI systems that cause harm. Lastly, LMICs need to think about data sovereignty. Local health data used for AI development should benefit local populations first. And I will quote Dr. Leo Selly. He said, "Let us move from AI bias, BIAS, to AI by us." Thank you.
Thank you very much. Thank you very much, for Professor Iris Isipton. I learned a lot from you, and it's quite important to to consider AI application altogether, regardless economic size. So last, I'd like to invite Professor Albert Wu again to share his additional thought. Okay.
Thank you so much. Next slide, please. Ooh. Yes. Could you, let's see. There's a slide that is titled Multi-Level Quality Assurance. Thank you so much. So I love the expression medical grade AI, because just because something is available on your laptop or on your phone doesn't mean you should be using it to make life or death decisions about yourself. And so I think what we need to be thinking about is quality assurance, maybe quality measurement, and then quality assurance at multiple levels of the healthcare system. There's a big role for policy and for regulation, and that includes at phases of development and testing, and then use, and then evaluation after use. We certainly need to approve AI or AI tools to make sure that they have involved diverse training sets, as we just heard. There should be, for tools that are going to be used very widely, there should be post-marketing surveillance, just the way there is sometimes post-marketing surveillance for a drug which hasn't been tested adequately. I think it would be very important to have labeling, just like there are drug labels for AI-enabled devices. And I put just an example of here that was suggested in a paper a couple of years ago, in the same way that a drug has information about what its name is, who developed it, when it was developed, what it's supposed to do, warnings about what may go wrong. All of those things should be provided for every widely used AI device. There should be requirements that adverse events that are caused by AI should be reported. And also, after something's been around for a while, it is very possible that that device may go out of date. And there should be a policy and a protocol for retiring AI that has served its purpose. At the health system level, I also like the suggestion of making sure that there are humans in the loop. When a decision is made, if at all possible, there should be a mechanism for the provider to look at the results and say, I think we should do this, or to say, wait a second, this data is provided for the wrong person, or this doesn't make any sense, let's discuss. There should be regular performance tests, and sometimes, especially for local use, a device or a tool might need to be retrained so that it actually works. And then finally, perhaps at the practice level, the most important thing I might have to say is there should be training for clinicians on how to use AI intelligently, for patients so that they can participate as members of the healthcare team, and ideally it should be training of patients and providers together so that they can figure it out. I think this AI is going to be here to stay, just the way computers are now present at most encounters, especially in higher and middle income countries. And this is something that we should learn about together. Next slide, please. Do we have one more slide? Maybe patients and physicians together would be a good last word. Oh, do we have a slide that says implementation challenges? Oh, well, okay, I'll take this slide. So in summary, artificial intelligence can be integrated into the clinical workflow. I would challenge the assertion that AI should not be designed to improve efficiency. If it can, doctors and nurses and others are already spending too much time. I think if we can make care more efficient, that would be great. That last slide was so terrific. Can you bring it back? I'll take this slide. There are some challenges to implementation, and I think that these things are already happening. The first is that physicians and patients may not be adequately trained on how to use these things. This is something that's coming in new. If you think about when computers came into healthcare a decade or two ago, we needed a lot of tech support. When electronic health records became common, again, tech support is really important. And we should have people who are smart at this, who can serve as champions, and can help everyone else come along. Resistance to change always happens. We do this normally as human beings. To help reduce that resistance, we need to show people that this works and maybe that it can actually save time sometimes. We need humans in the loop. We need protocols. What to do if the doctor and the AI, or maybe the patient and the AI disagree? What do we do about that? And we need clear reporting mechanisms. And finally, if this doesn't work, AI has a tendency sometimes to make things up. We call these hallucinations, but you might all call them errors. And when AIs produce errors more than good information, we need to keep track of it, check up on performance, and then fix things when necessary.
Thank you.
Thank you.
Thank you very much, Dr. Alberto. Thank you very much. Thank you very much. So instead of taking a question from the floor, I would like to wrap up this session. We discussed number one, first on the recognition. AI has already arrived in healthcare. That's the recognition I would like to share. Number two, not only medical professionals but also patients has gained access to AI. So the accuracy, reliability, the removal of hallucination issue is quite important. Number three, on the side of medical professionals, AI helps in such a way that it helps clinical work, not only clinical work, but also reducing administrative work. It will be very, very helpful. And number four, we focused on the analysis of incident report. That will be helpful to promote patient safety in years to come. Number five, the regulation on AI. There are various types of regulations across the world. We need to update. We need to follow up the degree of regulation and what is outcome from the regulation year by year. And number six, we need to consider AI application together regardless of the economic size. So I think those points will be succeeded to the next summit in 2026. So thank you very much. Thank you all, and let me join in thanking the esteemed panelists with big applause. Thank you very much. Thank you. Okay, session is adjourned. Thank you very much.
Thank you again to our panelists during the Experts Plenary 3, and thank you, Dr. Shin Ushiro, for chairing that discussion. And now, we move on to a crucial segment of our program where we will consolidate the key takeaways from our insightful panel discussions. The session will provide a comprehensive overview of the main themes, findings, and recommendations that emerge from our expert panels. And we are honored to have a distinguished group of speakers who will share their perspectives and insights from their respective tracks. First up, please join me in welcoming Undersecretary Paulo S. Teston, Department of Health, Philippines. Let's give him a big round of applause. So for this plenary session, we'll have 6 speakers to share their key takeaways based on their respective tracks. What are their insights, the key takeaways from the panel discussions that we had all throughout the day 1 of this Global Ministerial Summit. All right. So we'll have Yusek Teston later, and we'll have first to share the key takeaways from the panel discussion. Please welcome Dr. Arina Papieva, World Health Organization Headquarters, Switzerland. A big round of applause, please.
Thank you very much. I will be sharing the core messages from the session that focused on addressing diagnostic safety in healthcare settings. And before I start, I want to thank my co-chairs, Dr. Aisang, and also our distinguished panelists, Dr. Kurihara from Japan, Karen, Hardeep, and David. So the core messages from our session are as follows. Most of us will experience at least one diagnostic error in our lifetime, and in many cases the consequences are minor, but sometimes they may result in severe harm. Incidents related to diagnosis account for 16% of preventable patient harm globally. The direct financial impact of misdiagnosis, underdiagnosis, and overdiagnosis is estimated to account for 17.5% of total health expenditure, that is equivalent to 1.8% of GDP in an average OECD country, and approximately to US $870 billion in health expenditure each year in the United States alone. Errors in acute care settings, such as emergency rooms or intensive care units, are the most costly. And contributing factors to diagnostic errors range from system vulnerabilities, such as, for example, access to care and tests, fragmented care, and insufficient workforce numbers, to cognitive challenges in clinical decision-making, as well as health literacy gaps and communication failures. Patient and family engagement is important to improve diagnostic safety, and there is a special role for patient organizations to play in improving diagnostic safety. Engaging patients in research, not as subjects, but rather as partners, was also highlighted during our discussion. Workforce competency development was discussed at large with emphasis on making systematic assessments of missed opportunities and clinicians learning from their practice and patients. The development of soft skills for better teamwork and communication and creating a safety culture to ensure incidents are reported, analyzed, and used for learning and continuous improvement was mentioned. The importance of multi-professional approach to education was also highlighted. Addressing diagnostic safety requires a multifaceted, comprehensive approach at all levels, spanning across several domains, including patient engagement, workforce development, systems and processes, as well as diagnostics and technology. Establishing learning systems and fostering research are the prerequisites for effective and sustainable improvements. It is important also to contextualize and prioritize interventions based on the country-specific context and clinical settings. Strong leadership is essential to reducing diagnostic errors and achieving significant cost savings. There is also a need to have a global response to this challenge to address diagnostic safety, and for example, choosing the theme of the World Patient Safety Day 2024, improving diagnosis for patient safety, is one of these kind of responses. So that's all from our group. Thank you very much for your attention.
Thank you very much, Dr. Papieva. Now we move on to Mr. Howard Cotton, International Council of Nurses, Switzerland. Let's give him a big round of applause.
Hi, everyone. We've got a slide which just summarizes three simple takeaways from our session on creating psychological safety and healthy workplaces. First, and a very simple point, but important to reiterate, staff safety and well-being and patient safety are two sides of the same coin. That's not a line, that's proven by an extensive body of evidence and research, which isn't just from the health professions, but is from a range of academic institutions, is referenced heavily and increasingly in the WHO documents. However, we think that the alarm bells are ringing in terms of the health and well-being of the health workforce globally. Rates of assaults, attacks, violence, bullying, harassment, we're seeing all of them go up in a worrying trend. But in response, you'll all remember that in 2020, on Patient Safety Day, we published the Healthcare Worker Safety Charter. It went out under the strapline of two sides of the same coin, and that charter contained very many of the practical policies that we were recommending in 2020 countries should adopt. How many countries do you think have actually adopted that charter? The last data, the last baseline that we have, I got this from Neelam, was that only 20% of countries, it's actually 18 countries out of the 108 who responded. So a major issue in terms of the follow-up and the adoption of that charter. From our discussions, leadership emerged as a really key issue, not just at C-suite, right through to healthcare workers at the front line. But what also emerged from the evidence is that there's a gap between the perception of senior leaders about the safety of their organisation and those working at the front line. Perhaps unsurprisingly, the senior leaders of organisations have much more optimistic views about the safety of their organisations compared to the front line. We had evidence from Dr. Anthony Staines from Switzerland. There's OECD evidence which also highlights that same issue. We need openness and transparency. We need more honest conversations. We need a non-judgmental approach to how we're talking about these issues with staff. We need to be aware that if we say, as I hear a lot, that people want to do a root cause investigation to understand what the real causes of a safety incident is, what staff might hear is that this is a mechanism, a means to put the blame on somebody. So we need to, I was reminded, this part of the discussion that we had, I was reminded of the infamous line from The Few Good Men when Jack Nicholson says, "You can't handle the truth." And we as leaders of patient safety need to make sure we can handle the truth about what staff will say to us about their experiences. We had some fantastic examples from all of the speakers who were all wonderful. I commend them all to you, of practical initiatives to promote and develop safety and well-being among staff. Some of them really practical stuff. Is there a decent canteen? What about creche facilities? What do the staff rooms look like? What about carers leave in your organisation? But there was also a warning. People often say, what's the one silver bullet thing that we can do which will suddenly improve staff safety and well-being? The evidence tells us there isn't a single bullet. You need to put together a package of those very practical measures. But if we are looking for 2 or 3 things that we could do right now and which feel priorities, we need to address the woeful lack of legal protection for whistleblowers. 1. 2, I ask the audience in our session, put your hand up if your organisation's disciplinary policy explicitly says if you commit an error but report that openly and honestly, you will be not subject to disciplinary action. Nobody in the room, I don't know about this room, but nobody in our room in the side session was able to put their hand up and said that there was that explicit commitment within disciplinary policies in their organisations or organisations that they were aware of. Clearly, sign up to the the Healthcare Workers Safety Charter that we produced in 2020 is something that's very practical that people could do as well. Why is all of this an issue? Back to the 2 sides of the same coin, but it's even more of an issue because WHO's latest estimate of healthcare worker shortage globally has not gone down. It was at 10 million, and they've re-estimated that and now put it at 11 million. So we've not only seemed to have stagnated, there's worrying signs that global healthcare worker shortage is going up. And as we all know, no healthcare workers, no health care. Thank you very much.
Thank you very much, Mr. Howard Catton. Next, to share the key takeaways from our panel discussions, please welcome Dr. Hardip Singh, Michael E. DeBakey Veterans Affairs Medical Center, USA.
Thank you. Our session was about sort of bringing the 2 fields of patient safety on one end, which is sort of like my day job, and climate action, environmental sustainability, climate change related activities, which is sort of like I consider my nighttime job, together. And we had a lot of fun. I thought of this as more of like an arranged marriage between the 2 fields and why they need to work together. And I think it worked, the message sort of worked with the audience. One of the reasons we talked about why these 2 fields need to come together is as patient safety professionals, we really know how to reduce risk and harm. And we need to just think about going from reducing harm to patients to going to reduce harm to public and the planet at the same time. We have the skills to do that. From climate change, there's risk and harm to health, as well as risk and harm to health care, because as you know, systems just shut down when this, climate events happen, and they're increasingly doing so. The second thing we talked about was the healthcare impact itself on climate change. So, the fact is that aviation emissions, which you can think is a huge contributor to climate change, is just half of that of healthcare. So healthcare emissions are 4.5% global emissions, and aviation is half. So we have a huge carbon footprint. A lot of that comes from what we do in healthcare, the devices, the medications, our supply chains, the procedures we do, the surgeries that we do. So a lot of it is related to healthcare delivery. And think about it this way, there's a lot of low-value care. So the numbers, about 30% of what we do in healthcare is low-value care. And it's important to sort of frame this as a quality conversation. So the third discussion was about how do we frame this as a quality conversation. So we can either make sustainability and climate action as a seventh dimension of quality. There's 6 dimensions by the Institute of Medicine, or also we can then position it to be a part of other 6 dimensions: safety, timeliness of care. Imagine, we can't give care if once we have some of these events. And then efficiency. So we have a lot of waste in healthcare. We use a lot of devices that are, basically just sort of thrown away, not even reused. So there's a lot of things that we discuss that can be considered high-value care. I'm just sort of thinking of some of the other topics that came up in terms of actions. We discussed, there's a lot of actions that we can do in terms of sort of microsystem, clinicians, patients, healthcare professionals can do, and also what healthcare organizations can do, as well as globally what people can do. And sort of the questions came up, how do we get people mobilized in terms of policy and payment systems to get some of this action done by whether it's a healthcare organization or clinicians. And then we thought of some levers to enable those actions. The first thing we also discussed was there's a lot of silos in healthcare. I've talked to a lot of people who work in environmental science, environmental health fields. They feel that there's, the conversations they can't have with the clinical people or the healthcare people. It's 2 silos that we need to sort of break down. But the more important thing is we heard a lot from our patient representatives, and there was a lot of good discussion on what patients can do in terms of climate action and mobilizing people. And one of the things we discussed, which came out to be a pretty big message from our session, was the healthcare activities related to climate change, climate action, healthcare sustainability, maybe those should be a part of patient experience. We right now have organizational activities related to quality and safety as a part of patient experience. Everybody pays attention to that. In fact, organizations want 5-star ratings based on their patient experience. So we considered, and everybody agreed, that actions related to climate and environmental sustainability should, in fact, be a part of patient experience. And there are lots of other resources that we shared with the people that would be useful. Thank you so much. Appreciate it.
Thank you very much, Dr. Singh. Next, we have Dr. Jennifer T. Pagio, University of the Philippines.
Good afternoon. In panel discussion 2.2 on investing in patient safety for sustainable healthcare, I posed the question, what do we invest on and how do we best invest in patient safety towards sustainable healthcare? We received examples and the wins from our distinguished panelists from New Zealand, Singapore, India, and Japan. And I just wanted to summarize their inputs into 5. Indeed, investing in patient safety while ensuring sustainable healthcare requires strategic balance. In improving quality care, optimizing resources, and reducing healthcare impact, patient safety supports sustainable healthcare by investing in the environment, evidence, partners and patients, structures, and education and leadership. We invest in the environment by going green and using environmentally sustainable options and eco-friendly practices. We maximize best evidence, stop low-value care, and use low-cost, even high-impact technologies. Engage, collaborate, and partner. Partner with patients, partner with other healthcare providers, healthcare consumers, to not waste ideas and optimize their expertise. Fourth, invest in structures, strengthen human resource and healthcare structures, supply chains, policies, and availability of adequate number of competent mix of workforce. And lastly, education and leadership. Let's invest in education and training of our healthcare teams that is guided by the competencies for patient safety to translate to have practitioners, to champions, and to leaders for patient safety. I just want to end with this quote by Donald Berwick that says, everyone in healthcare has two jobs when they come to work: to do the work that we do, and to improve it. So we can do patient safety better, and that's why we're all here. Thank you very much.
Thank you very much, Dr. Jennifer Paggio. Next, we have Ms. Susan Sheridan, Patients for Patient Safety USA.
Hello again. So it's my honor to give you a little, the key takeaways from the session that was dedicated to closing the patient safety gaps and issues by integrating patients and families as problem solvers. So this afternoon we had a panel that representation from Senegal, Thailand, Germany, and the Philippines, where they all talked about how they are engaging patients and families in patient safety solutions. And there was a wide variety of examples from those just beginning their journey in engaging patients and families to the other end of the extreme, where there were systems where this is very well baked in. So my takeaway, I think we have a slide, but for your organizations, this is a call to action to your organizations. This is actually strategic objective number 4 of the Global Patient Safety Action Plan, to engage patients and families in everything that we do. So it's the how that's one of the hardest things to do. So how do you as organizations start this journey? Well, first of all, you can undertake a landscape assessment. There's wonderful tools online that you can really kind of make a self-assessment and see where are you on this journey. Secure, strong commitment by leadership. And when I say, I mean leadership, leadership, leadership. Engaging patients and families is all about leadership, the will, the courage, the passion. Leslie Thompson and I were brainstorming about we need a leadership boot camp because it's hard work. It takes courage, it takes valuing patient and family input. And so leadership is just, we absolutely have to have that leadership buy-in. We need to commit dedicated resources and personnel to really focus on making sure patient and family engagement is not just tokenistic. We've heard that word here by other patients and families. So let's make this real. Let's bake in patients and families into your organizations. Let's create mechanisms to hear from patients. So often, patients have so much to share with our leaders and our governments and our healthcare system, and there's no pathway for us to hear each other. So let's develop those mechanisms to hear from patients, the PREMs, the PROMs, and call for storytelling, have storytelling at your board meetings, develop policies and principles in your organizations to embed patient engagement in what you do. If you don't have policies and principles and leadership on board, this will be an idea that won't go anywhere. Develop partnerships between governments, with healthcare facilities. Reach out to your patient and civil society organizations. They are valuable resources. So many times, governments and healthcare systems come to me and say, we want to engage patients, but where do we find them? You are surrounded by them. Reach out to civil society, reach out to disease groups, reach out to patients, human rights groups. They are there and they want to help you. And when you're really reaching out and making those connections with the patients and the civil society organizations, invest in them, give them training, provide capacity building, help them learn how to tell their story. Now, WHO will be launching a storytelling toolkit in the near future that will be for you on how you can reach out and how you can best work with patients to best tell their story to instigate change in patient safety. Co-produce, we heard this all throughout the day. Co-production is designing, planning, implementing, and evaluating with the patient community. Not, as Charlotte said today, not at the end, don't bring us a product that's done and say, patients, we want you to agree to this. Bake us in at the beginning of the planning and ensure that the values, the preferences, and the outcomes that matter to patients are fundamental in everything that you're planning. So that co-development, create task force, create committees, create working groups, have listening sessions, get that voice infused in what you're doing. And then finally, monitor and evaluate your patient, the effectiveness of your patient-family engagement. And finally, once you've evaluated and you've established, mechanisms to engage it, let's share it globally so we can all learn together. So those were the key takeaways. I can't encourage you enough. Leadership, partnership, co-development, and monitoring. Thank you.
Thank you very much, Susan Sheridan. Last but definitely not the least, we have Undersecretary Paulo S. Teston, Department of Health, Philippines.
Thank you so much. Last but certainly not the least. Anyway, I'll discuss the key takeaways for panel discussion 1.3, which deals with innovative strategies for strengthening resilient health systems to ensure patient safety amid climate and disaster-related disruptions. Yes, I know it's kilometric, so at the beginning of the discussion, we had to dissect it one by one with the panelists. But we are all in agreement that building a climate-resilient healthcare system is essential to ensure continuity of care and patient safety during climate-related disruptions and pandemics. In the course of the discussions, one of the panelists, Professor Braithwaite, disclosed that the good news is that over 60% of the world's population now believes in climate change, and global frameworks such as the Global Patient Safety Action Plan are in place to support the country's efforts. We all agreed also that to effectively address the challenges faced by healthcare systems in disaster-prone and low-income regions such as the Philippines, a comprehensive approach is necessary. This entails the implementation of both short-term solutions and long-term strategies. A key aspect of this approach, according to Ms. Jean Courtney, involves innovative facility planning that considers the appropriate architectural design, engineering, and strategic location selection. Additionally, ADB's Mr. Richard F. Ving suggests having a comprehensive long-term master plan, which is essential for establishing robust financial, technical, and governance frameworks. These frameworks would be crucial for ensuring the effectiveness and the short, medium, and long-term sustainability of resilience initiatives. More importantly, it is imperative that countries invest in climate-resilient infrastructure with functional and sustainable designs, renewable energy sources, lower carbon footprint, and efficient water and healthcare waste management. According to Professor Nick Watts, who's also a panelist, there are limitations to adaptation which are mostly financial in nature. To mitigate such limitations, financial institutions can support climate-resilient investments by offering specialized financing programs, products, and innovations. Furthermore, accreditation bodies should integrate climate-smart practices and risk mitigation into healthcare standards. It should also be accompanied by enforcement and monitoring of compliance with these standards. Finally, global collaboration and knowledge sharing are essential for implementing adaptive healthcare solutions. In the words of Professor Braithwaite, achieving resilience, adaptability, and risk mitigation is not about the individual. It is about the interactions of the collective. All in all, by developing sound policy frameworks, implementing proactive and synergic mitigation strategies, and fostering strong partnerships, healthcare systems can enhance their resilience and adaptability, ultimately safeguarding patient care in the face of escalating climate and disaster-related disruptions. That's it for panel 1.3. Thank you so much.
Thank you very much, Undersecretary Paulo Teston of the Department of Health, Philippines. And with those key takeaways from our speakers, we conclude our plenary session. Now, once again, a big round of applause to all the speakers during that plenary session who shared their key takeaways from the panel discussion we had all throughout this day one. And we hope that these insights will inspire and guide the collective efforts in advancing patient safety globally. And we extend, of course, our sincerest gratitude to all our speakers, to all the panelists, and to all our delegates. Thank you very much for your active participation and engagement throughout the day. Please give all yourselves a big round of applause. Truly, your commitment to patient safety is commendable. Now, before we end the day one of our summit, we'd just like to remind you of the ministerial dinner for invited guests. And this will be held at ADB Dining Hall right after this program. So for the invited guests, you may proceed right away to the ADB Dining Hall for the ministerial dinner. And it will be a wonderful opportunity to continue the conversations in a more relaxed setting and also celebrate the collaborative spirit of the summit. Once again, thank you very much. I am Diane Carrera. Have a pleasant evening to all of you. May we just request our speakers from the last panel discussion during the key takeaways from the panel discussions, and all the speakers from the past panel discussions for day one, please. All the panelists, please, from the panel discussions for the day one, can we ask every one of you to kindly proceed on stage for a photo opportunity? Again, requesting all our panelists to kindly proceed on stage for a group photo of all the panelists for our discussions for day one. Thank you.